चलो ठीक है, you are unmuted and live streaming. The video is off. You need to on your video. Yeah. Good morning, Dr. Neeraj.
Sorry. Good morning.
Good morning. Pleasure to see you today.
Yes, thank you.
We are a growing organization. This is the second conference that we are co-hosting along with the Egyptian World Neurosurgical Community.
Okay.
Good morning, Dr. Anand Kavi.
Good morning.
We are what you call it, the micro-specialized stream of spine surgery, that is endoscopic spine surgery, and it's a growing stream. Eventually, all spine surgeons all over the world have to come on board. It is a new technique and people have to learn it if they want to progress. Progress is inevitable, can't be stopped, despite all its hiccups.
Yes.
Neeraj, Malcolm, I'll just see if I am able to share my presentation in a minute.
Please, you're welcome to try whatever you wish to. Always welcome.
I think you can see this.
Yes, beautifully.
Great, wonderful.
Yeah, you're first and I'm second because Hayati is getting shifted today. Hayati,
Oh, is that so?
yeah, Hayati requested me to shift to my time and I'm jumping to his time. This happened late last night, so I could not even put out a flyer for it.
Okay.
But I guess those who want to listen to me, we can listen to me through the recording if they're not on right now. And same thing for Hayati. Yeah, please. Promote to panelist. And now promote to co-host, please. Anand, are you a co-host? Make Anand the co-host, please. Great. So Anand, you are now a co-host. Dr. Samay is a co-host. Good morning, Dr. Samay. Welcome, sir.
Good morning,
Good
Dr.
morning,
Sabi.
Good morning, Dr. Anand.
Yes, had a good night's sleep. Yesterday we did a record number of speakers, and I think everything went right on time. And the only thing we missed out on was Dr. Tunch. Yeah. And Dr. Dennis Yuzakawa, I think we missed out on him also. And I don't know if they are ready today. We'll try and accommodate them somehow, extend the conference a little later. Let's see how it goes. Dr. Yuzakawa Dennis is suffering from COVID. That's what I've been informed.
Okay.
He's our panelist. I think he's listening to us. I really wish we could have him speaking to us.
We wish him speedy recovery.
Yes, we must. And we'll be contacting Dr. Tunch.
How is the climate in Egypt, Dr. Samay?
It's okay. We are waiting for you again.
And
Has the winter started or still time?
of today. So 7:40 last talk. Can you give
It's going decreasing.
Okay.
We can try and
Going
accommodate.
to be all right soon, inshallah.
40 Indian time. Yeah.
Yeah, sure.
No, he's not in Turkey. He's in Belarus or something. You just send him the India time. No? We are 2 minutes away from starting, so coffee.
Coffee always.
I miss Egyptian coffee. I really miss the Egyptian coffee. You guys, kings of coffee. I don't know what you'll add in it, spices. Whoa.
Okay.
You're the king.
I will send you one now.
Anyway, I guess we are We are right on time and all set to go. Just waiting for the clock to start ticking. Where is the sheet, please? Dr. Samay, I will start at sharp 11 o'clock. And what's the time now?
59. 11.
I will just speak for a minute. And then I request you to summarize yesterday's day. And then please flag today's day open so that we can start the Congress today. So,
Okay, Sheikh.
so just waiting for that sharp 11 a.m. Yeah, it's 11 a.m. Good morning, dear viewers. And good morning to all of you, my dear panelists. We are starting the second day of our World Congress. I can only say a big thank you to Dr. Samay. He has been like a pillar of strength, pushing me and guiding me, and Dr. Anand Kavi to organize this conference. This is our second year continuous conference. That is a virtual conference. Prior to that, we had 3 World Congresses that were real congresses at MGM University. And now we are going ahead with the second virtual Congress. And hopefully next year, if COVID permits, we'll again be back with a actual World Congress, a physical World Congress. So Dr. Samay El Morsi Hassan is the chairman of our conference. And sir, I hand over the mic to you. Please speak, sir.
Thank you, dear friend Malcolm. Thank you also, dear friend Anand. It was a great pleasure for me yesterday, and it was amazing. 1,000 and more than 100 registrations, and 4 YouTubes and Facebook channels, and also TV have been live. We can't say how many who have watched us, but it's thousands. It's amazing. We can't even count it.
Yes.
But I hope you enjoy the second day as we have enjoyed the first one, and increasing all our knowledge. And wish to see you again next year in life, inshallah. Thank you.
Thank you so much, sir. I now take the pleasure and privilege to invite the current chairman of Endoscopic Spine Foundation India, Dr. Anand Kavi, to please address this conference and to start his presentation. Anand,
Yeah.
the screen is yours. Please share.
So at the outset, I would like to thank my dear friend Malcolm and Dr. Samay for putting up this amazing show second time. And I'm sure this will grow every year. So I will be speaking on least impact spinal surgery during COVID-19 pandemic. Now, as we all know that COVID-19 pandemic had catastrophic effects, especially during the second wave. And my city, Pune, was a hotspot in India with most number of active cases and hospital admissions. And we had a very high mortality during that time. And there was shortage of all the resources. Impact on surgical practice was very widespread. We had to redeploy the workforce to cater to only COVID patients. All beds were converted to COVID beds in practically all hospitals. There was immense shortage of staff, scarcity of oxygen, ventilators, blood, canisters, medicines, cylinders, everything. And again, the prolonged treatment protocols of viral pneumonia meant that there was prolonged occupation of ICU and general beds, which again added to the shortage of already less number of beds. So as a surgeon, it was our duty to do triage and prioritize the patients with urgent and emergency procedure. And this needed a designated area for pre-admission COVID testing and assigning COVID and non-COVID facility accordingly. All the elective procedures were postponed and rescheduled, and non-urgent admissions were discouraged and managed conservatively as outpatients. Now, I would like to bring to your notice this very important original study by Sota Omugui, which states that origin of all pain is inflammation and inflammatory response. And sciatic pain is no different. It is inflammation around the spinal nerve. And as we all know that during and post SARS-CoV-2 infection, there was hyper-expression of inflammatory cytokines and patients landed up with cytokine storm. And these hyperinflammatory flares further precipitated the attacks of sciatic pain. And we saw a lot many patients with back pain and sciatic pain during that time. Adding fuel to flame, the exposure of nerve root to nucleus pulposus altered the sodium channel expression and its neural activity. And this further altered the axonal morphology and nerve root sensitivity, precipitating attacks of sciatic pain and further precipitated discogenic quada equina in some patients and requiring urgent surgery even during the COVID times. Now, as we all know that aerosol generating procedures like endotracheal intubation and oscillatory ventilation, which is required during the general anesthesia, had a very high risk of viral transmission, and this was a definite risk to the surgical team. Also, it had risk of precipitating the viral pneumonia with already COVID suffering patients, increasing the post-op need for intensive and high dependency unit monitoring of these patients. So in this scenario, transforaminal endoscopy under local anesthesia was a perfect solution. It offered a safe and very quick decompression with no post-op monitoring required in most of these patients. And patients could be discharged into isolation nursing immediately after surgery. So I will be presenting 3 case videos operated during COVID second wave. Now, for a healthy and functional surgical team, it needs adequate protection, and this needed special training in use of personal protection equipment, including myself and my team. We demarcated separate donning and doffing areas, and we followed all the protocols very strictly in that second wave. All the patients were assigned special private room with closed doors as compulsory single occupancy, and they were always masked with no exhalation valves. We had separate isolation areas for preoperative and postoperative care. All the patients with preoperatively screened with chest CT scans, RT-PCR test, blood test with markers, and a strict anesthetic evaluation by anesthesia specialist, COVID specialist, and pulmonologist was done. Now, operation theaters, usually we have positive pressure operation theaters with laminar airflow, but we cannot use them during the COVID times because it traps the harmful particles and they get disseminated into the external environment. So we had to use different operation theaters with low pressure or open pressure air pressure. Then we followed a strict disinfection and sterilization protocols during that time. And we had to use a separate transfer routes to and from the operation theater to isolation rooms. Now, surgical team had to be kept to a very minimum with only a surgeon, anesthetist, and one technician to operate the C-arm and other equipment. And a reserve staff was kept at the door for provisions. There was no scrub assistant during all these cases, so it was only 3-man show. After administrating the preoperative medication and prophylactic antibiotics and taking special separate consents for COVID and COVID treatment, these procedures were done as an awake procedure under local anesthesia, but my anesthetist also used a little bit of dexmedetomidine to comfort the patient, allay his anxiety, and relieve some pain. Draping was kept to minimum with only one last waterproof disposable drape, and no irrigation pump was used for all these endoscopic surgeries. Draining fluid was collected in a disposable container to avoid soiling of the surrounding environment. First case, this is a 36-year-old female with L5-S1 herniation on conservative treatment, but she had a COVID infection and then she developed a severe sciatic pain and back pain. And later on, she developed bladder disturbances and she started getting urination on slightest movement. So this is a small video showing the axial scan with a big extruded herniation in the left lateral recess and centrally and compressing the left S1 root. So the surgery was planned beforehand on a bone model, and the area demarcated in the red is the undersurface of the facet. So we decided to drill it endoscopically using an endoscopic burr under vision. So the endoscope was placed on the lateral aspect of the disc in the Cambin's triangle. And after drilling the undersurface of the facet, we could access the lateral recess and grab the extruded fragment out. With this mental imagery, we went ahead with this endoscopy. And now what you can see is an S1 facet, undersurface of S1 facet. And this is a slow speed endoscopy burr with which we did undercutting of that facet to gain access to the lateral recess. And as soon as we advanced inside through the window, we could see the extruded fragment in front of us. Hello, Mr. Van Johnson, could you please mute yourself? Thank you so much. And then we could grab this fragment out as a single piece. And it was a very big, bulky fragment, almost 6 centimeters in length. Then a 4.1 megahertz radio frequency bipolar probe was used to achieve hemostasis. And after that, we could very clearly visualize the decompressed thecal sac as well as the S1 root. So here you can see the S1 root as well as the dural sac, which is completely decompressed. As well as we can very well see transmitted pulsations into the L5 exiting root. So the surgical time required in this case was around 38 minutes, and by 40 to 45 minutes, the patient was out of operation theater. We could discharge her the same day to home isolation. Next case, another 40-year-old female. She was immediate post-COVID and she developed a down-migrated L4, L5 herniation and with left leg pain and weakness. So this was a high down-migrated extruded fragment into L4, L5, again in the left lateral recess. So for these cases, we need to do a bone window in the superolateral aspect of the pedicle and base of the superior articular process. So this is how we placed the endoscope in Siam, and then the pedicle base was identified. And then a window was created in the bone. So after clearing the soft tissue from the bone and achieving hemostasis, again a slow speed endoscopy burr was used. Why slow speed? Because it creates a low bone dust, and again there is less aerosolization in these procedures. So after doing the window, we used a blunt hook probe to tease the fragment, extruded down migrated fragment out from the central canal. And then we could access the fragment and grab it with its base. And with a slow tugging movement, we could get the entire down migrated fragment out. As a surgeon, it is a very satisfying moment to get the entire herniation out in one go. So this is the free dura and the nerve seen through the bone window which we created. The amount of bone drilled is less than 3 millimeters and it does not create any additional instability. Here also in this case, the surgical time was around 41 minutes and it was done under local anesthesia and patient was discharged the same day into home isolation. Third case, this was a 34-year-old male patient he was COVID-19 positive and he developed an L1-L2 disc extrusion with quada equina, which required an urgent decompression because he lost his bowel and bladder. So this was L1-L2 extruded herniation. This was his axial MRI. And we feel that in such patients coming from posterior midline can further jeopardize the already compressed quada equina, and transforaminal route offers a much better solution. So these are the CM pictures of how the endoscope was placed just under the posterior annulus. So this is the posterior annulus, which we see once we enter. And after achieving hemostasis, we could very well see the horizontal fibers of the posterior annulus. Then with an annular cutter, we create a small window. Now this window will give us access to the extruded disc fragment in the canal under the thecal sac. Again, with a blunt hook probe, we tease the fragment so that we can grab the tail. And once the tail is inside the disc, you can grab it by the base. And without losing the hold on the fragment, if we keep on tugging it slowly, we can get the entire extrusion. So we have to be very patient in such cases, because in case the fragment breaks, then we lose the connection. And then we have to do a more extensive surgery to retrieve the fragments. So this is the external view of that fragment, a very big one. Again, this was done under local anesthesia. This is the free decompressed thecal sac moving with the water column after the surgery. This patient was sent to isolation nursing and he recovered his bowel and bladder fortunately in 4 days' time. And then he was sent home under supervision. And this is his picture almost after 10 to 12 days. He still has weakness, but he started walking, he's pain-free, and bowel and bladder is recovered. So advantages of transforaminal endoscopy, all of us know. It is safer than GA in active and post-COVID patients. There is same-day discharge or transfer to COVID isolation possible, minimal staffing requirement, easy disinfection and sterilization after the procedure. And it is the most cost-effective, resource-friendly with negligible post-operative requirements. Friends, our future is uncertain. We cannot predict how long this pandemic would last. Hospitals and surgeons shouldn't expect a return to pre-pandemic approaches to deliver surgical care. The many changes that we have instituted during this pandemic is the new reality. And as a surgical community, we must learn, accept these changes, and evolve ourselves. We need to imbibe more efficient and minimally invasive techniques in our practice. Thank you very much. I hope you have liked my presentation.
Anand, beautiful as ever. Only 2 comments on your presentation. You have covered beautifully extruded disc, migrated disc, and contain disc herniation. So what is left about the disc? Nothing. You have just shown that in a very beautiful, simple presentation in 10 minutes, that you have covered the entire spectrum of all discal pathologies by Transforaminal. Fantastic presentation, fantastic.
Thank you so much, Malcolm. The focus here was on the
On the
COVID
pandemic.
Yeah, COVID pandemic.
But you put transforaminal endoscopy at a different level. So thank you for that.
Thank you so much.
And I'll tell you one thing, I'm not sure and I'm not certain about the future of the world with COVID, but I'm very sure about the future of endoscopy, spine endoscopy, especially with enthusiasts like you. It is the future. And to all my panelists and to all my attendees, it's a heartfelt message to all of you. Get on the bus before the bus moves away. You can't go through the next century of spine surgery without knowing spine endoscopy. So ride the wave or be left behind. That is in a nutshell. Now,
sorry, Malcolm, I'll take a moment without spending more time. This is actually an appeal to all my spine enthusiast friends. See, spine endoscopy actually started with transforaminal endoscopy world over, but I'm seeing that the enthusiasm of transforaminal endoscopy is slowly decreasing, probably due to longer learning curve or lesser results. But I would like to point out that every technique has its own advantages and disadvantages, and this technique is here to stay. Only thing is we can extend our indications by more better learning, more sharing, and definitely one should not be discouraged with initial bad results with transforaminal endoscopy. You need to learn biportal, you need to learn monoportal, you need to learn all other approaches, but definitely transforaminal endoscopy is also there to remain, and this is the most least invasive and result oriented surgery. So please don't get discouraged and take it up. Thank you.
Now, we were supposed to have Dr. Hayati as our next panelist, but because he is busy with his hospital work, I have opted to shift for him. So I shall start my own screen sharing and give you a small talk. Dr. Hayati will be talking at my time, that will be 4:15 in the evening. So I shall start my screen sharing now.
Yes, so Dr. Malcolm does not need any introduction, and he is one of the most lovable and friendly guy around. And I request him to please enlighten us with his presentation.
This one, yeah. Now, basically, my talk is upon the new frontier. This one's, no, I have to open this talk. I don't know what happened. I checked it in the morning. I think I will, just 1 minute, I'll stop my screen share and I'll just check out what is my problem. Can I just request Shidam to start with her talk? Shidam, are you there with us? Hello.
I'm here.
Shidam, can you start your talk? I'll just check out what the problem
Yeah,
is.
sure. Okay. Hi, dear colleagues. My name is Dr. Çiğdem Mumcu. I'm a neurosurgeon in Turkey. Today, I'm going to talk about biportal endoscopic technique, some useful tips. To start with, I'll describe UBE, then I'll explain the base concept of this technique. After that, I'll talk about complications and how to prevent it. Then I'll present some cases. Finally, I'll summarize my presentation. Spinal endoscopy has a long history, over 15 years, and is developed with well-known PELD, PCLD, and unilateral techniques. However, recently biportal endoscopic technique, which is called UBE, has been more popular. In the last in the last 10 years, endoscopic surgery has had such a great progress that today many spine surgeries can be treated by UBE. It is based on arthroscopic surgery. Let's take a look at the UBE history. In 1996, Dr. Anthony from Argentina published the first article about translaminar lumbar epidural endoscopy, only for lumbar discectomy. Then in 2001, Dr. Abdul Ghaffar described it too. In 2003, Dr. from South Korea presented endoscopic lumbar discectomy using the UBE technique. Between 2003 to 2013, UB surgery is extended from simple discectomy to treatment of stenosis and even fusion surgery. Let's move on to talk about the advantages of UBE. The merit of UBE is more familiar to spine surgeons. UBE and microsurgery are almost same approach in terms of instruments, anatomy, and surgical results. UBE view is a clearer and safer. UBE provides a good visualization of contralateral, sublaminar, and foraminal areas. And it has a wide range of indications. We can use all surgical instruments without any limitations. Furthermore, it is more beneficial for the patients. Let's watch these videos. The video on the left is UBE discectomy and the one on the right is microscopic discectomy. UBE view is much clearer and it also has more blood-free vision. That means clean view makes the surgery easier and safer. And here are the disadvantages. UBE is a great endoscopic procedure, but it is technically difficult. Especially, neurosurgeons might not be familiar with arthroscopic equipment. So the surgeons need to be trained to specifically learn the manual skills. UBE surgery has a long learning curve. To do UBE surgery, you should have 0 or 30-degree endoscope, RF device, shaver system, irrigating system, and special UBE instruments. UBE has a wide range of indications, all kinds of degenerative spine disease such as herniated disc, spinal stenosis, fusion surgery, revision surgery, facets, and so on can be treated by UBE. For the moment, we cannot operate intradural pathologies and spinal infection by UBE. However, in the near future, we expect to achieve this. When you start UBE, we recommend you operate with easy discectomy cases at the level L5-S1, which has interlaminar window that is much wider as it gives you much maneuverability. Later on, start with discectomy on the level of L4-5. By practicing more, then you can do it lateral recess decompression. And when you get more practice with using burr drill, you can start a spinal canal stenosis. Then finally, you can perform with posterior foraminotomy in the cervical spine or far lateral discectomy. You will gain enough experience in your first 50 cases. Yeah, okay. Now I will talk about some tips of UBE surgery. First of all, operative preparing is very important for patient safety. We should perform UBE under general anesthesia. It is better for both the patient and the surgeon. The patient must be in prone position with a neutral rolling bed. Also, 5 to 10 degree head-up position is necessary to protect optimum ISP during the surgery. Wilson frame allows kyphotic posture, which would increase epidural pressure and lead to more epidural bleeding. We recommend you not to use it. The next issue is about your team. Your team is very important as well. There are lots of details to prepare before starting the UBE. That means your nurses need to know how to set up the water pump or the irrigation system, how to connect your video system, and so on. It is not only the surgeon who must be trained with the manual skills, but also your team, your nurses, your technical staff for the final success. The next issue I would like to focus on is the technique. And here you can see the operative steps. First one is skin marking, which is the basis for UBE. There are two portals. One is the working portal, the other is the scope portal. These two portals must create a triangle above the lamina, which is very crucial. Second step is to create working space. For this, we clear upper lamina, interlaminar space, and lower lamina of soft tissue with the dilator. The next one is the irrigating system. It is essential to know how to use the irrigating system for fluid control, clear view, and bleeding control for patient safety. When you prepare the interlaminar space, the following step is similar to open microdiscectomy or microdecompression. This video shows us preparing the skin portal. For paramedian approach, first we need to determine the midline. Then the second line should be drawn on the medial margin of upper pedicle. Third line should be in the disc level. These lines should form a triangle in the center of spinous process. Distance of two portals is about 2 to 3 centimeters. After the skin and fascia incisions, the two dilators are inserted through the lamina, and then the dilators met and create a triangle onto the upper lamina. Then muscle detachment is made by the dilator on the distal margin of the lamina and medial side of the facet joint before inserting in the endoscope. It is necessary to prepare enough visual space. At the end, the scope and RF probe are inserted through the incisions, then are created V-shaped. At the end, the scope and RF probe are inserted through the incision, then are created V-shaped working mode on the upper lamina. Finally, a potential space is made with RF. So triangulation is crucial. If you make good triangulation, you can see the instrument in the screen. If you don't, that makes the surgery difficult. Irrigating system applies water flow continuously. So to control inflow and outflow is crucial. We should keep the pressure 30 to 50 millimeter mercury for patient safety. Controlled continuous outflow can make an optimal hydrostatic pressure. If outflow isn't proper, epidural pressure will increase and lead to some CNS complications. Good outflow gets clear view. Moreover, we can check the bleeding. If you lose anatomic orientation, the procedure becomes risky. We always need to know exactly where we are. We need to know, to have full orientation. If you feel you are getting lost, you should convert to microsurgery. High hydrostatic pressure can cause CNS problems such as headache, posterior neck pain, seizure, blindness due to retinal bleeding, hydrocephalus, and pneumocephalus. RF ablation may cause thermal injury on muscles and cord as well. It does especially protein denaturation at between 40 to 70 Celsius. That is why RF device must be used for a short period. If you cause more muscular damage by RF, it can lead to muscle edema than infection. If you want to get a good result, blood flow should be continuous. At the same time, your surgical view should be clear. Discopic hand can be moved in all directions. If you go deeper and closer to the pathology, you can reach a clear vision. That is very important. To keep optimum ISP 30 and 50 millimeter mercury, first, patient should be in the head-up position. Second, we always have to control the outflow. For this, the nurse holds the UBE retractor. Continuous outputs prevents complication. To prevent IF damage, you can relatively touch on dura of lumbar spine, but on cervical spine, don't. You should avoid touching directly on dura of cord level. Use RF for a short time and repeatedly. Let's talk about how we can control bleeding. Epidural vein usually bleeds. If there is bleeding, you should move the scope much deeper. Also, you can insert the suction tip here like a natural drain. Then fluid and blood will exit. Or you can coagulate directly with RF. If it doesn't work, you can use bone wax, gel foam, and so on. If you don't know where the focus of bleeding is, close the irrigation and wait for just 2 or 3 minutes. Clotting will happen spontaneously, then you can restart. In this slide, you can see my UBE cases that I performed for 2.5 years. In the beginning, I faced serious complications such as bilateral visual loss, epidural hematoma, and so on. I've learned how to avoid complications gradually. Now I will explain some vital details for a safe surgery. Now we will move on to talk some of my cases. This case was my first UBE case. He was 28 years old and had a right leg pain due to L5-S1 disc herniation. I performed UBE 2.5 years ago. There was no dural injury or any complication during the surgery. Post-operative, a few hours later, bilateral visual loss was observed. He was immediately referred to the Department of Ophthalmology. He had bilateral retinal hemorrhages. In this slide, you can see his fundus photograph of optic disc. He was applied YAG laser in both eyes. 1 month later, his visual acuity increased and the hemorrhages remarkably recovered. My second case is 34-year-old woman. She had left leg pain for 3 months due to L4-5 disc herniation. Preoperative MRI shows the ruptured disc at L4-5. This is another section, her MRI. After the UBE surgery, right side surgery, ruptured disc was totally removed. There was no dural injury or any complication during the surgery. Postoperative MRI showed good decompression of the spinal canal, but she developed right foot drop after the surgery because of excessive L5 nerve root retraction on the right side. She undertook physical therapy for a couple of months, then she completely recovered 6 months later. Here you can see her intraoperative video. The surgeon should always be gentle with the dissection and handling of neural tissue in such cases. Third case is a 21-year-old man with severe left leg pain, which had lasted for 7 months. Preoperative MRI shows the ruptured disc at L4, L5. After UBE discectomy, rupture disc was removed. This intraoperative endoscopic video shows ruptured disc compressed left L5 nerve root. Fourth case, 29-year-old man presented with severe pain in both legs with claudication. Preoperative MRI images show the severe spinal stenosis with herniated lumbar disc at L4, L5 level. After UBE surgery, central canal is fully decompressed. Post-operative MRI was taken 1 day after the operation, showing the sufficient decompression of spinal canal and adequate resection of lumbar herniated disc. Here, this is the UBE stenosis surgery. Let's watch my last video about how to perform UBE. You can see that surgical view is much clear during the operation. In conclusion, UBE technique gives a better and easier visualization of all directions. UBE may be an alternative and minimal invasive procedure for treatment of all degenerative lumbar disease. Thank you so much for your attention.
Shirem, a wonderful presentation by you.
Thank you.
Your talk was very, very informative. I'm sure all the attendees who are learning endoscopic spine surgery have a lot to learn from you today. Your talk was rich because it covered all the essentials. It covered how to do UB. It showed the comparative video between microdiscectomy and the clarity of UB. So I think you have really structured your talk very wonderfully.
Thank you.
You spoke very beautifully about your complications. So basically, your talk has been, I think, of great advantage to all the attendees here, and I think to most of the panelists also. So I'm very grateful. It's a pleasure to see you and to speak to you again. God bless you. Now I shall go back to sharing my screen and starting my talk. Thank you. I think now I can make it big and I can start. I hope I'm loud and clear to all of you. Dear friends, as endoscopic spine surgery has evolved, so have we. We have been learning and mastering various techniques, but there was always the question of fusion surgeries. How far can we go was always the doubt in the minds of our skeptics, never in our minds. So it became a question of developing endoscopic spinal fusion surgeries. And basically, I have managed to master two arts. One is the transcambin approach, and the second is endotelif using UB. So both the approaches I'm going to discuss with you. I'm going to play my video. Good morning, welcome to Golden Park Operation Theatre, Endospine Suite. Today we are doing a case of transforaminal endoscopic spine fixation. We'll be introducing the cage through the foramen without violating the facet, and we'll be doing minimally invasive posterior screw fixation with reduction of a patient of degenerative listhesis, as you see over here. The L5 is moved ahead on the S1. There is collapse of disc height, and we can see that in extension there is partial reduction of this, but in a flexion view, you can see that it's a grade 1 to grade 2 listhesis. Now, if you see here in the MRI, you can see that the huge broad-based disc bulge because of the listhesis. It's a very tight foramen. Bilaterally, patient is having severe claudication. There are wet facets that are observed, thickening of ligament flavum, but basically the sac size is quite capacious. So I feel that by getting a good distal height transforaminally and minimally invasive fixation and debulking this posterior discal surface through an inside-out approach, we will be able to restore this spine to its normalcy. This surgery is basically being done under local anesthesia, where the entire cage will be inserted under local anesthesia to the patient. And subsequently, after patient is given a sensory epidural, we will be putting in with the local aided 4 minimally invasive screws. The top 2 screws will be reduction screws, and we should be able to fix up her spine with the cage loaded with bone graft from the iliac crest. And hopefully she should be on her way to recovery. So thank you very much. Let's hope we get a good result today. Now I'm showing you the video of the preparation of the graft. Now we are curating the end plate. We are curating the end plates right now. I'm using a specially designed curate which goes in the disc, angles itself, and helps you to curate the end plate very nicely. Can you please bring the C-arm in front, Mr. John? Yes. You can see how I'm
live show,
rotating.
please, continuous.
Yeah.
Yes, thank you. And as you can see, continuously shoot. Here now, John, please. As you can see, we are now to your
It's an unedited video,
space inside.
so you can experience the pleasure and the stress of the surgeon also.
Steady now. No, don't shoot now. 1 minute. Shoot, please, John.
Normally, I don't take so much of exposure, but this is just for demonstration purposes.
And I'm trying to put it towards the upper end.
And you can see how the preparation of the end plates is progressing.
Live shooter. Yeah, now you can see the gradual movement of the curate towards the upper end plate. You're creating center of the disc. Okay, thank you so much. Stop shooting.
This is a video which shows you the preparation of the end plates.
This is the superior end plate.
You can see how it is nicely curated out. Pinpoint bleedings being seen from both the end plates.
To expose the end plate preparation on the
Above is the neural
S1
tissues.
vertebrae.
The entire
So
disc
the
has been emptied out.
Surfaces are now prepared and are ready. You can see the cage. There are a few loose fragments which are being pulled out, flushed out, and we are ready to place our cage.
In the next video, I'm going to show you how I introduce my cage. The cage has been loaded and packed with bone graft. We have already inserted some bone graft into the disc space. And now I'm introducing the cage. It's completely packed with bone. And you can see in the C-arm images how the cage enters the distal space. It's an L5S1 disc. Please understand it's not horizontal, it has an obliquity to it. And therefore placing the cage becomes a little difficult. But you can see patient is awake and aware.
Yeah, ask her to move her leg. Wonderful. Is she having any pain? Shoot, John.
She has no pain, she's comfortable. And now I'm introducing the cage in the distal space.
Shoot, John.
And you can see the cage entering the disc.
Shoot, John.
Now the cannula is protecting the
Is she having any pain?
exiting
Ask her,
nerve root.
please.
The facet is protecting the traversing nerve root. And the cage is well placed right in the center of the disc. After this, I did a biportal clearance of tissue posterior to the cage, just to see the position of the cage. Here you can see the cage in a corner. Above is the blue coated annular surface. And across you can see a dark hole. That is from where the cage was initially introduced.
Posterior to the cage now.
We are posterior to the cage at this moment.
And may cause of pain. So biportal endoscopy with insertion of cage through one of the foramens.
So coming back to my experience in transforaminal or transcambin fusion surgeries has been with degenerative retrolisthesis, in patients of lysis listhesis, and in patients of severe canal stenosis. Here you can see in this patient how the cage has been placed. You can see the incision marks on the skin for the fixation with pedicular screws and rods, and from where the cage has been introduced. This is a case in which there is a 4-5 degenerative listhesis. Transforaminal cage with minimally invasive screw fixation is a reality. It is something that we've been doing routinely for the past 3 years. I personally have done more than 50 cases of fusion by now, awaiting its long-term results and reviews before publication. Coming to this slide, I will be discussing with you facet sparing transcambin approach. What is it? it retains the integrity of the facet and it adds to the stability of the construct. We do not create an instability. Annular entry is far lateral, so the cage that goes in is more horizontal. Failure of the implant will not result in a complete collapse or crushing of a root because you have not removed the facet, you have retained the entire facet. TLIF is a misnomer. When we say translumbar or transfacetal lumbar interbody fusion, what does it mean? It means that we are going to destroy the facet, remove the facet, create space laterally, and then put in our cage. So is creation of instability by removal of a facet justified in the aim of achieving stability by fusion? That is a question to be answered. There is a possibility of non-union implant failure, and what happens in such patients with an iatrogenic facetal loss? So we need to consider these issues also. Basically, I agree that transcambin fusion is an indirect fusion. It's quite similar to OLIF, it's quite similar to ALIF. Therefore, it has certain restrictions in its approach. It cannot be used for direct decompression of all the posterior structures. So therefore, I developed and I started practicing endo-TLIF or endo-UB TLIF, in which you have a direct visualization of the cord, the exiting roots, but there is a more vertical positioning, and then you have to gradually, now we have picked up the art of flipping the cage, making the cage more horizontal and dipping the cage deeper. But we use a bullet cage, and I prefer to use a cage which is around 28 mm in length. Here you can see a video of me introducing the cage with the canal after doing a UB. And you can see it's a 28 mm case, completely loaded with graft. Slowly take a position. You can start the downward journey of the disc. Cage is loaded with bone graft. Graft is packed in from the facet anterior to the cage. You can see the cage is descending into the space between two vertebral end plates. See my cage going in nicely, tapped in place. So UB TLIF it is, but again, it has its own problems. This is a complication I encountered. I had a tear, a disaster struck me when I was sitting in the cage. I had a small lateral tear, dural tear. You can see a nerve rootlet coming out of the tear. This requires repair. It's unacceptable. And I had to struggle to suture it. The video of that has been put up elsewhere. But anyway, it's a complication and we need to learn to deal with it. Now, endo-TLIF, again, it is my favorite. UB TLIF is my favorite, especially where there are adherent and plastered nerve roots, where there is a dural sac which has been stuck to fibrous tissues. It's a case of a redo surgery. Why? Because here I get the opportunity to visualize the entire nerve root. I can see its adherence, and I can do this decompression and fusion, which I cannot achieve in an indirect manner through a transcambin fusion. So where transcambin fusion has its restrictions, that is where UB fusion has opened up a new vista or a new window. Here you can see me working on the facet. Endoscopic TLIF, especially in a recurrent disc herniation, holds a great advantage where one can identify the facet, osteotomize it completely, push away the dural sac with all its adherent tissues, then identify the root which is completely plastered, Here you can see how with the dissector I'm pushing away the root and identifying the discal surface, which is barely a millimeter across, getting into the discal zone and pushing away the root which is plastered to it completely. Now, this would not be possible by a transcambin approach and would result in unnecessary traction on the root at the time of expansion by a cage. So, every procedure has its pluses and every procedure has its minuses. Here you can see the dissector making space, and you can see the root which is plastered completely to the superior surface of the discal space. As a matter of fact, as I come laterally with the dissector, I find bone covering the root. And therefore here I will have to osteotomize that bone which is covering the root to free the further lateral extension of the root. Slowly I'm probing away, slowly I'm pushing away the root from the discal surface. And now you will see the osteotomization of the bony tissue covering the root, to make sure that the root is entirely free prior to placement of a cage. So, endo-TLIF via UBE holds a distinctive advantage as far as the recurrent cases are concerned, where one does not know the level of pathology, adherence of tissues within. Here you can see how I'm osteotomizing with the dissector and gently pushing away the bone, removing the bone which is on the root. This is the traditional part of the surgery where you put in a sizer, dilator, and subsequently use a rotating curette to create space for the graft. Thank you very much. This is the end result of that surgery. A beautifully placed cage, screws and a rod. Nowadays I keep doing unilateral implantation rather than bilateral because I'm sparing the other facet, and it's by and large mostly frozen because of the old previous surgery. Here you see a patient with a retrolisthesis at 3-4 and a bad segment at 4-5 with compression of the exiting root at 4-5 on the left side. Now here the question to me was that at L3-4, I needed to do a posterior decompression. I needed to free the traversing roots. And at L4-5, I felt that the sac was capacious. So what do? You can see here in the plain X-ray, the retrolisthesis collapse, and yet for 4-5, you can see this space in the tight foraminals. So I combined the two techniques. I did a UB endo-TLIF at the upper level, where I needed to do a proper decompression, free the lateral canal, lateral recesses, remove the thickened flavum. And at L4-5, where I felt that I could get away with transcambin fusion, indirect decompression, I put in a larger cage, and we achieved our goals of using both the fusion processes, whether by transcambin or by endo-TLIF. Main goal and aim being that the patient should be comfortable and walking the next day, in which we did achieve in an old lady. So, facet sparing TLIF, that is transcambin TLIF, is a perfect example of indirect decompression and fusion. What are its advantages? Advantages is preserving both the facets. You are inserting a cage under local anesthesia. In the second stage, you use a small sacral epidural, sensory and just put in your MIS rods and screws. Patient is doing his or her own neuromodulation. Minimal blood loss of maybe 50 cc's in the entire surgery. And you have a visualized end plate preparation. There is zero accidental durotomy or root tears because your sleeve is protecting the exiting root and the facet is protecting the traversing root. It's ideal for elderly patients with multiple comorbidities. But what are its disadvantages? Disadvantages, it cannot resolve central canal stenosis, cannot be done in old redo surgeries where you suspect severe entrapment of a nerve root. Little expensive infrastructure because transforaminal scopes and instruments are a little more expensive. And you do need a little bit of endoscopic training. Posterior UB endotelif is a perfect example of a direct fusion. You are visualizing the dural edge, the nerve root in its entirety. It's ideal for associated central canal stenosis, facetal cysts, other pathologies. It's an ideal for redo explorations where root entrapment is severe and root has to be explored from dura to the extraforaminal region. It's easier for a traditional spine surgeon to adapt to this procedure. And obviously, you can introduce a larger size cage. Disadvantages, yes, epidural or general anesthesia is a must. There is a possibility of a root or a dural tear, which I showed you in my own patient. And blood loss is relatively more in comparison. I thank you for being patient with me. I've had a few hiccups in my talks today. I think I should stop my screen share now.
Very good presentation, Malcolm. Just one suggestion, shout less on John, otherwise one day without shooting Siam, he will shoot you.
But you know what, Anand? When you show something unedited. There is no pleasure in the world trying to, curate everything. Our attendees and our panelists who are now going to come up to the level of endoscopic fusions on a regular basis, they need to see unedited videos. They need to see live surgeries. They need to adapt to a changing world. As a matter of fact, I have started doing a lot of live surgeries now. Many surgeries I put up live on Facebook so that they're completely unedited and people who are watching it can watch our struggle, our pain, our grief, but our happiness and how we do things. So I think
Malcolm, I feel we also need to put up a little long-term report of fusion rates and comparative fusion rates between both transforaminal as well as UB TLIF surgeries.
Exactly the thing. I'm waiting for my 2-year results to come in now. And we will be publishing very soon on that. We have done quite a sizable amount of cases. I know that's not enough. I know that's definitely not enough. But I think it's still a start. It's still a...
Especially in those patients with unilateral fixation.
Yes. That is one of the new variants in the theme that I've been taking.
Yes.
Because I have the concept that since we are sparing the facet, especially in transcambing completely, and even in UB, especially in redo surgeries, the facets by and large are quite fused, immobile, and unilateral fixation is only to make sure that there is no backing out of the cage. So I just compress a little bit to make sure that the cage is held nicely in. And I'm depending more on the actual process of fusion to give me a good result. And I will definitely be sharing those results maybe by the time we have our next Congress.
Wonderful.
Thank you very much.
That was a great talk and lots of learning from you. So let's proceed with our program.
Yeah, we have now a talk of Dr. Peter Van Diel. I just asked my guys to help me because unfortunately he's not able to be with us. So he's asked me to share his talk. I don't know, my own PC is today giving me trouble. Anand, I think we will request Dr. Kamtek Lim to start with his talk, and in the meanwhile, I'll set up the other talks. Just give me some time. So if you can invite Dr. Kamtek Lim.
Sure. Dr. Lim, are you around? Can you hear me, sir? Dr. Lim? Dr. Kamtek Lim, can you hear me? Hello.
Hello.
Nice to see you, sir.
Okay, long time no see.
Yes, long
I
time.
hope I hope to see you again in your country.
Yes, of course.
It's my turn.
Yes, yes. If you can start your presentation. There is a little bit of reshuffling, but it's actually your turn now.
Okay. Okay. Can you share?
Just start your screen sharing.
Okay.
Yes.
Can you see?
Yes, yes, we can see.
Okay. Can I start?
Yes, sir. Please proceed.
Okay. Hello, everyone. It's a long time no see. So we can see each other on the online finally. Okay, I will talk about the current situation of endoscopic spine surgery in Korea in the operation room. So what can we do with the endoscopic spine field now? Is the topic today. It's my disclose. My team, the 5 surgeon performed 5,800 cases endoscopy surgery for stenosis from 2016. The endoscopic decompression can be another option for surgeon to consider open surgery, and is being extended to the category of fusion surgery, TRIP and HDF. The operation conducted in my all cases are 100% endoscopic surgery now. We know as the world is becoming an aging society, there is an increasing number of the patients who suffered from with a medical problem, the heart, brain, and have a great risk from the general anesthesia during the big operations. The endoscopic procedures include the fusion surgery performed under the epidural anesthesia with a vascular sedation. But sometimes patients who need to be communication between doctor and the patient is necessary during the operation. Just epidural anesthesia without sedation is recommended and possible. You know very well, this is just a basic procedure, interlaminar approach. The landing point is just beside the spinal process, the ipsilateral and contralateral decompression and bilateral full decompression. As you know, just one level. The endoscopic view provides the good visualization, accessibility, even the central area, the very unapproachable midline region. This is because just the turn, the endoscope around contralateral can look very close. The bone work at the contralateral region get easier. It's, I think, one of the advantages of a uniportal endoscopy. If we turn the endoscopy, contralateral region, it looks like ipsilateral. the area, because the working channel is at channel and the lens is located on the edge, not at the midline. This is animation show how to perform 3-level intralaminar decompression with just one skin incision, 3 fasciotomy as a jumping technique. The middle segment first, L4-5, and then L5S1, L3-4 as a serial process. It's a 3-level to 3-4-5 decompression. Post-operative MRI, axial shows full decompression. Patient can walk right after procedure with free drain. It's a 4+ operation, 4+2 operation. It means first the 4-level intralaminar with just one skin incision using jumping technique, and then 2-level, the foraminoplasty with a paraspinal 1 skin incision using jumping technique also. Post-operative X-ray shows 6 drain at each segment, and the patient has 6 coronate. And I'm sure you are familiar with this transforaminal the approach for foraminal pathology. Endoscopic instrument can reach midline from the foramen after full decompression. It's a 2-level foraminal stenosis, the same side. The endoscopic, the foraminal approach, 2-level with 1 skin incision using jumping technique is best choice, I think. There has been huge increase, the significant advancement in endoscopic spine surgery over the past few years. Endoscopic decompression is being extended to the category of the fusion surgery, TRIP and HDEP. As the 57-year-old female has L4-5 unstable the spine. Post-operative radiology study shows the stable after endoscopic fusion with a small skin incision and minimized muscle damage. Using 1 skin port, endoscopic facetectomy, and the plate preparation, allobone graft, and implantation is possible, and 3 more, the skin incision are for the pedicle screw, the insertion. So full meaning of a full endoscopic fusion is means the whole process, from the start, discectomy and allobone graft, implantation to the finish using by endoscopy. I think ideal the skin port can be 4 centimeter from the midline, 4 centimeter, that can do the facetectomy and wider discectomy for fusion bed area. Endoscope system can reach to the contralateral disc space, and so we can make a wider space for the fusion bed the easier. KG. It's my paper of endoscopic the lumbar fusion. The post-operative MRI shows the marked increase the cross-sectional area and the foraminal the height, direct indirect decompression. The bone graft area was better in the endoscopic group than mini open TRIP. Fusion rate, the segmental lordosis, disc height, the of endoscopic fusion is just as well as mini open the TRIP. So moving to the cervical, after the introduction of endoscopic cervical posterior decompression for paracentral disc and stenosis, we don't need to perform HDF. So total case of HDF is decreasing in Korea now. But some cases, we need to fusion surgery and implantation with anterior approach to solve the problem in case of midline pathology. It's not easy to access to the pathology lesion with the posterior approach. We have to choose anterior approach. Under the general anesthesia with minimal neck flexion, face in soft handling with no pressure on eyes and nose, very important. We should be careful not to pressure the eyes, can cause blindness post-operatively. No head clamp are the proper way for endoscopic surgery. The ideal landing point of the instrument is medial board or lateral mass to perform laminectomy first, and 1/4 facectomy to decompress is enough. Ipsilateral and the contralateral decompression or spinal cord or the shoulder, axilla. You know, this is the vertebral artery. Should be careful not to damage the vertebral artery more the outside. I think an 8mm diameter endoscopic system is easier to move in the narrow space on the degenerative spine. The bigger size is 8mm, but bigger size, the endoscopic are not smooth like a small endoscopic movement on the surface of a hypertrophic facet joint. That's the endoscopic discectomy and the foraminotomy. Clean surgical view is one of the advantages of endoscopic surgery. We can find the motor root and the sensory root. It's the video clip. It's a waypoint landing spot, and C6, C7. We can expose the dura and the root. It's very important to know the anatomical structure. We had to remove the perineural membrane during around the root, and finally you can find the discal space. Do not retract the motor root too strongly. It's important to avoid the root injury. It's a 3-level decompression. So 3-level decompression for cervical stenosis. The endoscopic decompression with one skin incision posterior approach. So it's not work. Okay. It's a C45, C5 or 6. Sorry, it's not work. Okay. It's just the animation of the 3-level spine. In cervical spine, the distance between adjacent segment is short each other. Using the one skin incision, one fasciotomy endoscopic system, reach to adjacent area. It's the sliding technique for 3-level. And it's important to check the dynamic, the MRI extension, the flexion to know what is main pathology may result in compression, compressed spinal cord in case of a myelopathy. And the 4-level stenosis from ipsilateral to the contralateral, ipsilateral to contralateral, full spinal canal decompression is available with endoscopy. Thanks to the excellent outcomes of endoscopic decompression, forced the H-depth laminoplasty to be decreased now in my operation room. MRI axial view shows the increased spinal canal post-operatively, and post-operative MRI shows a significant increase in cross-sectional area without muscle injury. The one skin incision and the 2 fasciotomy, jumping and sliding on the surface lamina at 4-level segment is available. And in case of the anterior autofusion, the the wide facetectomy can be useful for decompression completely. That doesn't cause the instability post-operatively due to the strong autofusion anterior. I think posterior the cervical, the muscle ligament complex is like a bowstring, can keep its shape, curvature of bow. And the posterior decompression doesn't cause kyphosis because that does nothing to damage posterior muscle ligament complex. If we apply endoscopic surgery in cervical region, laminoplasty can be avoided that cause post-operative kyphosis. In case of a foraminal stenosis, just unlooping is enough for root decompression like this, the Corin canal. Just unlooping, right? But wider decompression include pediculectomy is sure to require for discectomy, like this, the Suez canal. It's a pediculectomy. It's the C1, the hemilaminectomy using endoscopy to decompress myelopathy for C1 to Atlanta axial, the shooter tumor case, no instability. There were the endless, the agonists about the brain problem related to pressure from the water irrigation during the operation. It just scared me, but fortunately, there were no any brain complication after the operations. C1 hemilaminectomy. It's taken a long time to get the kind of endoscopic technique in high cervical region, like a C2 symptom in case of rheumatoid pannus arthritis. We can apply endoscopy, high cervical region, instead of the fusion surgery. It's a C2 root decompression. It's a C2 root, the final end stage of C2 root decompression with the endoscopy. There is more space. There's more space between the dura and the spinal canal, the wall at C12, the high cervical, than low cervical area. The surgical work would be much easier than expected at upper cervical area. The endoscopic surgeon has extensive experience in developing the technique how to approach to the anterior cervical space for endoscopy HDF with small skin incision and safety. We can use endoscopy in HDF also. 10-degree lens angle is very important to see the ipsilateral uncovertebral joint. There need to be the education before the endoscopy HDF to know and how to. It's very important to note the anatomical structures, normal anatomical structure to avoid the damage anterior visceral organ, carotid, esophagus, and the trachea. One of the most serious complication can be the esophageal injury during the operation. I have one case of the esophageal injury at the early stage. So the insertion of the Levin tube was essential to know the location of esophagus. And so even though it's a trachea is the Levin tube under the C-arm, even though the esophagus is more right side, I will approach it to right side approach. But generally the pushy, the anterior visceral organ include the esophagus with a finger to the opposite side. And then we can insert the needle into the disc space, and then you can insert the serial instrument and the endoscopy. It's a skin scar, different. The young male patient has a C5 or 6 herniated disc central type. AP diameter is just 3 millimeter. It looks like we will have to perform anterior approach ACDF. As the process, it's a very clean view with under the endoscopy. At the anterior disc space and discectomy, and then the removal uncovertebral joint and the cage insertion, osteophyte, posterior hypertrophic osteophyte removed, and finally, after removal PLL, we can see the dura pulsation and the cage insertion with the DBM, and to keep the drain is very important to prevent the hematoma. You can see the esophagus moved to the safer place that you can use a punch under the endoscope view. Post-operative X-ray, MRI, small scar, and 6-month follow the X-ray. It's very interesting case. The old male patient has a cervical myelopathy due to anterior disconation and posterior buckling of ligament flavum. Post-operative MRI shows full decompression with posterior decompression and anterior, the ACDF both. The first, I performed posterior decompression and then anterior ACDF with endoscopy at the same stage. You can see the posterior decompression drain and anterior ACDF drain. It's a posterior, the endoscopic decompression, just spinal cord, ipsilateral and contralateral. Before the implantation, you can see pulsation of dura after the discectomy and removal PLL. And it's we can apply the endoscopy for the cervical ADR at the same way. And move to the thorax, endoscopy can apply to the thoracic region. Most common pathology region, thorax will be the OLF and the herniated disc. OLF has been widely recognized as the main cause of thoracic myelopathy. MRI shows the bilateral, the compress, the spinal cord at T10, 11, 12, and just beside the spinous process like a lumbar, the bilateral decompression, and post-operative MRI shows a full decompression. And the disco, the approach for disco, the herniation is different. The landing point is, so I prefer the paraspinal approach. And the process of the endoscope surgery, you can, using the drill punch, you can expose the dura and the root. And with the paraspinal approach, we can reach it to the midline. The post-operative MRI shows the full decompression at T8, 9, 10. I think the next advanced the operation will be next the advanced operation we are gonna do is the VB the vertebral body sliding osteotomy with endoscopy for the cervical decompression and the IDM also, the tumor removal. So one of the biggest change to the spine surgery is that the total number of fusion case include the trip and the cervical age depth, were actually decreasing after introduction of endoscopic surgery in spine. Maybe this is because endoscopy is doing so many things in degenerative spine. The challenging to the something is scary at the moment always, but we have a new weapon with a new idea to overcome the many difficulties, many pump now. Either way, endoscopy is a science for equipment, endoscopic technique for the surgical approach. The window of generational change are upon us. It's a current situation of the spinal, the endoscopy surgery in my operational. So if you want to get the information more, please visit the process, Korean Research Society of Endoscopic Spine Surgery. Thank you.
Dr. Kim, Dr. Kantek Lim, it's a privilege and honor to listen to you. Every time you set a new benchmark for the world to follow. Your technique or jumping technique in endoscopic spine surgery, your innovation in cervical fusion via scope. And today you have really pushed the limits of endoscopy to the sky. We are all very proud to have you with us. Once again, on behalf of all the panelists and all the delegates, I thank you, Dr. Kantek Lim, for being with us. Thank you very, very much, sir. May I please ask you to stop your screen share now, sir? Please, can you stop your screen share? Dr. Lim, can you please stop your screen share, sir? Please exit. Yes, thank you, sir. Thank you so much. I will now invite Dr. Yoon Sung Kim, our principal keynote speaker today, to address the conference. Before I start his presentation, Dr. Kim, can you please unmute yourself and can you please address us?
Yeah. Hi, everyone. I'm Hyun Sung Kim from South Korea. It is my great pleasure to give a lecture in second World Congress of Spine Endoscopy. And thanks to inviting me, Professor Malcolm Pestonji. I believe that this conference is a very nice conference and will success and guide the endoscopic spine surgery in the world. Thank you so much. Please sharing my slide in your side. Thank you, Chairman and Professor Malcolm Pestonji. Good afternoon, ladies and gentlemen. I'm Hyun Sung Kim from Nanuri Hospital, South Korea. First of all, it is my pleasure to be able to give a lecture at the second World Congress on Spine Endoscopy. Today, my lecture topic is full endoscopic uniportal, posterolateral, transforaminal lumbar interval fusion, technical tips and clinical results.
Who is the next speaker?
Endoscopic spinal surgery has made steady progress in the meantime. Currently, endoscopic lumbar interval fusion generation is in progress. According to my paper published in Neurology India last year, when endoscopic lumbar interval fusion become possible, more than 90% of degenerative spinal disease can be solved by endoscopic spinal surgery. The currently implemented endoscopic transforaminal lumbar interval fusion is divided into transforaminal Campbell's approach and posterolateral approach. Among them, the trans-Campbell approach has the advantage that it can be implemented in the local anesthesia and can preserve the facet. On the other hand, the posterolateral approach is a facet sacrifice approach, but it has a much wider indication, can provide sufficient decompression and reduce DRG injury. Today's my lecture will discuss the posterolateral approach. This figure shows the process of uniportal full endoscopic posterolateral transforaminal lumbar interbody fusion. The skin incision point is the lateral border of the upper pedicle, and the working channel docking point is the medial border of the facet joint. The first step of uniportal full endoscopic posterolateral transforaminal lumbar interbody fusion is the process of the resection of inferior articular process. And this process can be divided into medial to lateral approach and lateral to medial approach. This video shows the process of removing inferior articular process from uniportal full endoscopic view. This video shows the process of removing superior articular process from uniportal full endoscopic view. The drilling point of superior articular process should be the upper margin of the pedicle as a guide. The second course is the disc preparation course, which is the most important course in the uniportal posterolateral full endoscopic transforaminal lumbar interbody fusion. This is because effective disc height restoration and high fusion rates can be obtained through this process. The most important part of this process is first, adhesive disc drilling, and second, end plate denudation. The next process is the inserting the cage, and this process can be effectively and safely inserted using the Harrison cage glider that has bilateral lobe root protection that I developed. This video shows the process of inserting the cage through the Harrison cage glider. This photo shows the skin incision after full endoscopic transforaminal lumbar interbody fusion. Now, I will show the surgical process of the uniportal full endoscopic posterolateral transforaminal lumbar interbody fusion. This patient was a 70-year-old male patient with severe collapsed spondylolisthesis. Now, let's take a look at the surgical procedure.
Here is the resection of shipyard process. Here is the guide of the pedicle here. You can see here that the disc space is firstly very narrow, but after drilling, the disc space more widened.
After surgery, the patient pain was significantly improved, and it can be seen that sufficient fusion has been achieved on CT follow-up after 6 months. Biportal full endoscopic contralateral lumbar fusion has several advantages. The first advantage is that sufficient decompression is possible, shown in these cases. The second advantage is that it shows an excellent effect on focal segmental correction because it can sufficiently releasing adhesive disc in endoscopic view. Sufficient adhesive disc drilling on the full endoscope view is also very effective for discrete restoration, shown in these cases. According to a report by me in 2020, this advantage of contralateral full endoscopic transforaminal lumbar interval fusion can be found to be of great help in the reduction of spondylolisthesis. Here's another case of spondylolisthesis treated by Biportal posterolateral full endoscopic transforaminal lumbar interval fusion. Because of advantages of focal segmental correction and discrete restoration, some of adult degenerative scoliosis can be effectively corrected through several advantages of posterolateral Biportal full endoscopic transforaminal lumbar interval fusion. Here's another cases of degenerative scoliosis treated by Biportal full endoscopic posterolateral transforaminal lumbar interval fusion. The endplate denudation technique performed in full endoscopic posterolateral transforaminal lumbar interval fusion is a very important part of the fusion process. It can be seen that fusion is completed through 4 processes. The first, the endplate preserve stage. The second, the endplate opening stage. Third, the bilateral sclerosis stage. And the fourth, the fusion bridge formation stage. The fusion rate of full endoscopic posterolateral transforaminal lumbar interval fusion is significantly higher than that of conventional open surgery. And it is presumed that this is due to the following 3 conditions. It is estimated that first, endplate denudation, second, 3D printed cage, and third, DBM block are important factors to increase the fusion rate. According to my study accepted in Global Spine Journal, uniportal full endoscopic transforaminal lumbar interval fusion compared to open transforaminal lumbar interval fusion is VAS, ODI, McNabb's criteria showed similar results, but 1-year Bridwell fusion grade lower and Kim's fusion stage higher were statistically significant. This patient was a 62-year-old male patient who complained of severe right lower extremity pain. The pain was remarkably improved through uniportal full endoscopic posterolateral transforaminal lumbar interval fusion. And the fusion was very successful at only 1 year follow-up. As shown in these cases, uniportal full endoscopic posterolateral transforaminal lumbar interval fusion exhibits a high fusion rate and rapid fusion process. Finally, I showed a few cases. This patient was a 57-year-old female patient who complained of severe right lower extremity pain. The pain was remarkably improved through uniportal full endoscopic posterolateral transforaminal lumbar interval fusion. And the fusion was very successful only at 6 months follow-up. And it can be confirmed that paraspinal muscle atrophy, including psoas muscle, has sufficiently recovered after 6 months follow-up. This patient was a 67-year-old female patient who complained of severe both low extremity pain. The pain was remarkably improved through uniportal full endoscopic posterolateral transforaminal lumbar fusion, and the degenerative scoliosis was successfully corrected after full endoscopic posterolateral transforaminal lumbar fusion. This 48-year-old female patient came to the hospital with very severe pain caused by inflammatory discogenic back pain. In the preoperative X-ray, we can see the loss of lordosis. The patient pain improved remarkably after uniportal full endoscopic four-level transforaminal lumbar fusion, and the loss of lordosis can be seen to be remarkably improved after surgery. This patient was a 70-year-old female patient who complained of severe right leg pain and foot drop. This patient received kidney transplantation 3 years ago. The patient received the three-level uniportal full endoscopic posterolateral transforaminal lumbar fusion, and the total operation time was 3 hours 10 minutes. After receiving the operation, the patient pain was remarkably improved, and the motor weakness also improved near completely. In conclusion, endoscopic lumbar fusion is not a simple minimized option treatment tools. The ultimate goal is to obtain better results than conventional open surgery through adhesive disc releasing and end plate denudation, and to provide better treatment results to patients. Thank you for your kind attention.
Thank you so much. My lecture is finished.
Thank you so much. Wonderful talk. And I think today you put it in a nutshell, sir. You have described, like I had also spoken upon, both the approaches of fusion, whether you do it transcambin, whether you do it transfacetal, whether it's monoportal or biportal. Basically, it is the combining of techniques. It is the combining of advantages. In transcambin, we have indirect fusion, and in monoportal or biportal transfacetal fusion, we are having complete direct control of decompression. So excellent presentation. Thank you so much, sir. Very kind of you. We are honored to have you with us, sir. Thank you, sir.
Dr. Kim, that was really a remarkable presentation with wonderful case presentations. I would like to congratulate you. And your ingenuine, that intradiscal cage device, cage implantation device was also amazing. So once again, heartiest congratulations for an excellent presentation.
Thank you so much. Thank you so much, Kabi. Yeah.
I will now be presenting Dr. Peter Van Diel's talk. So I shall again start my screen share. 1 second. Dr. Peter Van Diel has not been able to be with us today, and he sent his talk.
My name is Peter van Dalen from Belgium, Waregem, and I would like to present you a full endoscopic cervical facet cyst resection. 61-year-old female was seen with left arm pain, no score at 9 out of 10 in the arm with no myelopathy. She had on EMG a C8 denervation of the left arm. Imaging performed by MRI and CT scan. You could see a large paracentral facet cyst, C71, compressing the C8 nerve. There's no myelopathy. On the CT scan of the cervical spine, similar view of the large paracentral C71 facet cyst. see. As a treatment, full endoscopic cervical keyhole following was chosen. The patient's head is fixed in a leaflet. For good imaging in lateral fluoroscopy at C71 level, it's important to put traction on the shoulders. During the endoscopic surgery, fluoroscopy will remain in lateral view. As a reference, in AP fluoroscopy, midline and facet lines are marked. This lateral line at the middle of the facets will actually be the entry point for the camera of the endoscope. Then the fluoroscopy is positioned in lateral view and needle is placed at the correct level in a projection of the C7-D1 disc. The needle can then be removed and at this actual point, the 6 millimeter incision is made. This is controlled by lateral fluoroscopy. As the next step, the dilator can be bluntly docked on the facets and over the dilator, the cannula can be inserted through the paracervical muscles and docked on the facet joints. Here we can see those steps during the actual surgery. Now, the endoscope is put inside the working channel, the actual endoscope. On this lateral fluoroscopic view, we can see that our endoscope is targeted at the correct level where our pathology exists. On endoscopy video, you will see this image for orientation. 12 o'clock is towards the midline, 3 o'clock is called towards the feet of the patient. Lateral is 6 o'clock and 9 o'clock is cranial towards the head of the patients. When you start endoscopy, you will only see soft tissue covering the bone structures which have to be cleaned up by our device. The goal is to identify the V sign, V created by the upper and lower lamina within between the flavor ligaments, base of the facet joint. In the endoscopic view, you see the bone of the upper and lower lamina with the flavor ligaments. As the next step, the lower margin of the upper lamina will be drilled. Foraminectomy is performed by resection of the middle margin, middle of the facet joint. Also the in this sense, we see that drill resection of the section is completed by utilization of the stretch of the flavor resection. The exiting CV is identified. Resection of the flavor ligament at the cranial part of the operation area. Well, as you see, it's the facet cysts. Resected. Calcium patch. It's the facet cysts shown here. It's towards the cyst. The exist. The bulk. Cyst. With the nerve dissector, a blunt interval is inserted between the dura and the cyst wall. This is not always possible because of adherences. Here we can clearly push medial wall of the facet cyst away from the dura. Wall is then resected with kerosene punch puncture and still a lot of material from inside the cyst and also on the decomposition. You can see the exiting seal and the 12 position of the dura. Stimulation also the lower part sides. The cyst wall is more screen. You can see device show that necessary. With the rongeur, the cyst wall fragments get moved. That's this possible. Yes, towards. Sorry, that's the excellent. So you can see that we have the front one now. See. So see. Final completion. You can see pulsating dura neurostructures in the decompression. Endoscopy procedure is finished. Spinal surgery, small damage. The actual volume of cyst wall and cyst content which was removed on postoperative MRI, you see a very nice decompression of facet cyst. The red area you can compare it with real. On postoperative scan, you see that there was no station. Small keyhole from performance. We look at the picture. There's not a lot of cellular system just that surgery it's an important cases. Surgery full endoscopic treatments. The largest series of the Vascular. They reported one surgical case. Also came published case of symptomatic facet system as the take-home message, you could say that certain facet cysts or cervical surgical full endoscopic steps are identical. Symptom adherence of the cyst to the dura can be hazardous and can make surgery. Overall, for endoscopic surgeries, these are quite rare pathologies. Thank you.
I am stopping that presentation. I'm really sorry for the audio, but it was a wonderful case presentation of a cervical facetal cyst which was removed very delicately, and it was targeted like an interlaminar disc surgery in a uniportal method. So I think, Anand, that was a wonderful presentation. I really apologize to the panelists and to the attendees for the poor audio, but I felt that it was worth playing this particular video. Now I invite our next speaker, Dr. Seok Bongjung from South Korea. He is wonderful UB spine specialist. I think one of the fastest UB spine surgeons I've come across in my life. Dr. Jung, it is our honor and pleasure to have you with us. Please start your screen share and let us hear your work, sir.
Thank you.
Please start your screen.
Can you hear?
Yes, we can hear you, sir.
Yeah, thank you. Good evening. It is a real honor to give a presentation at the symposium. I am Seok Bongjung, orthopedic surgeon in Jinju Hospital in South Korea. What I'd like to talk about the multi-level posterior lumbar interbody fusion biportal endoscopic technique, 30-degree scope. As you can see at the below, the biportal endoscopic surgery has a lot of advantages, especially in biportal lumbar interbody fusion. There is no transfusion and quick recovery and no infection. You can perform these following operations using this method: lumbar and thoracic decompression surgery, and lumbar discectomy, and lumbar interbody fusion, and cervical and discectomy, cervical decompression and discectomy. Let me start by looking 5 different spinal surgery with biportal technique. This picture shows the lumbar L45. The video on the right shows the overview of the surgery. The operation time is around 27 minutes. This picture shows the foraminal disc herniation L45, right side. On the right shows the overview. It takes about 30 minutes. This is SAP. This is root, existing root, disc space, dissected, remove the disc. This one is decompression in stenosis. Left one is pre-operate. Middle one is decompression state. This is a short clip in stenosis. It takes average operation time. It takes 38 minutes. Cervical prolapse and discectomy. C67 left side disc herniation. It takes 40 minutes. Laminotomy, phlebectomy, and dissect the annulus, remove the disc material. Lumbar interbody fusion, 80 minutes. Left one is spondylolisthesis lytic. Middle one is post-operative X-ray. This video is a case insertion. Biportal surgery was performed from 2015 to 2020 in 1,936 segments. Among them, lumbar stenosis 908, lumbar interbody fusion 181. Total 148 patients underwent biportal interbody fusion. Among them, 150 patients were on one level fusion, and 30 patient is two level fusion, and 3 is three level fusion. For ambulation, one level post-operative 1 day, 3 level post-operative 3 days. Mean surgery time, one level is 1 hour 25 minutes. 3 level is 2 hours 50 minutes. We had only 2 patients have transfusion. One is the patients who have liver cirrhosis on the one level. The other person is the patient who takes anticoagulant in the 2-level fusion. This picture shows the open surgery. Left one is 3-level fusion with 3-5 transfusion. Right one, and the picture in the middle shows severe scoliosis and post-operative state with 3-5 transfusion. Left X-ray picture shows the spondylolisthesis. Right one is post-operative X-ray. It took 1 hour 15 minutes, and hemoglobin level was decreased from 13.4 to 12.3. Pictures on the left side show the stenosis. Right one is post-operative video is a shock clip of the this surgery, laminotomy, and facetectomy, and medial facetectomy, remove the bone fragment, flavectomy, discectomy, and the cage insertion. Before inserting the cage, we have to have endoplate preparation, and then we graft the local bone into the disc space. This video shows the local bone graft through bone marrow. This picture of the surgery, and the picture at the right corner shows the surgical wound after interbody fusion. We shortened the video of the whole procedure of the lumbar interbody fusion. Maybe it takes 4 minutes. Stenosis and cephalad and lateral partial laminotomy with half protective ball and the calcium punch. And the coagulation with the atherocare. With the chisel and osteotomy. Medial facetectomy and laminectomy. Using the straight mosquito, remove the bone fragment. We can use this bone for bone graft. total facet, medial facetectomy. Remove the bone. With the calcium punch, remove the remnant bone. Removal of ligament flavum. Ligament flavum is being removed with calcium punch. You can see the dura and the epidural space. Change the portal side. Rotate the right source 108 degree. You can see the contralateral side. For sufficient decompression, we remove the contralateral ligament flavum. You can see the contralateral lateral recess and the traversing root. Disc space dissect the annulus and the disc space preparation with the Remo. And sufficiently, we remove the disc material in the disc space for good fusion. Sometimes we can use reverse current for sufficient discectomy. This is a reverse current. After disc space preparation, local bone graft into the disc space, and this is disc preparation. After preparation in disc space, you can see the disc space and plate. After bone graft, and then cage insertion. Triangulation is a basic skill for this operation. You need to have the tip of both scope and the instrument meet at the top of the triangle. And many biportal surgeons use 0-degree scope, but 30-degree scope has a wider view, as you can see it in this picture. It shows that 30-degree scope makes the field of view wider on the same patient and the condition. Here is the video comparing 0-degree scope and 30-degree. The first is 0-degree and then 30-degree. This is 0-degree. This is 30-degree. 30-degree make a wide view of tops, bottom, left, and right. So 30-degree scope has many more advantages than 0-degree scope. Especially it easy to do stenosis and by the fusion surgery. If the portal position is a little off, you can cover it with the 30-degree scope. Especially for beginner, I strongly recommend the 30-degree scope because it is very difficult to change once you get used to the 0-degree scope. Skin incision and approach is a very important factor to make it succeed. Especially for beginner, for discectomy and stenosis, two skin incision are each located above 1 centimeter, below 2 centimeter from the lower lamina of the lower margin of upper lamina. For lumbar interbody fusion, two skin incisions are located above its pedicle, and a little more lateral than discectomy. For foraminal approach, two skin incisions above the transverse process. and much more lateral. Grip in the right region, standing on the right side of the patient, you can must grip the working or distal portal with the left hand because the slope of the lamina lies toward to distal part. In case of stenosis or fusion surgery, sometimes you can change the location of a portal for sufficient decompression of hard to reach places. In other words, you should be able to use both hands in the walking portal. For laminectomy, I use a half protective ball to reduce the damage on the opposite side. Punch, we use the calcium punch to remove the remaining bone from the lamina. We also took a video for your better understanding. Here I grip the walking portal with the left hand. Here is the working portal. And right side circle. Outflow water and educate
is on. Dr. Jung, I think you got cut off from us. If you could start again, please.
And please unmute yourself.
Hello. Dr. Jung.
Unmute yourself, please.
Unmute.
Dr. Jung, we cannot hear you. Please unmute yourself. In the left-hand lower corner of your screen, press on the mic button to unmute.
Can you hear me?
Yes, we can hear you.
Yeah.
Please screen share and restart your presentation.
Okay. Director workers keep the patient under observation if it is under 5 millimeter. But if it is over 5 millimeters, then we. Sorry.
Please share your presentation, sir. Screen share. Go to screen share and restart your presentation from where it got cut off.
Restart?
From where it has got cut off. Your presentation has got cut off. Please restart from where it stopped, sir. Start ahead.
Restart?
Yes, Dr. Jung, there was an internet problem, so your video got cut off. So you can
From
restart your video from where it got cut off.
from the beginning?
No. From where it got cut. From where it got cut.
Okay. Dural tear?
Yes, dural tear.
Okay. Okay. When dural tear occurs,
I think you were on the right-handed approach. You were talking about right-handed approach.
You have to share your screen, sir. Your screen is not being shared. Anand, can you please guide Dr. Jung?
Yeah, Dr.
your
Jung.
video? This video?
Yeah, just share your screen first. Go to the central lower part. You will see a green mark, share screen.
Yeah.
The green up arrow, just press that button.
Can you see my presentation file?
No, we cannot. You need to share your screen.
Cannot? Wow.
Go to the lower central part of your screen. There is a green button, share screen.
Sorry. Sorry. Can you hear me?
Yes, we can hear you, but we cannot see your presentation.
Okay.
You need to share your screen.
Okay.
That's correct.
Yeah, thank you. Okay. This slide?
Yes.
Okay, I restart. I can restart. Okay. Great. In the right region, standing on the right side of the patient, you must grip the walking or distal portal with the left hand because the slope of lamina lies toward the distal part. In case of stenosis or fusion surgery, sometimes you can change the location of a portal for sufficient decompression of hard to reach places. In other words, you should be able to use both hand in the walking portal. For laminectomy, I use half protective covered ball to reduce the damage on the opposite side. We use the calcium punch to remove the remaining bone from the lamina. I also took a video for your better understanding. Here I grip the walking portal with the right hand. L45. Here I grip the walking portal with the left hand. Bleeding control. The following are the method of bleeding control: hypertensive anesthesia, care and radiofrequency, continuous outflow of water, adequate hydrostatic pressure. In cervical case, I use 30 mm HG. in lumbar surgery, 40 millimeter HG. When duratio occur, we keep the patient under observation if it is under 5 millimeter. But if it is over 5 millimeter, then we can stitch it up with 7.0 directly. This is video. Stitch it up with 7.0 nylon. This picture shows the decompression in spinal stenosis at the ipsilateral side. This picture shows the sufficient decompression in the contralateral side. You can see the facet joint and the lateral recess. Middle one is through the fluoroscope. This is the mimetic diagram of inserting the cage. Remove the laminectomy, facetectomy, cage insertion. For interbody fusion, when inserting the cage, be careful of upper level exiting route. You can see the L4 exiting route, L4 traversing route. Here is disc space after cage insertion. This picture on the left side shows the patient who got the surgery, and 5 years ago he underwent one spine surgery. MRI shows the record and the severe stenosis. This video the process of the cage insertion. Left lower post-operative X-ray 3-level fusion. And 65 male patient, 3 for stenosis, 5 lytic spondylolisthesis. Middle one is post-operative X-ray. This is a video. Medial facetectomy, disc space preparation, cage insertion. 75-year-old female patient, severe spondylosis and 3, 4, 5, 5, 6 stenosis. This sagittal MRI is, you can see the severe state. This is post-operative 3 months. After 3 months X-ray, shortly. Okay. This picture of the wound in 3-level fusion with biportal technique, and the right one shows the scar 2 months after the surgery. Left one, okay. Left one is pre-operative MRI. Middle one is post-operative MRI. And right one scan, which apparently. Here is the chart showing the various level of proficiency and their progression. I would urge beginner to perform as many discectomy cases as you can before performing cervical or interbody fusion. Biportal endoscopy multi-level lumbar interpedivision, a lot of advantages. This surgery would be a good surgical technique for multi-level lumbar interbody fusion. Okay, I represent Endovision as KOL, and I currently am training doctor all around the world who would like to learn biportal spine endoscopic technique. Thank you very much for your understanding. I hope seeing in Korea after end of the COVID state. Thank you very much.
Thank you. Thank you so much, Dr. Jung. It will be a pleasure to visit you in Korea someday.
Yeah.
It is our pleasure to have you. And now I will be sharing the screen for our next participant, Dr. Sang-Kyu Son, Master Sang-Kyu Son, as he's well known in Korea. And he's one of the foremost proponents of the UB spine technique. So I will be sharing the screen now, and I will be sharing his talk to you.
Hello everyone, I'm Dr. Song from South Korea. Today, my topic is can the endoscopy replace the microscopy in spinal surgery? I commonly searched my interest in Google. I searched minimally invasive spine surgery. So many hospitals, so many society concerning about minimally invasive spine surgery. Also, they have own unique technique. This paper published in 2015. This paper said the failed promises of minimally invasive spinal surgery. They say same risk of traditional open surgery, also no track record of improved outcome. But recently, this paper, below paper in 2019, this also saying shift toward minimally invasive spinal surgery because there are so many evidence of feasibility, efficacy, safety, and value compared to traditional approaches. This paper published in 2020, this paper is the review of minimally invasive lumbar decompression. The author said after failure of conservative treatment, their first choice is minimally decompression, also good result. What considerations for the shift towards endoscopic spinal surgery? In my opinion, there are 4 factors. First, surgical indication, usually same in the traditional surgery. Second, surgeon must deep to learn. 3, minimally invasive surgery for better patient care, for medical business, for hospital and medical company. This paper is the recent 2020. This paper is the result of the microendoscopic spine surgery, MED. This table is the applications of MISS, MED. So many indications yearly, microsurgery and open surgery. Okay, you know that I am UB surgeon. I briefly explain about UB concepts. I already say there are 8 concepts about UB. First, unilateral biportal endoscopic surgery. Second, fluid medium surgery. Third, triangulation is important. Fourth, the first thing is the semi-tubular system and working total. 5, one-hand surgery. 6, lens inside body. 7, lens to be movable and fixed. Finally, 8, pivot movement. Okay, this is my application complications of UBE, cervical, thoracic, lumbar. These all diseases common in my hospital, also in your hospital. First, cervical, thoracic disc, foraminal stenosis, spondylosis with myelopathy, single level, also multiple level, also OP level, thoracic, thoracic disc, soft and hard. OLF, common disease is OLF, also bursting fracture. Bursting fracture is relatively indicated. Lumbar, thoracic disc, central stenosis, foraminal stenosis, commonly central and foraminal combined stenosis, and Parkinson extraforaminal stenosis, spondylolisthesis, and epidural cyst ASD, adult degenerative scoliosis and kyphosis, infection, spontaneous or post-operative infection, spinal tumor, especially only one extradural. Also, revision surgery is common. I compared to microsurgery in cervical disease. Okay, thoracic disc, thoracic disc, commonly in microsurgery, ASD, AIDS, or ACDF is common, but I surgery through posterior approach, posterior laminotomy and discectomy, just like lumbar discectomy. Foraminal stenosis, foraminotomy, posterior foraminotomy, UBE, commonly microsurgery, ACD, also foraminotomy, single level SCM, cervical ULBD in UBE, but ACDF, laminectomy and laminoplasty microsurgery, multiple levels SCM, cervical endoscopic laminectomy, that means laminectomy with sparing the tip of spinous process and also flabbectomy UBE. But in microsurgery, laminectomy, laminoplasty, also transforaminal system. But my case, I have a contraindication in cervical UBE, centrally extruded cervical HNT, severe, very severe OPLA, craniocervical junction problems. This is a diagram, this is my approach, my technique, UV cervical bilateral laminotomy through interspinous approach. Note that cervical region, cervical area is cold region, so there is not enough space to do working. So I approach through interspinous approach. First, I drill out interspinous area, after then bilateral laminotomy. This is my UBE, cervical bilateral laminectomy through interspinous approach. This is my technique is for multiple level SCM or OPLM. This technique is cervical endoscopic laminectomy. That means first the laminectomy with sparing the tip of spinous process and also flabbectomy. Finally, this called the full decompressed. This here. Okay, this case is cervical 2, 3, 4, 5 OPLM with myelopathy, but this I approached. I operated endoscopic laminectomy with sparing the tip of spinous process. You can see here, preoperative, post-operative X-ray, and also MRI, full decompression, and the sparing with sparing the tip of spinous process. This is my endoscopic laminectomy. Also, I compared to microsurgery in thoracic disease. OLF to thoracic socket to have this common disease. For OLF, I approach through translaminar approach. That means keyhole laminotomy and removal of both bilateral OLF in microsurgery common to do total laminectomy. Also, for thoracic socket, disc, I approach through transforaminal also towards pedicular approach. Moving in microsurgery, common through lateral extracapital approach or total laminatum. Part 4, thoracic hard disk, I approach through transforaminal approach or hemi-laminatum, moving ipsilateral total facetectomy, percutaneous fixation, also percutaneous contralateral posterior fusion. In microsurgery, lateral extracapital approach, also total laminatum. Also, I have a contraindication of thoracic. First, severe OPLA tumor, intradural or aggressive tumor, also infection is contraindicated. This is the diagram for translaminar approach for OLF removal. This is laminar. 10 laminar. I approach, I make a keyhole. Also, I approach the smooth translaminar approach this time. So this is the operative, post-operative approach. This is post-operative showing full decompression after removal OLF. Also, this case is OLF very severe, central or foraminal extended. I approach the through translaminar approach. Also, I surgery endoscopic removal through translaminar approach. This is a preoperative, post-operative MRI. You can see here full decompression, very clean, or damage or fault. This is T1112 hernia disc with myelopathy severe, huge disc. I approach the through translaminar or transforaminal approach, discectomy. This is the preoperative and post-operative. Okay. Also, I compare to microsurgery in lumbar spine. It's hernia disc, laminotomy, and discectomy. In UV burn, I have many approach types. You know that there are so many types of herniation disc. So, common ipsilateral approach, contralateral approach, commonly also transforaminal approach. In microsurgery, commonly one type laminotomy and discectomy. For central stenosis, ULBD, endoscopic ULBD, also microscopic ULBD. Foraminal stenosis, foraminotomy, also two-time ipsilateral approach, also contralateral approach. Conventional foraminal microsurgery. Especially for L5 extraforaminal stenosis. I have so many cases of extraforaminal stenosis of L5. I approach commonly transallar approach. In conventional surgery, commonly foraminal approach. So commonly far out extraforaminal area may be incompletely decompressed. So I like to approach through transallar approach, foraminal and extraforaminal, entering middle exiting, special exiting zone. Full decompression is important, I think, in L5 foraminal stenosis. Spondylolisthesis, instability, and commonly fusion using UV, commonly called UV fusion only, or there are two types. Classic type is in flash case also. I have so many revision surgery. For revision case, I commonly approach through transfacetal approach. Also, in microsurgery, two-leaf, three-leaf, four-leaf, one-leaf, three-leaf, or so many types. For extra epidural cyst, endoscopic removal, also open removal in microsurgery. ASD also, I have so many cases of ASD in my hospital or other hospital transferred to me. So So for ASD, I commonly endoscope fusion only with the metal chain in UV endoscopic fusion. Also in microsurgery often fusion metal chains. Also recently I tried to overcome the adult degenerative scoliosis hypothesis. I tried to surgery, short segment correction and endoscope fusion only, commonly L2 from L2 to S1 or L4 to S1. But in microsurgery, long segmental correction and fusion, high thoracic or high thoracic to iliac or low thoracic to iliac. For impatient, endoscopic debridement and irrigation same as open debridement. For spinal tumor, okay, the only one indication is the extratubular and small tumor in UV, but in microsurgery, all kinds of tumor is possible. So I had a contraindication of lumbar UV, high-grade spondylolisthesis, aggressive infection, almost all spinal tumor, severe long segmental scoliosis. Okay, I show you 4 types of foraminal approach above L4-5, ischemic type, accept type. For L5 S1, ischemic type, Allah type. For Allah type, for extraforaminal and combined, this one. Okay, this is a diagram for extraforaminal stenosis. Here, yellow color is root. Okay, I always emphasize the full course of root. This one L5 pedicle medial part. This one S1 pedicle lateral part. This one S-shape learning is important. So this one height is the lumbosacral ligament. Okay, and here, okay, vertebral body disc 2, lumbosacral ligament. This is red color is the important compression factor in far-out syndrome L5 foraminal extraforaminal stenosis. This one. This one, okay. If you want full decompression, you must try to remove the red ligament. This is abnormal ligament from anchoring on radiating ligament in normal spine. But in L5 extraforaminal stenosis, this ligament may become very deep, very hard. So this ligament participate of dividing two partition, two blocks. So you know that the L5 root go out through lumbosacral tunnel. This ligament divide the upper part, lower part. So root learning through lower part. If you want to full decompression, you must remove this abnormal ligament. That is important, I think. Okay, this is L5, so right extraforaminal stenosis. Acute diagonal important L5 root symptom, Allah sign, valve bend in MRI. Okay, here this one say type U. This is body to disc to ligament. This area, leg is lumbosacral ligament. This ligament is valve bend, abnormal ligament. This ligament divided two parts of lumbosacral tunnel. After removal, this valve bend, full decompression, one tunnel is important. Okay, this Allah black. This Allah is the black. This black color is the sclerotic change in normal spine, normal bone. So we call this black color is Allah sign. This Allah sign is blue for extraforaminal stenosis. Also, this one Okay, this one, Allah sign, power band. Okay. Finally, I always emphasize the fusion surgery, endoscopic surgery, everlasting challenge of all kinds of fusion surgery. 4 types. First, complete neural decompression. Second, solid fusion, good lordosis, global spinal balance. Also, minimal invasive surgery to save the posterior element, including parasympathetic. This is usually for L5 so degenerative sclerosis. You can see here, good lordosis, also solid fusion. This is the usually for L5 Smith, good lordosis, also solid fusion. This is the result of UV fusion, usually the result. Okay, you know that this paper is the Scoliosis Research Society swap adult spinal deformity classification. This paper is important to me to make balance of spine commonly sagittal modify. You know that PI minus LL, I want within 10 degree. Also global alignment SVA 4 millimeter. Also pelvic tilting, thus below 20 degrees. This is my purpose of the balance of spine for my urinary case. Okay, this is the case. This is the case. Is the adult degenerative scoliosis with multiple postforaminal stenosis, also with the previous L5 on laminectomy state. You can see here the degenerative scoliosis kyphosis. This is the preoperative, postoperative. Also, this is the balance, good balance. Also, here, parameter, change, good result here. Also, this one, SVA, or below, this is SVA is 30 millimeter. Okay, good result. This patient also comfortable in postoperative period. Okay, I proposed the double cage for fusion and lordosis. This diagram is I use two case transverse line. Anterior is small, posterior large. Anterior fully case, posterior totally case. This one here. Also anterior height, posterior low height. This case is more harvest bone also to make more big disc angle, also to make the good lordosis. Also this axial view is so many harvest bone, this one. Okay. Okay, I summarize. Okay, this one learning curve is not steep for you beginners. So also technical surgical basics for UV already exist in spine surgeon hands. UV is based on conventional surgery principle. First, nearly same anatomy approach. Second, near same instrument, nearly same system of arthroscopy. Just in case of UV is not eligible during operation, you can easily convert to microscopic surgery. A mere hole could manage something that have been aggressively controlled by heavy spade. This one, okay, this one surgeon as the heavy machine operator, but this one surgeon as a life quality designer. What UV has done in my hospital before microsurgery 95%, but after UVE microsurgery 5%, UV 90%. UV suggests win-win solution for sustainable growth for all participants because it places patient in center for better patient care. In my conclusion, again, do you think that the UV can replace the microscopy in spinal surgery? Okay, you know that history tells the answer. Thank you. Thank you for your attention. Thank you. Bye.
I think we've just heard a wonderful lecture from our dear Master Son. So I think we will now request that we go ahead with our next lecture. And we are really learning a little earlier than scheduled. So can I request Dr. Michael Schubert to start with his lecture, please? Can you share your screen, Dr. Schubert? Dr. Michael Schubert, can you please unmute yourself?
Hello, can you hear me?
Yes, we can hear you, Dr. Michael Schubert.
Can you see my screen?
No, you have to please press the green button and start sharing your screen, sir.
I did.
No, sir, it's not yet being shared. Yeah, yes, perfectly, sir. Perfect.
Now you can start it. You can see
Yes,
this?
yes, yes, sir.
Okay, so everyone can see me. At first, Malcolm, many thanks for your very nice invitation. When I read all the lectures you and all the colleagues you have organized from all over the world, my deep respect for what you have organized. I think it's a lot of work. It sounds very easy. We just make an international conference, Zoom conference. We are living in hard times, and for that, my deepest respect and many, many thanks. Last week, I had a first meeting here in Germany with some colleagues. It was in Homburg Saar, but unfortunately only with 40 or 50 party patients, and it was not that much. Okay, let me start with my presentation. I hope you can see everything. As maybe a lot of people of you know, I do perform endoscopic procedures. Next year, I do it for already 20 years, and I almost have performed 10,000 endoscopic procedures. And with my colleague, Dr. Hoogland, I have published in 2007 or 8 a study with endoscopic transforaminal discectomy for recurrent lumbar disc herniations, but only with a follow-up of 2 years. And now I was looking for something with a little bit prolonged of time, that means in 5 years. And as you all know, it is a lot of work to get all this back to these patients, even if they are satisfied. Normally they don't want to do anything with you as a surgeon, and then you ask them and to find the right email address and all the things. But at least I could finish it. And now let's start the presentation. So this is my disclosure. I have my own instruments called by Med2B. It's called Septovation. So if anyone is, say, supporting me, or also because, as you know, it costs a lot of money to do in scientific work. So at first, let me start. What was the purpose of the study? It was to evaluate the effectiveness and the complication rate of an endoscopic transforaminal minimal invasive foraminotomy and discectomy for recurrent lumbar disc herniations independent of size, location, and spinal anatomy. So the outcome measurements, it have been a questionnaire including McNabb, BAS, and the follow-up was always next day, 3 months, 1 year, 2 years, and 5 years. Something very important, almost all operations performed in lateral positioning of the patient. It was also possible to do it in prone position, but I personally, for a lot of reasons, I prefer the lateral positioning, because I do all my patients, not in general, I think of almost 10,000 patients, I have maybe operated 2 or 3 patients in general anesthesia. I do normally regularly in analgesic sedation, and for that it is much easier and more comfortable for the patient and for the anesthesiologist to interact during the operation with the patient, and for the patient it's more comfortable in a lateral position. That's my experience. And here you see an animation I have created for my patients. I don't do it full endoscopic. The procedure is performed, I do perform under X-ray control, and then with the instruments of septovation, I enlarge the neuroforamen until I reach the ventral epidural space, and under endoscopic control, the discogenic will be removed. These are, for example, typical pictures. What you see in the beginning, yes, you will remove first the discogenic. You see on the video what's running on the left upper part, and at the right lower part, there's a free nerve root. After it, I remove also from the inside of the disc, because what I do perform is an outside-in technique and not the inside-out technique. Here is another nice case. It was a lateral recurrent discogenic compressing at the upper part. You see the compressing nerve, and here you see the extruded disc still covered from the skin, not really angulated, and now you can see this discogenic is coming out. This part was very, let me say, a bit more painful for the patient. This is the outside video, and in that time, a colleague from Netherlands, Dr. Manu Kunborg, he was with me. It was a lateral discogenic, at least very easy to perform, and it took me less than 10 minutes because you do not have to do that much. Okay, very nice. So here I will show you now some examples. This was a status after open microscopectomy, hemilaminectomy, as you may see on level L5S1 on the left side, and with I can't point it with my. No, I can't point it. But as you may see on the MRI axial view on the right upper part, this is a really huge bony and pars defect with a lot of scar tissue. And at the lower part, you see my intraoperative control of the forceps to make sure that I'm at the right spot with my discogenic, with my forceps. Here you see it was a bit tricky. A discogenic compressing in the axilla of the S1 nerve root and a dural sac. So transforaminal, it wasn't that easy. If you perform a transforaminal, you had to do it like you see on the X-ray control in the middle part of the screen. That means I had to perform the procedure a little bit more, not in the caudal part of the neuroforamen, a little bit more up, and with a bended forceps, I could go around the dural sac and remove nicely the discogenic. Here again, an extra foraminal discogenic level L5S1 with the control of the forceps. And here this is a picture with the freed nerve root and the removed discogenic. This is a long time ago, a patient with a cranial sequestrated L5S1 discogenic. Some colleagues, they think you have to do it transiliacal. For me, there's no need to do it transiliacal. Also, this herniation I have removed transforaminal. And here you see again the control of the forceps. So I'm at the right spot. Just the approach is not normally transforaminal. It is at level L5S1 around 10, 12 centimeters lateral. I have performed only 7 centimeters, and this is the reason why I could reach the cranial secretory disc herniation at level L5S1. Okay, now we come to this scientific work. At first, very important, what have been the inclusion criteria. So I have chosen patients with the recurrences that developed as a new disc herniation with at least 6 months pain-free interval at the same level, regardless type of operation and numbers and pre-operations, primarily radicular symptoms with an acute onset, signs of nerve entrapment, correlation neurodiagnostics and symptoms, correlating positive MRI and CT. I think like you all do it. And I perform the operation only in one level. Exclusion criteria for the study: herniation more than one level, patients younger than 18 and older than 80 years. Okay, in the conclusion, that means 576 patients have been operated endoscopically for recurrent herniated disc herniations in the time period of 12 years. 543 patients fulfilled the criteria of the studies. 354 had in previous microscopic disc surgery. 189 had in previous endoscopic spine surgery in our center or somewhere else. The follow-up at 5 years was 439 patients who responded to this study. And the the division of female and male have been 29, almost 30% female and 70% male patients, and the average age was almost 50 years. These are the typical levels I have performed. The majority of the disc herniations we always see at level L4, 5, and then 5S1 and the rest. So now let me come to complications or recurrence rate after a recurrent herniated disc operation again. That means 9 patients, almost 2.1% had again an early recurrent disc herniation. That means less than 3 months. The all-over recurrence rate of all these patients have been 9.3%. And that means 41 patients of these 439 patients. 34 patients have been treated for a recurrent herniated disc in our own center. That means the second recurrent disc operations. 31 again in an endoscopic transforaminal discectomy or procedure, and 3 patients only in a microscopic decompression. 7 patients have been treated elsewhere, 1 with endoscopically, 1 fusion, and 5 microscopic decompressions. That is what they have reported. And no case of infection or disease have been seen. Complications, sure. I have seen 3 nerve root irritations. That means a dysesthesia and low-grade paralysis. I have seen intraoperative dural leakage, but it was never giving a problem or needed any kind of revision surgery for me. 5 patients reported an increase of numbness, no wound infection, and not 1 nerve damage have been seen. Results after 5 years on the satisfactions patient's own judgment for excellent and good results means for excellent and good results, almost 87%, almost 90% reported an excellent and good results. So I think it's a very, very good result. If I ask my patients for loss of leg numbness, so there was an vanished or better in almost 84%, only unchanged in 16%, and worsening thanks God, only in 0.7%. We come back to the strengths, leg strength. So vanished or better results, almost the same like with the numbness in the leg. 87% reported an excellent result, and unchanged, unfortunately, in 12%. And for McNabb, an excellent and good result I could see in 80.7% of all my patients, only not satisfied and in 3%. If you look to the VAS of back pain and leg pain, there's almost the same good results of 6.6 points what had in patients who reported in better outcome for the back pain, and for the leg pain 7.2. Results after 5 years, something very important I like to ask my patients is sportive activities, not only going back to work, because in Germany we have a health care system that if you are sick, you get your money for a long time supported, and you get your money from the government for a long time. But something very important for the patients is back to daily activities and sports. So preoperative, 256 patients have been active in sport. Postoperative, some 12 patients, 21 patients reported more to do to be active in sports. Unfortunately, from these all patients, 54 patients never returned to their sport activities they did before. After 5 years, if I ask my patients, if you would undergo the same operation method again, I think that's what you all know. A lot of patients, they will report, yes, I would do it in this procedure again. It's almost 98%. That means in a conclusion, like for normal endoscopic procedures, that this study demonstrates again that the endoscopic transfemoral discectomy or decompression has a good, also now, because this was a 5 years follow-up study, a good long-term efficacy for recurrent herniated discs, or might even exceed the results of a microdiscectomy independent of size of the herniated disc and location of spinal anatomy. Thanks for your attention. Okay. Can you hear me?
So much, Michael. Wonderful as usual and amazing as usual. And Septovation, believe me, is a wonderful product. I have been using it myself when you had visited India and with Alex. So
yes, we miss you guys personally.
Thank you. Thank you so much, Michael, as usual. You are a dear friend and a brother.
Thank you very much, Malcolm.
Hope to see you soon again someday.
Yes, hope
this post-COVID world with a real conference and some real fun.
Hope we all see us again. Yes. Okay, it was a wonderful time. You've been one of very great hostess we had in India. So hope Corona will pass away as fast as possible, and we personally see us again.
Yes, thank you. We shall meet again. Can you please now stop sharing your screen, sir? Can you stop sharing your screen?
Yes, just a second. I'm sorry.
Now we have with us Dr. Hyo Dong-hwa. He is a master of UB spine surgery from South Korea. It is my singular greatest pleasure and honor to invite him to now start his presentation. And we are going to be privileged to see his unique work in contralateral UB surgery. So, sir, I request you to please start your presentation. Welcome again, once again, Dr. Hyo Dong-hwa. Welcome, sir.
Well, thank you, Chairman. Yes, thank you for invitations. So,
Please share your screen, sir. Thank you, sir.
Okay. Okay. Can you see then my presentation file? Okay. Yes, I'll start. Thank you for invitations. My name is Dong Aom. I'm a neurosurgeon in South Korea. Now I work in the Endoscopic Spine Surgery Center in Seoul Hospital in South Korea. Today's my topic is contralateral sublaminar approach using the biportal endoscopy approach for the lumbar pathologic lesions. The advantages of the contralateral approach is first is the better view of the existing root and foramen, and the better views we can see it clearly, see the medial border of the pedicle, and we can reduce the bone work during the interlaminar approach, and we can minimize the facet joint injury during the posterior endoscopy approaches. So the indication of the contralateral sublaminar approach using the biportal endoscopic approach, UBE. The first is the foraminal stenosis and HMP and migrated disc herniations, and especially the better work in the upper lumbar lesions, and also we can remove juxtafacet cyst using contralateral sublaminar approaches. So today's my presentations focused on the surgical technique of the biportal endoscopic sublaminar approaches. So just with tilting the endoscope, we can easily see the contralateral approach without any maneuvering. So just these 2 points is routine, the skin incision points of the routine UBE. So however, the target, if we main target the external root and upper foramen, we have to modify the two skin incision more caudally. And if main target is the traversing of root and lower foramen, we have to make the two skin incision points more the cranially like this. So the incision area modification is very important for the easily approach for the foramen contralateral. So I firstly see the base technique. So the main target is the contralateral traversing the root, and you can see this is the contralateral ligament flavum. I firstly divide the superficial and deep layer. And firstly, I remove the superficial layer of the ligament flavum. Now I drilled at the lower lumbar lamina and upper portion. So you can see the border, the lower border, and we can easily detach the ligament flavum from the lower lamina upper portion. And we did a small laminotomy. We can clearly detach contralateral ligament flavum. Dissect the area of medial border of the SAP. You can see the complete dissections of the contralateral ligament flavum. We can easily and safely remove of the contralateral ligament flavum. You can see the contralateral traversing of root, and you can see the medial border of the pedicle. The final view, this is the base technique. And the second is the contralateral external root decompression. So this is the superior articular process of a tip. This is the foraminal ligament, lateral sleeve of the ligament flavum. The SAP tip is the main landmark of the contralateral approach. Firstly, I partially remove the tip of the contralateral SAP, and you can see the contralateral foraminal ligament. We can easily detach and dissect and remove the foraminal ligament easily without any injury of the neural structures, and the removal of the hypertrophied foraminal ligament slowly and carefully. And you can see the external lobe contralateral. You can see the contralateral lobe root. So dissections more laterally, and you can see the foraminal ligament, and this portion is the contralateral extending lobulus. So I'll remove more laterally foraminal ligament. You can safely decompress and expose of the contralateral extending lobulus. This is portion is the disc space. The main, the surgical landmark is the contralateral SAP tip and foraminal ligament. Now I palpate the medial board of the pedicle like this. So this is the basic technique. And now I show the clinical cases. First case is the foraminal disc herniations. We can easily remove the foraminal disc herniation using the contralateral UV approach. Firstly, we expose the extending lobulus and dissected and the remove of the rupture disc and final view. Now I show the video. So we firstly did ipsilateral laminar dissection and ipsilateral midline laminotomy using diamond drills. I prepare the NSK drill, and you can now I midline laminotomy, right to left approach, and you can see the middle portion of the ligament flavum. This is a contralateral ligament flavum. Now I remove of the contralateral ligament flavum, left side. Partially remove of the contralateral ligament flavum and foraminal ligament. You can see the extending lobulus here. So I more laterally, more superiorly remove of the ligament flavum, and you can see the contralateral. This is the superior articular process. Now I remove the foraminal ligament. Now you can see clearly see the foramen and the extending lobulus, maybe ganglion here, and you can see the unmigrated foraminal disc herniations. So I dissected here and remove here. We can easily and safely remove this herniation without any injury of the neural structure, and also we can decompress the contralateral foramen and extending lobulus here. So there's a final view. If we use the biportal endoscopic surgery, we can very safely surgery, very magnified clear view, endoscopic view. So yes, final view. You can see the contralateral nerve root and medial board of the pedicule. So I move to the next cases. So now I show. So this patient, the left side, foraminal disc herniations, you can see. So I did the contralateral sublaminar approach. First laminar dissections here, and after I did a midline laminotomy using the diamond drill. Just very narrow laminotomy. Contralateral sublaminar bony decompression. And now I remove the contralateral ligament flavum and mid portion of the ligament flavum. Now I partially remove of the contralateral ligament flavum, and you can see the severe adhesion with the disc herniations, and you can see the disc herniation particle under the extending lobulus. Now I dissected the disc herniations below the extending lobulus, and now I remove of the rupture disc herniation firstly, and also you can see the next large size of the foraminal disc herniation, and you can see the extending lobulus L3, yes, the final view. So, and the second case is a male patient complained of the L2 term pain. You can see the unmigrated disc herniations at the L2-3 area. So you can see the foraminal disc herniations as well as central stenosis. So my decision is sublaminar contralateral approach. Now I firstly did the medial laminotomy. This procedure, very familiar procedure. If we do the unilateral laminotomy, bilateral decompressions using one portal or biportal, this approach is very familiar approach. So now I did the extended upper portion of the laminotomy and contralateral ligament flabum removal. Also, you can see the rupture disc herniations. The herniated disc particle adhere with the extended level 2. So I firstly dissect, and you can see the disc herniation particles here. This approach is very familiar approach. If we treated the spinal stenosis, we frequently did this approaches, just modification of the contralateral approach. Now I remove the foraminal disc herniations firstly, and the extended lobe root was completely decompressed here, and also this patient also have the central stenosis. Also I did the decompression, extended lobe root as well as the traversing lobe root, like here. The final view, I did the 2 root decompression using the contralateral approach, L2 root as well as L3 lobe root. So after surgery, you can see the complete removal of the foraminal disc herniations as well as the resolve of the central stenosis after surgery. So I showed another cases. This patient down migrated disc herniation at high upper lumbar area. I did the sublaminar contralateral approaches. So right to left approaches. So I did the midline laminotomy, left to right side midline laminotomy here. This procedure is very familiar approach when the endoscopic decompression of the spinal stenosis. So this is the mid portions. Now I remove of the contralateral ligament flabum here, and you can see the contralateral S3 lobe root, and you can see the rupture disc herniations, and you can see the S3 lobe root, and also another. I remove of another particles, second particle, remove of the foraminal disc herniation, down migrated. Also, you can see the medial border of the L3 particles, and also I remove of the rupture disc particle again. Also, I explore and dissect it under the contralateral S3 lobe root, and also remove another disc herniation. Also, you can see the laminar disc particles. Big particle was also removed. The fragmented, yes. Also, you can see the S3 lobe root and the medial border of the pedicle. The complete decompression of the contralateral S3 lobe root, and I can completely remove the foraminal disc herniations down migrated. So foraminal stenosis is another good option for the contralateral sublaminar approach. You can see the central stenosis as well as foraminal stenosis. So you can see the foraminal stenosis as well as severe central stenosis. So my decision is the 3 root decompressions. Many surgeons recently frequently done the unilateral laminotomy bilateral decompressions using the biportal or the uniportal. So firstly, I did the right side L5 lobe root decompression. I did the lateral recess decompression firstly. So now I removed the right side hypertrophied ligament flabum first, and lateral recess decompression first. And you can see the L5 lobe root. And I did the contralateral ligament flabum. And now I remove of the remnant the contralateral ligament flavum and bony decompressions. So this process is very familiar to the endoscopic spine surgeon for the treatment of the central stenosis, and I did the more cranial decompression for the external lobule. You can see the L4 external lobule here, and this portion is the tip of the SAP. SAP tip is very important landmark, and also I remove the tip of the SAP and the contralateral foraminal ligament, and now I decompress more laterally. L5 luter, L4 novoluter, left side, decompressed. L4, L5 novoluter, left side. And finally, you can see the right side L5 novoluter. I did the triple luter decompression using the biportal endoscopic surgery. Left side L5, right side L5, left side L4 novoluter decompression using single approach. So after surgery, the foraminal stenosis and central stenosis were resolved after biportal endoscopic surgery. Also, the cestal view, also you can see the decompression of the foramen after surgery. So this patient has the age of very old. Her condition is very poor due to ischemic heart disease. You can see the severe foraminal stenosis and the central stenosis. So maybe this patient is the indication of the fusion, such as the tulip or olive. So, however, these patients cannot receive the fusion surgery due to poor medical illness history. So my decision is bilateral contralateral approaches for the forward to decompression. So firstly, the left to right side approach. So this is contralateral ligament flavum hypertrophied. So dissection. This approach is recently very similar approach for the endoscopic spine surgeon. So I did a small laminotomy using the drill. Yes, L5 upper portions lamina. So I remove of the hypertrophied contralateral ligament flavum firstly. Dissection between the plane, the dura and the ligament flavum. And you can see the L4 external lobule, and you can see also the rupture disc herniations here. So I did a dissection of the foraminal disc herniation from the external lobule, and I carefully remove of the foraminal disc herniations and adhesion tissue firstly. So the rupture disc herniations severely adhere to the L4 external lobule. I can the foraminal disc herniation without any injury of the external lobule. So I did the decompression, the right side L5, L4 root 2, and L5 novelty here. So firstly, I did the 2 root decompression. I moved to the contralateral side. The same procedure was performed using this approach. We can minimize. You can see the severe adhesion, the dura between the ligament flavum. So I removed the hypertrophied ligament flavum. Firstly, I decompressed the contralateral L5 lobule here. You can see the L5 lobule here. And then move to the more cranially for the external lobule decompressions here. So I now remove the foraminal ligament, the lateral sleeve of the ligament flavum here. So dissections very carefully. So firstly, careful dissections between the ligament and the dura. You can see the foramen L4 lobule here. So we have to remove more cranially for the complete decompression of the contralateral external lobule. So you can find a view, L4 W2 here, L4 W2 here, L5 W2. I did 4 root decompressions using the bilateral contralateral approach. Comparing the preoperative MRI, you can see the complete decompression of the central canal as well as foramen. So after surgery, you can see the foraminal decompression as well as the central stenosis. The final case is the facet cyst removal, such as the ligament flavum cyst or synovial cyst. This man complained of the right leg pain. You can see the foramen synovial cyst of the L5. The contralateral approach very useful for the removal of the synovial cyst. You can see the synovial cyst, the normal dura. After operations, we can completely remove of the contralateral synovial cyst. And now I show my video. So this patient complained of the right leg pain. You can see the calcified synovial cyst. So my decision is the contralateral approach. So the calcified synovial cyst severely adhere with the dura. Firstly, dissection is first. We have to find the surgical dissection between the synovial cyst and the dura. Now I'll remove of the calcified synovial cyst. The calcified mucinous components was the drainage out. This approach is very familiar approach for the biportal endoscopic surgeon as well as the PSLD surgeons. You can see the transforaminal route. After dissection is first, removal of the cyst is next. So I did now the remnant cyst wall using the endoscopy equipment. So you can see the very severe adhesion cyst to be the contralateral transforaminal route. Dissection first and removal is next. We can completely remove the cyst lesion without any injury of the dura and nerve roots. The final view of the biportal endoscopy removal of the synovial cyst. So you can see the after surgery, you can see the complete removal of the synovial cyst. The case is the unilateral approaches, bilateral discectomy. So this patient received the fusion surgery 2 times, about 10 years ago and 1 year ago. However, his leg pain occurred again. So you can see the bilateral down migrated disc herniations. Also, you can see the bilateral disc herniations here. So also you can see the severe stenosis. What is your opinion? This patient refused the fusion extension surgery. So this patient received the fusion surgery 2 times. I do not want to fusion surgery again. So, my decision, also you can see the bilateral disc herniations as well as the stenosis. So my decision is unilateral approaches, bilateral discectomy, left side approach. You can see the L2 lamina. This approach is very familiar approach for the biportal endoscopic surgeon or the PSLD surgeon. So now I did ipsilateral laminotomy, and now I dissect the exposure of the lower lamina upper portion. Firstly, I did hypertrophied ligament flavum firstly, and now I did sublaminar bony decompressions using the diamond drill. And you can see the contralateral, detach of the contralateral ligament flavum. This approach is very familiar surgical procedure. Now I did the contralateral central canal decompressions. So dissections between the adjacent tissue and the dura. Now you can see the contralateral traversing lobe here. And now I did complete decompression of the central canal as well as lateral recess. Okay, and you can see the ipsilateral. Now I remove of the down migrated disc herniation firstly, left side. Also, this procedure is very familiar approach for the biportal endoscopic surgeon. So down migrate disc herniation is complete removal. Yes, you can see the ipsilateral traversing oblique here. And now I move to the contralateral sublaminar approaches. Also, I remove all the contralateral disc herniations using ipsilateral approaches. Now I move to the sublaminar and yes, and complete removal of the contralateral disc herniations here. Also, I check the axilla portions. Yes, also remove of the axilla. And now I did the anuloplasty using the radiofrequency, ipsilateral, and decompressions, contralateral, and central canal. The final view, and finally I put in the epidural, the drainage catheter after contralateral, central canal, ipsilateral, neural decompression using the unilateral approaches, bilateral discectomy. After surgery, you can see the central canal decompression and the bilateral disc herniations were completely resolved only unilateral approaches. So ASD decompression or ASD discectomy is another option of the biportal endoscopic surgery, especially sublaminar contralateral approaches. So, however, the extraforaminal area, there are the limitation of the contralateral approaches. So, based on the middle portion of the pedicule, the outside of the area, if the pathologic lesion located, the paraspinal or transforaminal approach is better than the contralateral approaches. So in summary, so optimal indications of the contralateral sublaminar approach, uniportal or biportal, the upper lumbar migrated disc, foraminal disc herniations, foraminal stenosis, cystic lesion, to combine the lesion also very useful the approach. So we can well visualization and we can complete the decompression, extending route as well as traversing lobe route. So these are my articles about the sublaminar contralateral approach using the biportal endoscopy. Thank you for invitation. Yeah, thank you.
I should say, sir, yours was a wonderful talk. You have solved the problems of many of us UB surgeons by your approach to the contralateral decompression, especially for migrated discs, because it usually used to be a problem whether we will be invading into the pars, we'll be causing iatrogenic weakness. So this contralateral sublaminar decompression, seeing the traversing, seeing the exiting route, getting in between the two of them, removing the axillary disc, removing a migrated upper migrated disc, it's a fantastic approach, sir. Thank you very much for sharing this with us. We all are taking home a beautiful lesson from you today. And I'm really grateful to you, Dr. Hyo. Thank you once again.
Thank you.
I will now request the pioneer of UB spine surgery, Dr. Yumjinwa, to start his talk on XTLIF. Dr. Yumjinwa, can you please share your...
Hi, how are you, Dr. Malcolm? Nice to meet you again. Okay.
Welcome.
Okay. Oh my God.
Can you share your screen, sir? Yes, sir. Thank you. Perfect, sir.
So where is the share? Okay. Okay, I'm sorry. I can approach the...
Take your time, sir. Take your time.
Okay.
Screen properly. Yes. Just click on your topic. Yes. Perfect, sir.
Okay.
Perfect. Please launch it.
Okay.
Thank you, sir. Thank you. Please start, sir.
Yes, wait, please. Start.
Please start, sir. Please start.
Okay. Wait, please. Sorry about that. Where is start? So is it okay? Oh my God.
You have to make it full screen.
Okay.
Perfect. Perfect.
Good. Can you see this? Okay.
Yes.
Hi, how are you? Sorry about that. Okay. Nice to meet you. And thank you for the doctor. And special thanks to Dr. Malcolm. And it's my honor. Okay. Today, my topic is endoscopic extreme T-lip surgery for large cage. I came from South Korea. And this browser is Endovision. Okay. Is it possible to put a large only cage under endoscopic T-lip procedure? Let's see. There are various surgical approaches for lumbar fusion, as you know, PLIP, T-lip, X-lip, O-lip, or R-lip surgery. But I think the goal of spine fusion surgery should be like this. Number one is we have to decompress the pathology region, and we have to do bone-to-bone fusion. And if possible, we have to restore the spine balance. For better spine fusion, precise and gentle end preparation will be necessary. Also, a large interbody spacer would be better than small. For balance, proper cage position is very important. Sometimes we use bone materials, autobone on DBM and BMP or I-factor. Well, I did many endoscopic fusion surgeries, but whenever I'm doing that, I feel some limitations. The small cage footprint, the cage is too small. Okay? So I cannot correct lumbar lordosis. Lumbar lordosis correction is not easy. Okay? And sometimes I can't complete end preparation. For good surgical, for good coronary sagittal balance, cage size and cage position is important. Let's look at the cage size first. The bigger cage would be the better. As you know, T-lip cage is width is 11 and 13, and length is 28, 32, and some company made 38 millimeter. X-lip and O-lip cage already produce width 18 and 20, 22 millimeter, and length is 40 and 45 and 50. In this picture, you can see the difference. Next, cage position is very important. According to the Alexander Abusi article, unfortunately, the center of endoplate is the weakest spot. You can see the endoscopic T-lip postoperative MRI view. This is not bad, but the cage is very small. So I use the banana cage, but not good, I think. But this is actually cage. Okay. I think a good cage position should be like this. In the AP view, the cage from pedicule to pedicule. In the sagittal view, the center of the cage should be anterior to the center of the body. For better spinal fusion and correction, among this surgery, I think the O-lip surgery is the best. But O-lip surgery, whenever doing an O-lip surgery, we have to worry about vascular injury and spastic train injury and urinary tract and peritoneal injury. And O-lip surgery is not so easy technique for ordinary spine surgeons, especially in the level of L5-SN level. And we cannot do posterior decompression. Also, we cannot use autobone. For posterior decompression, we need to change position. But some surgeons recently doing this job in lateral position, but it's not easy. So I think under T-lip procedure, because T-lip procedure is familiar to spine surgeon, so if I can put large cage, like or even X-lip cage, would be better procedure. So I reviewed the Cambridge triangle. According to this article, Reed article, L1-2 level, the base is 12, L2-3 level 13, L3-4 level 17, and L4-5 level 18. But there is no data L5S1 level. So you can see the 18 or 17. So early cage, the size is 18 or 20, 22. So I think I can put the early cage at least in the level of L34 and L45 level. So I have to make an operative corridor. I removed facet joint completely. So I extended Cambridge triangle. So I call it length of extended Cambridge triangle. So L34 level may be larger than the 17, L45 level larger than the 18, L5S7 level. Fortunately, the facet joint width is very large. So we can use 18 or 22 large cage. This is an example of a preoperative measurement. I always recommend to check LEK before operation. In this MRI view, L45 level, the average is over 18. L5S7 level, the average is over 20. This is the actual endoscopic view during operation. You can see the extended Cambridge triangle is almost 20 millimeter. So I made an X-TLIP procedure. Under endoscopic TLIP procedure, I have to do total prostatectomy, and I have to use the large cage, same as early cage. And anterior and transverse line of cage will be necessary. And the operative corridor is between the TLIP and X-TLIP procedure. So I call it X-TLIP. Actually, this video made my partner, Dr. He Dong-ah, previous presenter. He's a very excellent endoscopic surgeon. He made this video for me. Okay, this is all about X-TLIP procedure. He's very nice. Okay. Indication of X-TLIP is the same as, I think, the TLIP surgery. I show the cases. Case number 1, 65-year-old male patient, lower pain and left radicular pain. Already he had 6 months ago, he had 6 months ago endoscopic compressive surgery, but there is no improvement. In the MRI, you can see the lateral recess stenosis and L5S and foraminal stenosis here. So this is a picture of the endoperitoneal preparation. So we can get enough bone after total prostatectomy. And this is actually transforaminal approach. You can see the L5 exiting route, and this is medial side, and this is discal space. So I do not have to expose the medial side. So this annula is very hard, so I have to use the Carson Longer. The procedure is the same as open surgery, minimally invasive TLIP surgery, the same as. This is a shaver into the L5S and discal space. The procedure is the same as TLIP surgery. And I put a only cage into the L5S1 interbody space without the root damage. This is only cage. Okay, we can see the root is intact. And this is the postoperative X-ray view. The cage is from pedicle to pedicle, and the rhodotic curvature, rhodosis is not bad. Postoperative MRI, you can see the very decompressed state, and you can see the cage position is relatively good. Next case is a 75-year-old female patient with left radiating pain. diagnosed as spondylolisthesis, L4-5, a preoperative MRI. This is postoperative MRI. You can see the cage location is very good. This is paramedian approach because this patient is L4-5 spondylolisthesis. So I have to decompress the central decompression and contralateral decompression. So I approach the paramedian approach. So procedure is the same as TLIP surgery, laminotomy and total fascectomy. This is L4-5 level. You can see the exiting double here, and you can see the medially, you can see the transverse double here. Already I did the central decompression. And this is steroid. Also, I put a shaver into the L4-5 discal space. And I have to retract the root medially. And I put a trial. I have to check the size, okay? This is 45 and 18. And then I have to put the only cage through the, this is a cage guide. So we have to we made a special instrument for safe delivery of a cage. And this is anterior and the transverse line of cage. So you can see the exiting double here and transverse double here, and you can see the only cage here. Case 3, this is very interesting case. A 75-year-old female patient and low back pain with right leg radiating pain, diagnosed as schwannoma L4-5 level and spondylolisthesis L4-5. So I did XTLIP L4-5 after microscopic removal of schwannoma. A preoperative MRI, you can see the schwannoma L4-5 level, and postoperative MRI, very removed state, and cage position is good, anterior, very located. And this is microscopic decompression picture. And next case is 76-year female patient, pulmonary stenosis L2-3 level, and lumbar stenosis L3-4 level. Some kind of deformity, but L2-3 level, I have to use a TLIP cage because the operative corridor is very small. But I can use the XLI cage, only cage, L3-4 level, because we can get enough corridor for XLI cage. So I think this is surgical tips. I always recommend in case of spondylolisthesis case, unilateral sphectotomy, we call it SPO or Ponte approach, okay? Not complete, but I try, okay? And anterior and transverse line of large cage will be necessary, and if possible, anterior distraction and posterior contraction recommend. So we have to make and follow PI-LM mismatch should be less than 9 degrees. Advantage of XTLIP, I think that we can do direct decompression and good for high BMI patient. Because obese patient, there is no problem. I recommend strongly endoscopy decompression. So we can get better coronary and sagittal balance, proper high fusion rate and proper low subsidence rate. And we can avoid vital organ injury. And most important thing, I think, is spine surgeon friendly procedure. Is TLIP surgery is a very spine friendly procedure, so no need to beg up vascular surgeon. Complications may be same as those of TLIP surgery, but technically demanding, not easy technique too. So we have to worry about always nobility injury. We have to be very careful. I think the upper levels above 2-3 level, I don't recommend. If the LK is small, less than 15 millimeter, also I don't recommend. We can do vertical level, but takes too long time. So I usually recommend 2 levels. And if you correct lordosis correction, more than 15 degrees, I don't recommend. We have to do open surgery. Present, since December 2019, more than 10 hospitals in Korea, maybe over 200 cases And so Dr. He and I published the first EXT article, 2021, February, modified paralateral endoscopic transforaminal lumbar diffusion using biportal endoscopic approach. You can use as reference. So EXT is possible remission. So we can put large only cage under endoscopic TLIP procedure. So conclusions, EXT procedure provides large interbody diffusion bed and spacer compared to those of TLIP surgery. Maybe bigger cages would be better, but still further long-term study is required. Thank you for your attention. Thank you very much. Thank you.
Dr. Yumjinwa, thank you. Wonderful presentation as usual. And you have shown the world what XTLIF is. It is your baby. You and Dr. Dr. Hyodong developed this technique, and we are very grateful. It is, after watching your videos, I've learned to flip the cage and I've learned to make my cage more horizontal. Okay. So I'm grateful for the little learning that I have got from you. Thank you very much.
Thank you. Thank you.
I now want to request, where is our dear friend? We are waiting for one of our panelists from yesterday who could not join us. We want to request him to join us. He has not joined us yet. So either we'll wait or else, what time is it now? Dr. Tunch. Dr. Tunch, yesterday his talk had got stuck because we had a problem with so we're waiting for him. His Mac was not responding yesterday. And he's connecting right now. So we'll give him 1 minute's time. Anybody, any panelists or anybody has any question for Dr. Yumjinwa or Dr. Hyodongwa? So right now is the time to ask. Dr. Harshad Parekh has a question, is how do we manage dural tears if they occur? Dural tears, you can directly repair them, you can directly suture them. We use, some of us use arthroscopy portals, shoulder portals. So you can introduce a portal into your wound to give you a direct path to the tear itself, and through that portal, scopic portal, you can directly suture the tear. You can use tachoseal, you can use even clips. In laparoscopy, we have clips. So that can go through a 5 millimeter thick scope. You can, if you have a reserve scope, if you have a reserve PSLD scope with you, it becomes very easy to just introduce it from the instrument portal, even in UB surgery, and put in a clip applicator through that. And you can even directly clip the dural tear. So there are various ways to deal with it. I have also put up a video of how to manage a dural tear. It's on my YouTube video. And if the tear is less, most of the time in endoscopy, we usually have a tear which is about 2 millimeters, 3 millimeters. So if the tear is so small, then we can just ignore it, clear up your surgery fast. Please drop the fluid pressure to the minimum possible, because we don't want fluid entering the epidural space. And try and put in a patch on the meanwhile to try and control the ingress of fluid into the dural tube, and complete your surgery as fast as possible. So that is the one question that was pertinent. I'm waiting for Dr. Tunch to join us, but if he cannot within the next 1 minute, then I will request one of our most eminent panelists, Dr. Fuijo Ito. Dr. Tunch is joining us. Dr. Tunch, welcome. Welcome, sir. Welcome. Can you please start your presentation? Unmute yourself, Dr. Tunch, please. Please unmute yourself. Yes, thank you, Dr. Tunch. Please start. Your presentation is on. It's wonderful. It's really wonderful. Please put on your mic, Dr. Tunch. Unmute yourself, Dr. Tunch.
Ooh.
Hi, you see my screen?
Yes, we see it nice and clear today. Welcome.
Okay, I apologize for technical problem of yesterday. And now, because I don't want to take your time, I will make a very short presentation about how I select my target, my approach for a disc herniation on L5-S1 level. Okay. For L5-S1 level, when we see a disc herniation, we have two solutions. The first one is the transforaminal approach, and the second one is the interlaminar approach. And when I say interlaminar approach, it can be a monoportal or biportal approach. Because many of our friends now we appreciate loudly some stenoscopic and biportal approach. When we see an MRI like this, we start to say, oh, I will do it by UBA or stenoscope. It will be more easy, more quick. Why I will spend my time with transforaminal surgery? Of course, we have to make a preoperative evaluation before the surgery. And what we have to do? First, we have to make some anatomical consideration and to see what's the height of the iliac crest and what are the dimensions of the intervertebral foramen. But we have also to evaluate the surgery duration, because every surgeon who make endoscopic surgery constate that transforaminal surgery for L5-S1 level, especially the needle placement, take time, and not only take time, the puncture of the disc is more difficult, and this level resulting in increase of radiation exposure to both patients and surgeons. So we don't have to calculate only the height of iliac crest, but we have to calculate also the surgery duration and the radiation exposure. So the wider interlaminar space on L5-S1 provide more favorable anatomical condition for the minimally invasive interlaminar approach. Similar to conventional open operation approach, especially for neurosurgeons who use microscope. The posterior interlaminar approach, it matches the operation a bit for most spine surgeons with easy identification of microscopic vision of the anatomical orientation. And the anatomical orientation of transforaminal surgery, especially for the beginners, can sometimes be difficult. Is the transforaminal surgery is less invasive? In general, yes. In general, yes. Especially for the preservation of ligamentum flavum, and especially because we don't make any retraction of nerve root, especially for central L5-S1 disc herniation, transforaminal surgery can reach the disc, avoiding the blockage of dura and pass the midline of the spinal canal without stretching the nerve root and without stretching the dural sac. And this may reduce the risk of dural tear and postoperative dysesthesia. For transforaminal surgery, for interlaminar approach, we have less irradiation exposure, everybody know it. But there is some limitations, anatomical limitations of interlaminar. For example, for an extraforaminal far lateral disc herniation, we can prefer it, this approach. And short surgery duration for interlaminar approach can be one advantage. So the difficulty of transforaminal approach is the mobility of the working sleeve, because it's restricted by the size of the foramen. And if we are not able to do a complete surgery, what are the risks? The risk is the residual disc tissue and the poor effectiveness. So what I am doing, like so many other surgeons, I'm trying to prefer in this level, if possible, an outside-in technique with a foraminoplasty, and I'm using some hand drills. With the hand drills, I enlarge the foramen and I enlarge my vision. I think the Tom Sheedy and other hand drill systems are very useful. Sure, you can use some electrical drills. You don't have to use especially some hand drills. You can use some electrical drills, and with electrical drills, you can make the foraminoplasty under visual control, and you can have less radiation exposure, because we have important radiation exposure with hand drill. So when I use especially transforaminal approach, especially for transforaminal approach, I select far lateral disc herniation, large central disc herniation, and for revision surgery, especially if the patient had a posterior surgery before, because we can avoid the scar tissue, we can avoid the fibrous tissue by the transforaminal approach, and we can contact directly the nerve root and the herniation. For me, relative contraindications of transforaminal surgery are large sequestered disc herniation and highly migrated disc herniation, especially in elder patients, because many times I observe in elder patients that the herniation was multi-fragmented, not only one pieces of herniation. And I think I remove all necessary, but in postoperative period, I see the patient continue to have some complaint, and on MRI, I see there is another fragment that I didn't remove. So highly migrated disc herniations, because we don't have some anatomical control, complete anatomical control, they are not very lovely approach for me for this level. So for interlaminar approach, these large sequestrated disc herniations and these highly migrated disc herniations, I prefer. Sure, we can do by this approach all type of surgery, but we can not do this far lateral disc herniations. It's not easy. And this revision surgery, I don't like by interlaminar approach, because scar tissue. So I will finish my presentation to not have your time. So I have abbreviated it. Here I present you for which case I prefer transforaminal approach, and for which case I prefer transforaminal approach. Thank you for your time. Thank you for watching.
Dr. Tunch, thank you very much. As it is important to operate, it is also important to develop the concept of how to operate. And I think your topic has stressed on that. It was a wonderful topic. We are very grateful to you. Thank you, sir. Thank you so much. Can I request you, Dr. Tunch, to stop sharing your screen, please? You to stop screen share. Yeah, thank you, sir. Let me please invite one of our most principal and most important speakers of today's conference, Dr. Fujo Ito from Japan. Sir, good evening to you and welcome. We are honored to have your presence with us, and we are grateful for the time that you have given us. May I please request you to start your screen share and start your topic. The world awaits you, sir.
Okay, I am Ito. Can you hear?
Yes, sir. Please start your screen share.
Okay, I will start my presentation. Is it okay? Can you see?
We can hear you, but you have to start the screen share, sir. We can't see your presentation yet.
Okay, start. Today, I will talk about IG Spine Hospital developed a new
It's not working. Share your screen first.
Just a moment. Can you hear? No?
We can hear you clearly, sir. But you have to press the green button, the start the screen share.
Green start button? Sorry.
There's a green button in the panel. Zoom panel, green button. Start screen share.
Sorry. It's okay.
Yes, sir. Take your time, sir.
All right.
No hurry.
Can you see?
Yes, sir. Yes, sir. We can see your screen, sir. Perfect, sir. Please enlarge it now.
Okay, I will start. Is it okay?
Yes, sir. Please, sir.
All right. Today, I will talk about IG Spine Hospital developed a new PEDIF method for spondylolysis and degenerative spondylolisthesis with or without canal or foraminal stenosis. There are three categories in endoscopic surgery. The first category is fiber or needle operation for mild degeneration. The second category is decompression surgery, such as PD, MED for disc herniation. MEL, PSLD, or UBE are used for stenosis. The third category is fusion surgery, which includes our original PEDIF, MEDIF, and others. Our developed MEDIF and PEDIF approaches are indirect decompression methods. This figure shows other fusion approaches. This is the PEDIF approach. These approaches are for regular TDIF, PSLDIF, and UBEDIF. SAP must be cut off. The spinal canal must be invaded. So dural damages tend to be occurred. These are XRIF, ORIF, and ARIF approach, of which the good points are no canal invasion, posterior muscle preserved. However, these methods have risks of damaging the intestine, ureters, and vessels. MEDIF approach is from more lateral than PEDIF. This approach is similar to the transforaminal method. The opposite side incision is only to insert sextant pedicle screws. It needs decompression of lateral side of SAP and total discectomy. The spinal canal is not invaded. However, not under continuous water irrigation. Endoscopic view is not so clear. The other original approach, PEDIF, is similar to MEDIF. PEDIF needs unilateral decompression and can be in the safety triangle, like percutaneous endoscopic discectomy. It needs no bone resection, no muscle retraction, and no canal decompression. So, no dural damages and no internal organ damages. PEDIF with clear vision and a continuous water irrigation, and the least invasive with 5 incisions of each around 1 centimeter. Fusion surgery has many complications. Since PURE has much muscle detachment, it tends to cause not only postoperative muscle atrophy, but also adhesion to the dura mater and nerve damage. TLIF tends to cause nerve or dural damage. Since XLIF retracts psoas muscle, it tends to cause L4 root palsy and intestine rupture. OLIF tends to cause ureter damage. ALIF tends to cause vascular damage and ejaculation trouble. PLIF complications are rare. PLIF is similar percutaneous endoscopic discectomy and simple method. Overall procedure of PLIF. Step 1, collect the harvest bone from the iliac using the trifine, and artificial bone substitute is also mixed. Step 2, total discectomy through unilateral can be the safety triangle and the percutaneous full endoscopy. Step 3, the end plate should be scraped off by our original outer sheath cutter. Step 4, intervertebral cage insertion. A, the cage packed with bone chips is inserted along the L-shaped retract slider, which protects the exiting route. B, the expandable cage is delivered along L-shaped retract slider. All types of cages are available. Fixation with screws. A, hybrid cancel screws are used for less instability cases. B, PPSI digit fixation for much instability cases, such as spondylolysis or spondylolisthesis. Ike Spine Hospital developed PLIF is performed using a full endoscopic conventional used for discectomy. Firstly, start by harvesting cancerous bone chips from the iliac crest using a torifine via an 8 mm incision. Total transforaminal discectomy is easily performed through safety Cambridge triangle. The unilateral approach is used to sufficiently remove the nucleus and end plate using the outer sheath cutter. One cage is transmitted into the intervertebral space along the special designed L-shaped retract slider. In case of a highly instability, such as spondylosis or spondylolisthesis, it should be fixed using stable pedicle screws. 4 incisions are 1 centimeter, and 1 incision is 5 mm, which are minimally invasive operations for the patient. How to harvest the cancerous bone chips. Firstly, set the image in the inspire 30 degrees to the head side and 30 degrees to the opposite side, and project the teardrop image on the monitor. A gem-sealing needle is inserted to the iliac crest. A needle aspirates bone marrow blood. Collect the cancerous bone chips from the iliac crest using a torifine via an 8 mm incision. Forceps is also useful to collect the bone chips. Push out the bone chips from the torifine onto the petri dish. Mix the cancerous bone with bone substitutes are padded into a cage. Mixed bone chips are padded into an 8 mm flat outer sheath. Mixed allograft bone is padded through the cannula into the disc space. Mixed cancerous bone and bone substitute. This is hydroxyapatite and the collagen hybrid substitute. Superpore is phosphate calcium. Aspirate bone marrow fluid firstly. Bone marrow fluid is mixed with bone substitute. Connect an air suction tube to the bottle of bone substitute to promote bone marrow fluid infiltration and negative pressure. After the mixed allograft local bone is padded from the same bottle, the P cage filled up with hydroxyapatite collagen hybrid is transmitted through the portal. A. Total discectomy and end plate resection through Cambin's safety triangle. B. In the unilateral approach, the endoscope is inserted to the disc space, red circle, at 45 degrees, and then the endoscope can be tilted widely from 30 degrees to 70 degrees to create a wide range of the mother bed yellow circle. However, in L5S1, its range of motion is limited, so bilateral approaches are required. If there is foraminal stenosis, foraminotomy has to be done to prevent the exiting damage during the insertion of a cage, or there is a radiculopathy due to lateral recess stenosis or herniation, ventral facetectomy is necessary. It is important to rationally remove the entire disc and end plate. The outer sheath cutter has been improved based on the duckbill outer sheath. Each tip is wedge-shaped at 45 degrees. Rotating the cross handle is effective for scraping the end plate thinly and aggressively. The scraped end plate and nucleus are then removed with forceps. The endoscope can be tilted widely from 30 degrees to 70 degrees to create a wide mother bed. The compression maneuver is performed from one side with wide foramen or radiculopathy to the other side, and from posterior to another. Let's show the resection area on CT. Insert outer sheath cutter from the posterolateral and perform discectomy and end-plate resection of the ipsilateral. Then tilt the endoscope horizontally to decompress the contralateral and dorsal side. Wide range of discectomy and end-plate resection can be performed by tilting the endoscope appropriately. At L5S1, ROM of the endoscope is limited, so bilateral approach must be performed. It is important for a bone fusion that the end plate should be scraped off to the extent that light bleeding is observed. The outer sheath cutter is an evolution of the conventional 70.5 millimeter duckbill outer sheath. By rotating the thin surface layer of the hard end plate can be scraped off. The tip is sharpened at both ends of a 10 millimeter duckbill. Each has 45 degrees blades. Another expandable blade cutter smoothes the remaining irregularities of the roughened end plate. First, it is inserted with the tip closed and is expanded in the disc space to remove the remaining disc material in the concave end plate. The flexible diamond burr is useful to do drilling of the end plate under endoscopic view. Finally, the expandable blade cutter is inserted with the tip closed, and then the expanded tip can smooth any remaining irregularity on the end plate. The flexible curettage can also remove residual cartilage tissue. As a result, a smooth mother bed can be created with continuous water irrigation and a full endoscope. It's important to remove the entire intervertebral disc and end plate. First, remove the intervertebral disc from the ipsilateral side with forceps and the endoscope. A flexible diamond burr helps to shape the end plate within a narrow outer sheath. Then rotate the outer sheath cutter and scrape the end plate thinly and actively. At L5S1 level, a surgeon or assistant stands on the contralateral side and decompresses. In the same way as the ipsilateral side, remove the intervertebral disc with forceps. By rotating the outer shin scatter, the shin surface layer of the hard end plate can be scraped off. Remove the scraped end plate with forceps. Finally, the expandable blade cutter is inserted with the tip closed and then is expanded in the disc space to remove the remaining disc material in the concave end plate. How to insert the cage. This figure shows the relationship between the cage insertion pathway and the exiting route. First, the intervertebral disc space can be in the triangle is decompressed to make it easier to insert the cage. L-shaped retractor slider is inserted into an 8 mm outer tube. Round corner of the L-shaped retractor slider protects exiting route. The folder with the barrette cage filled with the substitute bone is sandwiched between double L-shaped retract sliders, allowing easy passage through the skin. Immediately after the tip of the barrette cage reaches the disc space, remove the caudal retractor and advance in the cage to 1/3 of the disc space and the fluoroscopy. Since to 0.5 mm L retractor sliders may close diagonal contact with both sides of the cage, it only increases the thickness of the two metal by 1 mm. The metal fitting will gradually increase the intervertebral height while flexing and while protecting the exiting route. The cage passage in the muscle is performed smoothly. The cancer screws are fixed for less instability, such as modic change, DDD, and L5S1 foraminal stenosis. PBS are used for much instability, such as spondylolysis and spondylolisthesis. Even in the case of PPS, the endoscopic portal and lower PPS portal can be shared, so it is limited to 5 small incisions. Less instability cases are fused using a hybrid facet screws method. Indicate case 1 is modic type 1 changes that is confirmed with T2 high intensity of MRI image. Degenerative disc disease shows chronic low back pain with intradiscal massive vacuum that temporary pain relief is achieved with the disc block. Indicated case 3 is when bilateral foraminal stenosis due to decreased disc height is accompanied by low back pain and radiculopathy. 2 transfacet screws are easily loosened, and each translaminar screws tend to interfere. The new original hybrid system eliminates the disadvantage of easy loosening or interfering by combining a transfacet screw and a translaminar screw. Degenerative disc disease occurs continuous chronic disable pain for a few months. In the situation such as no effect of painkillers, rehabilitation and tranquilizer, and temporary effectiveness of intradiscal injection, percutaneous endoscopic transforaminal lumbar interbody fusion, PDIF, with hybrid facet screws is recommended. This 75-year-old male has continuous bilateral anterior side pain and severe low back pain. He had also L1 vertebroplasty due to severe osteoporosis before. PDIF was performed at L3-4 with hybrid screws facet fusion. CD shows right transfacet screw. Left translaminar screw was inserted from right side through the lamina to left. This 76-year-old woman had severe low back pain and moderate bilateral lower leg numbness with 300-meter intermittent claudication. Image showed L4-5 degenerative disc change and mild spinal canal stenosis, but no instability. After percutaneous endoscopic discectomy by the transforaminal approach, PDIF with hybrid facet screw fixation was performed and her symptoms and MRI improved completely after 2 years. Much instability cases are fused using rigid percutaneous pedicular screws method. Indicated case 1 is spondylolysis accompanied with severe lower back pain. Indicated case 2 is spondylolisthesis in more than myodine level 2, or severe lower back pain in even if myodine level 1. Even in the case of PPS, the endoscopic portal and lower PPS portal can be shared, so it is limited to 5 small incisions. How to insert PPS? There are 3 key points of needle advancement. PPS entry pathway must be decided under correct AP and lateral floor image views. The jump city needle entry point is at the outer upper quarter of the pedicule under AP floor view. The needle is set at the posterior line of the pedicule. As can be seen from the CT image, the tip of the needle is at the outside and beginning point of the pedicule. PPS midpoint is important. In AP view, the tip of the needle must be inserted till the medial line of the pedicule. In lateral view, the needle tip must be set at the posterior line of the vertebra and midpoint of pedicule. CT also showed the same position. PPS terminal position. The final target point of PPS is slightly lateral, the center of vertebra in AP view. In the lateral view, the needle tip is anterior 1/3 of the vertebra. In CT, the tip of the needle is slightly lateral, the center of the vertebra, and is 1/3 of the anterior. Procedure to insert PPS. The jam city needle is inserted into the lower pedicule via shared lower portal. The guide wire is inserted into the jam city needle. The same procedures are performed into each other pedicule. Tapping maneuvers are done for each other pedicule. PPS is inserted into the pedicule. The length of the load is calculated. Insert the appropriate length load subcutaneously. Fix the load with the set screw. Check the PPS fixing position and the floor image. This patient was a 51-year-old man with continuous numbness on the posterolateral area of both sides with 200-meter intermittent claudication. Expandable spacer elevate can minimize insertion force, provide controlled dissection, and optimize end-plate to end-plate fit. The PDIF mother bed can accommodate cages of various shape and is unlimited. This patient was 71-year-old male with severe low back pain. The L5-6 disc was hollowed out. Nucleus disappeared and instability was occurring. Resection of disc and end-plate were done. A cage was sandwiched between double L-shaped retractor sliders. The cage was inserted along L-shaped retractor slider. PPS were inserted. Bone plantation was done. PDIF relieved back pain. This case had light sciatica and back pain during work due to L4-5 degenerative spondylolisthesis and instability at L4-5. After PDIF, symptoms had disappeared. A PDIF surgery time was 2.5 hours. Blood loss was 30 milliliter. Post-operative X-ray and MRI sagittal views showed good correction at L4-5, and the PPS system and cage were in a good position. 3 months later, the MRI axial view showed that the spinal canal was moderately expanded due to the extension of the redundant yellow ligament. 1 year later, the spinal canal was further expanded due to shrinkage of the hypertrophied yellow ligament. Light's intraleaf system is also a very good method. After making the mother bed, expandable cage is delivered into an 8.5 millimeter outer tube or L-shaped slider. This patient is a 51-year-old male with spondylolisthesis. Expandable lumbar fusion device LIDE was inserted into the intervertebral space at the contracted height. When it is expanded in the disc space, the implant can lift the upper and lower end plates to the appropriate height. Postoperative images show good correction. This female patient suffered from bilateral sciatica and 100-meter intermittent claudication. L4-5 showed lateral instability and disc space was narrow with disc herniation, light L5 root damage, and left extraforaminal disc herniation, left L4 root damage. Firstly, discectomy and endplate resection were performed from right wide disc space, and then left extraforaminal discectomy and endplate resection were done from left side. After PLIF, intermittent claudication and bilateral sciatica almost completely disappeared. This patient was a 71-year-old male. He had moderate back pain, 20 millimeter intermittent claudication, and severe right sciatica. CT showed right foraminal stenosis at L5S1 and spondylolisthesis. MRI showed also right L5 exiting root compressed. PLIF was performed. Right foraminotomy and insertion of the cage increased vertical distance of the foramen. This patient was a 46-year-old manual laborer with spondylolisthesis of L5 and spondylolisthesis at L5S1. At the L5S1 level, the iliac limits endoscope tilt. Therefore, it is not possible to completely create a mother bed only through one portal. Bilateral cambio approaches can create a complete and wide mother bed. This case is spondylolisthesis and listhesis at L5S1. Two cages are driven in from both sides, and heavy worker needs stronger fixation. The narrow L5S1 disc cavity has been raised and fixed. Conclusion, characteristics of PLIF. Create a mother bed under the endoscope from cambium triangle with an outer cis cutter. Discs and end plates can be removed from one side. However, bilateral approaches must be done at L5S1. The iliac cancellous bone can be sufficiently corrected with an 8 millimeter incision. Continuous water irrigation makes clear vision. Less instability cases such as DDD or modic change can be used with the transforaminal screw and the facet screw. Much instability cases such as spondylolisthesis, listhesis need PPS fusion. L-retractor slider can protect the exiting root. Various type of cage can be inserted along double retractor sliders. No muscle retract, no bone resection, no canal decompression, indirect method. Herniation and lateral recess stenosis can be decompressed directly. No dural tear, no internal organ damage, no large vessel rupture. The fourth isthmus, Asia-Japan, combined with the 14th Smith Summit Forum, will be held online from March 25th to April 24th, 2022 next year. Welcome to Japan from beautiful Maiko-san. Thank you.
Thank you. That was a wonderful presentation, sir. We were really shocked and amazed. You have designed new instruments, and your technique is totally different from what I do. And I really appreciate what you're doing. I find it amazing, sir. Thank you very much. This was a very, very informative talk on transcameral lumbar interbody fusion. I think I should start calling it as Dr. Ito's technique now. That would be my respect for you.
For me.
Thank you, sir. Thank you so much.
Thank you so much.
Our next panelist from Japan, Dr. Koichi Sario, I think has joined us. So Dr. Koichi, if you want to share your screen, Dr. Ito, can you please?
Okay.
And I will request Dr. Hayati to speak after Dr. Ito. So Dr. Hayati, bear with me. Thank you. Dr. Koichi, can you please start your presentation?
Okay. Dr. Professor Ito, please remove your slides. Unshare.
Yeah.
Thank you.
Thank you, sir.
Your mentor, please.
Thank you. You have to stop your.
Yeah, please stop. 伊藤先生、共有外すってやつをどっかで押してくれないと僕は入れないんですよ。共有外す。
Thank you. Thank you.
Okay. Thank you so much.
Welcome, sir. Welcome, sir.
Yeah. Okay. Is it okay?
Yes, sir. We can see your screen. Please proceed, sir. Welcome, sir.
Okay, thank you for your invitation. My name is Koichi Saida from Tokushima, Japan. It is my great honor for me to be here to speak my endoscopic technique. Today's my talk is transforaminal full endoscopic spine surgery. I'd like to say that technique should be beyond the gold standard. First of all, I'm from Japan, and I'm a society chairman of Japanese Society of the Minimally Invasive Spine Surgery, and also I have I'm a board member in a lot of international or Asian minimally invasive or endoscopic society. Today's talk is transforaminal or transcambing approach. As you can see here, the red triangle, this is the Cambing triangle. Through the Cambing triangle, we can access to the spinal canal and intradiscal space. The purpose of my talk is to introduce the cutting-edge technology of the transcambing or transforaminal full endoscopic surgery. I would like to say transcambing full endoscopic surgery can change the current gold standard. There are four basic techniques in transcambing surgery. Number one, discectomy, endoscopic discectomy. The second, endoscopic foraminotomy. The third, endoscopic ventral facetectomy. Finally, Professor Ito also mentioned that the transcambing lumbar interbody fusion. I think those four techniques should be basic one. So if you want to be an endoscopic surgeon, please have this technique. But first of all, discectomy. This is the most important basic technique. Transforaminal surgery is possible, of course, decompression under the local anesthesia. Again, this is a basic technique for transcambing or transforaminal surgery. What's the key point? It's a foraminoplasty. If you want to be a skillful full endoscopic surgeon for transcambing or transforaminal approach, first of all, please be a skillful surgeon for foraminoplasty. Look at this three-dimensional CT scan. The bump of the superior articular process make narrow of the foramen. So 8 mm cannula cannot go into the neural space. So first of all, foraminoplasty, then you can see here, the right CT scan, the foramen got bigger. Now you can do any type of surgery safer without any damage of existing nerve root injury. So foraminoplasty, number one, first. For discectomy, now I'm doing a foraminoplastic outside in technique. First of all, we should put the cannula just beside the superior articular process. We can say SAP. Then with looking at this bone, we can take it out disc material from outside. So I'm a student of Tony Young, Arizona. He said, always, bone is my friend Koichi. So I said, again, bone is my friend. Always at the beginning of the surgery, please look for a bone. Where's my bone? Where's my bone? If you see the SAP bone, that's wonderful. This is a way for the successful surgery. Okay, this gentleman is 32 years medical doctor. Actually, he's a general surgeon and having a disc herniation here, the big one. But the facet joint is big, so first of all, I made foraminoplasty here. Then take it out the big herniated mass. Just 5 days after the surgery, he could return to the original job as a surgeon. That surgery is possible to be to do a quick return to the original life. If you have a good skill of the foraminoplasty, even at the L5S1, it is possible to take it out using a transforaminal approach. Usually, interlaminar is recommended for L5S1 disc herniation, but if you're a good surgeon for foraminoplasty, that kind of mass is possible to remove. Look at this. After shaving the SAP, you can just access directly to the base of the herniated nucleus pulposus. Pre-op and post-op, you can see that totally removed. 2 months later, she is actually a professional golfer and she returned to golfing. I'd like to say, even at L5S, TF discectomy is possible under the local anesthesia if you have a skillful foraminoplasty technique. So take home number one, foraminal endoscopic lumbar discectomy. If you have a good skill of foraminotomy, any type of herniation, even at L5S, can be the indication for the transforaminal approach under the local anesthesia. I think this is one of the biggest merit under the local anesthesia. The second is foraminotomy for foraminal stenosis. Okay, this is there are 5 steps for foraminotomy. Number one, placement of a cannula on the facet bone right here. Again, I'd like to emphasize that bone is my friend. Bone is your friend. Always look for bone surface right here. This is a SAP. If you see the bone, this is successful. Then SAP is removed partially, and after that, we can see the thick hiatal ligament just over the existing nerve. Then remove it using Kellison longule for endoscope. Then you can see here the decompressed existing nerve root here. If need, you can remove the herniated nucleus pulposus laterally. This is possible. Now we finish the endoscopic foraminotomy for foraminal stenosis. This is a gentleman. His job is professional baseball player. Actually, he's a southpaw, left-handed. Then his chief complaint is right buttock pain for 5 years. The pain is increasing year by year. What's the point? What's the pathology? He's having a right buttock pain. I'd like to tell you one thing. I'm a sports doctor. If the pitcher, right-handed, left side facet got hypertrophy, the left-handed, right hand. So contralateral facet comes hypertrophy. I knew that. I proved that. So he's a southpaw. So right side facet got bigger. So look at this. Little bit of foraminal stenosis as comparing to the left side. Right side foraminal stenosis is here. Then I did a video nerve root block and I confirmed it. Then you can see here, big SCP is pushing L5 is it nerve root here. So after the foraminotomy, I shaved the tip of the SCP of S1. All is gone. Not all, half of the facet contact is gone. Now exiting nerve is decompressed. If you see the axial slice, nothing. You know, I may remove all SCP. No, please look at this. More than half of the facet contact is preserved. He started pitching for the next season, and so far he is really good for 4 years. Then go number 2, transforaminal endoscopic lumbar foraminotomy under the local anesthesia. This is good. However, one thing, clinical outcome is not good when degenerative scoliosis is combined. So if there is a scoliosis there, I'm always doing a K-leaf. Okay, I'd like to introduce two great my mentor, Professor Tony Yang, Phoenix, Arizona, and Professor Akira Dezawa, Tokyo, Japan. They are my great mentors. The third one is ventral facetectomy. What is a ventral facetectomy? This is new. I came up with the idea in 2017. You can see here for 5, the very narrow foramen and also lateral recess stenosis, and drilled, completely drilled out into a spinal canal. This is a ventral facetectomy. The concept is the ventral half of the facet is drilled out under the local anesthesia for lateral recess stenosis. I started in 2017. Okay, introducing one gentleman, 60 years old. He is a dental doctor. He has a own office. And his chief complaints are both leg pains, intermittent claudications. So you can see here, central disc herniation, also lateral recess stenosis bilaterally, making L5 nerve root impingement bilaterally. So I did a bilateral full endoscopic ventral facetectomy under the local anesthesia. Leg pain completely disappears after the surgery. See here, central disc is also removed. Actually, he's a dental doctor and he started his job just 5 days after the surgery. Take home message number 3, ventral facetectomy. I think ventral facetectomy is very good, minimally invasive decompression for lateral recess stenosis. And also, I'd like to emphasize that it can be done under the local anesthesia, since most of the patients of the lateral recess stenosis is elderly, like 70s or 80s. In Japan, sometimes 90s. So I need to do a surgery for such a elderly, with poor general conditions. So general anesthesia is perfect merit. So no more general anesthesia for such elderly cases. However, one problem, spondylolisthesis is combined, clinical outcome isn't good. So for such situations, lateral recess stenosis by spondylolisthesis, I prefer to do an interlaminar decompression or K-leaf. The final one is transcambing lumbar interbody fusion, K-leaf. Professor Ito also mentioned about the transcambing fusion. In these 5 years, a lot of papers in the literature and a lot of names, PE leaf, PET leaf, FE leaf, FET leaf, endo leaf, endo T leaf, so many names. So I said, make like a nomenclature. I said K-leaf because everybody is doing full endoscopic guidance, cage insertion through the Cambridge triangle. So I named it K-leaf in 2019. And I'm writing many papers using this word of K-leaf. So if you agree, please use KRIF, full endoscopic KRIF. This is a transcambing interbody fusion. There are two great professors in the world for Cambin's triangle. Of course, Professor Cambin, he passed away, unfortunately, 2020. And at the same time, Professor Hijikata also started transcambing technique from Japan. What's the difference between K-leaf and T-leaf? Looks similar, however, there are biggest difference. Look at this T-leaf. T-leaf is a cage insertion through this triangle after total facetectomy. This is a paper from Professor Harms in Germany. And this is K-leaf. K-leaf corridor is through the Cambin's triangle, no need for facetectomy, little bit the shaving of the SAP. So Cambin's K-leaf corridor, T-leaf corridor, totally different. Do not confuse it. So I prefer to say K-leaf, not endoscopic T-leaf. Okay, I invented friend K-leaf from Tokushima, Japan with a surgical spine company in Tokyo, Japan. Look at this. The yellow arrow, just 12 millimeter, we can go insert the big cubic cage. I'm doing first PPA, pedicle screw insertion. Cage is second. First, I'm doing PPS first. Because most of my cases, spondylolisthesis, you see here, exiting nerve root is not anatomically, so I'm reducing it first. So that the Cambin's triangle get bigger and exiting nerve is normalized position. Okay, the most important thing is a foraminoplasty. It's making the Cambin triangle bigger and bigger for a safer insertion of the cage. You can see after a foraminoplasty, you can see here disc surface. Exiting nerve is right here. So I'm always counting 1 drill head, 2 drill head, 3 drill head, 4 drill heads. 4 drill head means 12 millimeter. This is enough for a safer insertion. And also, I invented a safe guide. Look at this tip, ball-shaped tip can prevent the accidental insertion into the abdomen. This is so safe K-wire, safe S-wire. Through this S-wire, we can insert the spacer 8 times 10 millimeter. Then also, if after I inserted the spacer, the height is at the beginning 8 millimeter, then it rotates. This guide is got further up to a 10 millimeter. Then I inserted open square cannula right here. And I'm doing neuro monitoring, EMG free run monitoring. I'm always listening to the warning sound. No warning sound, it's okay to insert this open cannula. But if there is a sound, I'm doing a foraminoplasty once again to make the Cambin triangle bigger and bigger. And through this open cannula, you can do this curate using your device. This is just a standard curate device. And you can see here the freedom of the movement of the curate is very wide because this is open cannula. The next step is bone grafting. I'm working in basically university hospital. My university has a bone bank, so we can use allogenic graft. But if you don't have a allogenic graft, you can take out the autologous bone from a pelvis. Pelvis is very close here. You can take it at autologous cancerous bone using a Trefan. Okay, using this open cannula, sliding into the mechanism. Here, this is exiting over here. No more damage, no sound. Also, this 8 times 10 is a big space. So you can use a big cage sliding into the disc space. Finally, after I inserted the expandable cage in appropriate position, I'm doing expansion. With rotating this handle, the cage is got bigger and bigger and bigger. I can show you the one case, 84 years old female. She's having a low back pain and leg pain. You can see here, the disc is totally collapsed, showing type 1 modic change. Modic type 1 causing her low back pain. And also the foraminal stenosis, you can see here, SAP is pushing existing nerve root here. It causes leg pain. So lower pain and leg pain, we need the fusion. She has a history of laminectomy 5 years ago, right here. So I place the cannula right here, but in this situation, disc is totally collapsed. Then I inserted a pencil type dilator in here. The height is 8 millimeter. So now disc space is 8 millimeter. Then I put 8 by 10 open spacer first, then rotate it. Now the disc space is going up to 10 millimeter. Then inserted the open square cannula. The next step is sliding in the expandable cage right here and expand it. So this is AP view. You can see here this length is 30 millimeter and width is 10 millimeter. So I'm using one big cage. Although Professor Ito shows us 2 cages, I'm using a big one. I like it, big one cage. I started 2018 this technique. Totally, I performed 33. For the beginning 13 cases, I was using Dr. Nagahama's Petrif system. After May 2020, I invented my original device. So after that, I'm using my device. So I performed it, 20 cases. And clinical outcome is excellent to good because this is a fusion surgery. And I encountered 2 existing nerve root irritation. No muscle weakness, just a sensory irritation, dysphagia. It's normal. Normally, it is healed within a couple of months. One from a Petri system and one from a Carey system. So, existing nerve root injury is 6.1% as a complication rate. Okay, let's discuss a future gold standard for the spine surgery with 4 cases. I'd like to say this is the beyond. You can see here, beautiful view of the endoscope, and you can see here the nerve root. Case number 1, 50 years old female, chief complaint is left leg pain. She had a history of 4-5 fusion and 5S lab discectomy long time ago. You can see here, this time, left leg pain is from a foraminal stenosis. The S1 SCP is pushing L5 existing nerve root. What's the plan? Yeah, I think everybody agrees because we are endoscopic surgeon. But a traditional orthopedic surgeon says, yes, yeah, fusion, facetectomy fusion. I think this is a gold standard in the world among the traditional orthopedic spine surgery or neuro spine surgery. Gold standard is additional fusion. However, we are full endoscopic surgeon. We can do that endoscopic under the local anesthesia, and after foraminotomy, pain disappears after the surgery. She is a nurse, and 3 weeks later, she returned to a nurse job. We can avoid fusion surgery. So we are beyond the gold standard in the world. So case number 2, 65 years old male, chief complaint is right leg pain. He has history twice of the surgery. One is microendoscopic discectomy from here. After that, for the lateral stenosis, he underwent MEL, microendoscopic laminectomy over here. However, a couple of 5 or 6 years later, leg pain started again. You can see here 4-5 foraminal stenosis pushing L4 impingement nerve root, and also it pushes L5 nerve root impingement. So the pain is from both two nerve root involvement. Here, this is a selective nerve root graphy or block. Here and here. After L4 and L5 nerve root block, pain is totally disappeared. So pathology is L4, L5 impingement for foraminal or lateral stenosis. He has a history of decompression here 2 times. So L4, L5 posterior fusion was planned in the former hospital. I think this is the gold standard. So, however, this patient says, I don't like a fusion. I don't like such kind of big surgery. So please look for somebody, for endoscopic doctor. And he comes to me. So what's the plan? Yeah, gold standard is fusion. Yeah, I did full endoscopic foraminotomy and also lateral recess decompression for ventral facetectomy. Just a second. Okay. Transforaminal full endoscopic surgeons, we can avoid the fusion surgery. I think fusion is a gold standard. So again, full endoscopic surgeon can be beyond the gold standard. Okay, next case is number 3, 90 years old, left leg pain. I think here we have in Japan a lot of elderly cases, elderly patients with such pain. So he has a complication of vascular and pulmonary complications. General anesthesiologist says no more general anesthesia, but he said a lot of pain, much pain, strong pain. No drug was not effective. Such a plan. I think gold standard is pain controlled by a pain physician because no more general anesthesia. So this time I performed full endoscopic ventral facetectomy for this kind of 90 years old gentleman. You can see here the narrow foramen got bigger, drilled out through the spinal canal. This is, I say, ventral facetectomy. This is a final view of ventral facetectomy. This is a traversing nerve root, and this is a disc surface. Blue color is disc surface, and this bone is not a cancerous bone. So this is a pedicle. The white one is joint surface of inferior articular process. For such cases, the ventral facetectomy under the local anesthesia is a good indication. Okay, final case, 57 years old female, grade 1 spondylolisthesis. However, in a flexed position, almost grade 2 spondy. Symptom is intermittent claudication 100 meter. At rest, no symptoms. Her job is rhythmic dance coach. She's always teaching the students with sitting position because standing is very painful. Okay, what's the plan? Decompression only? Decompression with fusion like a TD or PRIF? Or ORIF exercise with PPS? I think gold standard is decompression and fusion using a TD or the PRIF. What's the plan? This time I performed the fusion without decompression. During surgery, I performed a myography using a dye. You can see here, just after PPS insertion. This is a strong compression of the neural canal. Here, after 8-meter cannula, slightly dye is coming right here. Then I inserted the 10-millimeter spacer. It comes up, and finally I reduce the slippage right here. So the dye is completely comes down to the caudal space. If there is no symptom to rest, fusion without decompression due to Friend-Kelly would be the best choice. So you see here, Kelly has a greater power for reduction. Before surgery, before reduction, the dyes comes stopping here. But after Friend-Kelly, the dyes completely goes down. In the case here, the slipped vertebra is totally reduced. Okay, this is MRI before and after the surgery. This is 2 weeks after surgery. The slipped one goes normalized and stenosis is opened up. After surgery, no symptom anymore from her. So I started this one. So totally, I did 4 cases for such indirect decompression, but it's very good. Friend-Kelly is a bit minimally invasive, less damage of muscles, minimally blood loss, and also quick. It's very quick because no decompression surgery. So surgical time is very quick. And one more biggest merit, no more worry about the dural tear or hematoma. I'm feeling this is the biggest additional merit for without decompression. Thank you so much for listening to my talk. And this year, I'm having a World Congress of Minimally Invasive Spine Surgery and Techniques in Tokyo, Japan. And this is a worldwide COVID-19 pandemic. So I decided to open this meeting hybrid. So today, many doctors from many countries are listening to me. So please submit your abstracts and please talk together. And the key station is Tokyo, Japan. This is online and in-person hybrid congress. From Tokushima, Japan is so small country, but beautiful nature and ocean. A lot of foreign fellows coming, so this is email address. Please contact me. Thank you so much.
Thank you, Dr. Koichi. Thank you so much. Your talk on full endoscopic resection of the facet was amazing. You have achieved something that is beyond most of us.
Thank you so much.
Your patient selections are so wonderful that they are almost auto-fused. So therefore, just opening up the foramen is doing the job. Resecting the facet, resecting the lateral recess, everything done through transforaminal is amazing, sir. Amazing. Thank you so much, sir. Thank you for a wonderful talk, sir. I will now request my dear friend and brother from Turkey, Dr. Hayati, to please start the presentation. Salam, sir.
Thank you very much. Do you hear me, dear brother?
Please share your screen, sir.
Do you hear me?
Yes, we hear you.
Okay. Thank you. How are you?
Fine, dear Hayati.
As usual, you're doing very nice organization.
Thank you, sir.
Nice to see you again. Nice to hear you again.
Thank you. Thank you so much. Welcome, sir. Start your screen share.
Okay. How can I share my... Maybe they should let me to share my screen.
Please.
There's no... okay.
Yes, your screen share has started. Please start your talk, sir.
Thank you very much. First of all, I want to thank the organizing committee and their Dr. Pestonji to give me the chance to speak with this valuable Congress. I'm appreciated for this. My topic will be consecutive decompression of the lumbar spinal stenosis. I'll try to fit my time. This is my presentation plan. So I want to look at to the literature about the stenosis surgery results. In multi-level stenosis, MIS surgery has very successful results in at most of published research in the literature. And also, again, the multi-level stenosis with the open decompression and instrumented fusion has very high success rate. Even microsurgery, single-level microsurgery in multi-level stenosis has also very high success rate. And also, again, in the single-level endoscopic surgery in multi-level stenosis has very high success rate. Also, some of most of physiotherapy-related papers saying that there is no difference between the surgical therapy with the physical therapy, and also some of them say that there is no difference between all the surgeries, open, fusion, MIS, microsurgery, and all the endoscopic surgery has no difference between this technique. If we look at the multi-level spine stenosis researches in the literature, we have seen very few studies actually targeted to the multi-level, not just the lumbar spinal stenosis. And so we can say that the literature has some confused about the multi-level spinal stenosis. Actually, if we look at the etiological and the epidemiological research in the literature, they say that mainly, especially in the central stenosis, has dominantly influences the genetic factors. So, in the genetic factors promote the multi-level, became the multi-level. Also, the one segment started to the cascade, and the pathology goes to the multi-level from the single level. And also the other thing is multimorbid degeneration can be seen with the lumbar spinal stenosis, because lumbar spinal stenosis is not alone disorder. There is many of other problem can be seen with the lumbar stenosis. Also, we have seen after surgery, we have seen some constant symptoms after surgery. And the one possible explanation for the continuing the symptom after surgery in these patients may be the presence of comorbid musculoskeletal conditions, as comorbid conditions limiting walking ability, including knee and hip arthrodesis, and also all this can predict worse surgical outcomes. In another study, we've seen that many of osteoarthritis can be seen the lumbar spinal stenosis together. But we are using the same questionnaire, same scoring systems to assess the patient. So we need to answer these questions to get reliable results from the literature maybe. So we don't know how can be sure about the responsible level, which level is the responsible for the symptoms in the lumbar area, or how can be sure about the causes of residual and new symptoms after surgery. So also how can we distinguish the causes of symptoms before the surgery and after the surgery, because this case can have hip pain, knee pain, leg pain, and etc. So also we are using same tools for assessment before and after surgery in patients. And also we are asking the same questions, almost always. For example, they asking for the knee, for the hip, for the lumbar, almost some, of course, some difference between the two. For example, some specific questions can exist in these questionnaires, but say mostly, mainly, all the assessment questionnaires or scoring systems almost similar each other. So the surgeon, as a surgeon, spinal surgeon, we should know about the nature of the spinal stenosis. So according to the literature, we have some type of spinal stenosis classified as congenital, acquired, and combined. And we know that the stenosis starting with the radiological, firstly, the radiological started from the radiological changes of the disc, intervertebral disc. The intervertebral disc has crucial role to the intervertebral or lumbar stenosis. Disc pathology can create the facet joint arthritis. Then we've seen ligament, yellow ligament thickenings because of occult instability. And then we've seen the vertebral body osteophyte stain. All those cause the metameric circumferential instability. Then we have seen squared central and lateral stenosis. And the pathophysiologically, the pathomechanism of the central and the lateral spine stenosis is predominantly related to degenerative change of the intervertebral disc. And also because of this, spinal stenosis can be seen in central canal or lateral portion of the spinal column, and central and lateral recess or foraminal stenosis can be seen in a single location or multi-location. Same pathologies can be seen in multi-location, or same or different pathologies can be seen in same location. In the central stenosis, there is two main reasons. Stenosis may be created by ligamentous or soft tissue degeneration, that's named as ligamentous stenosis, or the stenosis may be created by osseous widening of the facet joints, and they named as non-ligamentous stenosis. In lateral portion, pathoanatomically, there is two main causes: the disc, calcified and bulged disc, and the hypertrophied flavum can cause the foraminal stenosis constantly, and the SAP can cause the dynamic. And also we have a combined pathology that can cause the combined stenosis, foraminal and central stenosis. The instability can cause the three-dimensional stenosis. Spinal cord is compressed by posterior structures of the canal, and the nerve roots are compressed by facet joint parts and the facet joint components and the disc and the flavum. So the surgery, we know that the surgery is our weapons. We should use this to the correct targets. To choose the correct targets, we should know the relationship between the symptoms and the pathology and the pathoanatomy and the pathophysiology. So most of the symptom, the critical symptom is the intermittent neurogenic claudication, and the back pain, leg pain, weakness, numbness. All this is the common symptoms, not specific symptoms. So, what is the consecutive decompression? Consecutive decompression means the compression should follow the nerve root. So, compression of the central portion, compression of the lateral recess, and the lower foramina for traversing nerve roots, and the upper foramina for exiting nerve roots, and the decompression for lower lamina of the adjacent upper segments for exiting nerve roots and the current level, and the compression of the far lateral portion of the foramen. And we have some zones. We should consider these zones during the surgery. For example, zone 1 consists of the central portion, and 2 is the subarticular area or recess, and the 3 is the foraminal, and 4 is the extraforaminal or far lateral. Here is this is our current level, but we should add, sometimes we should add the upper level inferior portion and the lower level superior portion to make fully decompression. In multi-level adjacent segment, consecutive decompression can provide the fully decompression of the lateral recess, lower and upper foraminals, and the far lateral portion, because we know that most of symptoms coming from the lateral portion of the spinal canal. So now, current surgery can cover the central and both lateral zones, but sometimes we need the upper level to add the surgery to get fully decompression of the segment. And also, sometimes we should consider to add the extraforaminal zone and the foraminal zone, like this degenerated cases. In this case, we are planning to decompress the not just one level. This is the current level, maybe, and also we should add the upper level inferior foramens. Now we have a study about this. This study designed for the single diagnosis made for just single level decompression in multi-level degeneration. Means that the single level considered as the main responsible level, severe stenosis. But the other adjacent level is moderate, maybe we cannot be sure about the symptoms, because we know that the dermatomes, myotomes can be not exactly distinct each other. So we see that the consecutive decompression has better results than the single level decompression. Now I will show you a simple study. The case was 87 years old, diabetes. He has diabetes and have hypertension also, he operated cardiac operated previously, and also he had very severe scores about this stenosis. And you see here the MRI pictures, very severe stenosis. If you look at the upper level, maybe we can consider as a free nerve root, but let's see what's happening. Now, the right side is the current level surgery seen, and the left side is the additional level surgery. Now, in the multidegenerated cases generally has a spontaneous fission. So this is an advantage for surgeon because it gives an advantage for surgeon because we can make wide decompression, but still we should preserve the facet joints bilaterally. Also facet joint capsules and also posterior long-term ligaments should be kept intact. But we can go step by step to lateral, from central to lateral, to make a wide decompression. It can provide to escape, to prevent to the iatrogenic instability. Now we've seen here the upper contralateral foraminal decompression. In this, we can make fully decompression in one segment with the UBE without additional approach. So for this, I'm using the 30-degree endoscope. Now you've seen the exiting nerve root. Yeah, we did a very wide decompression, but still no instability or risk of instability. Yeah, and also we can make intracanal foraminotomy like this. You've seen this is exiting nerve root. This is exiting nerve root. We are doing intracanal internal, maybe we can name as internal foraminoplasty, foraminotomy. Now we removed completely the flavum. Then we've seen the traversing nerve here. Then we will do contralateral side. The left side also the 0-degree endoscope, and the right side is we are using the 30-degree endoscope. Here's the same lateral traversing root and axilla, and also same lateral upper foramen, and here is the nerve root, just here. So it is possible the same lateral or four foraminal decompression using by unilateral biportal approach. Now we're seeing completely decompression. 4 foraminal decompression. Maybe we will do more decompression for the contralateral side. Now you can see the difference between the 0 and the 30 degree. Yes, completely foraminal decompression. Here, this is the nerve root. Same lateral, left side. The 9 o'clock is the cranial side. Both of videos. And the left L5 nerve root. Now, the left side surgery, the left side video showing the L4, L3-4 level. Now, we decompressed completely the L5, L4 left side with the previous surgery. Now, we seen the L4 again. If you notice, there is a prominence on the left L4. Yes, here. This is a calcified disc part, still can cause some symptoms after single level surgery. Then we will remove this part from here. Actually, to assess the correct level previously before the surgery, I always doing a very thin slice MRI scanning of the additional or adjacent segment with the responsible segment. I'm sorry, this video may be short. And now you're seeing here is the responsible segment here, bilateral decompression seen here, and just here is the upper segment. We removed this part with the disc, and this is the postoperative assessment of the patient. So as a completion, the results which related with the stenosis surgery are debatable, still debatable in the literature. Stenosis is not alone as a disorder. Pathophysiology and pathoanatomy of the stenosis should be known by a surgeon. Consecutive decompression may necessary in a multilocated stenosis, and consecutive decompression is targeted to decompression of the nerve root from cord to far lateral foramen. Thank you for your attention.
That was a really great presentation, Hayati. It was really a very academic one and very enlightening one about the different zones of decompression which need to be done so that we get a good clinical result. Thank you very much.
Thank you.
So now I would call upon Dr. David Song. Dr. Song?
Hello.
Hi.
Can you hear me?
Yes, I can hear you very loud and clear.
Yeah, thank you. Nice to meet you.
Hayati, could you stop your screen sharing? Hello. Dr. Hayati, you please stop
Actually,
your
I
screen.
stopped. Yes, I stopped it, but okay.
Yeah, okay, good.
Yes.
Thank you. Thanks a lot.
Thank you.
Yes, Dr. Song, you can start sharing your screen.
Can you see my present file?
Yes, we can see the presentation.
Okay. Good afternoon, dear my colleagues. I am David Song from South Korea. I am a neurosurgeon. The topic I'm gonna present today is the concept of posterior cervical foraminotomy and the overview of biportal endoscopic posterior cervical inclinatory foraminotomy. Before we go any further, I would like to be grateful Dr. Malcolm Prestonji for giving me the opportunity to present at this conference. Let's look at the historical background of the cervical posterior approach. The posterior cervical approach is an antique surgery. It was introduced before the HDF. The posterior cervical approach had great advantage for motional preservation, but it has not been popularized due to some various problems. For example, too much muscle injury and passive violation and limitation of accessibility to central region and the difficulty of surgical technique. So HDF became the standard operation. But these days, importance of minimal invasive spine surgery has emerged, and with the development of tubular retractor system and spinal endoscopic instrument system, the posterior cervical approach is back in the spotlight. In particular, endoscopic PSHAP in unilateral radiculopathy has become a groundbreaking surgery because it makes excellent result, early discharge, early return to the work, and no postoperative pain. Some papers show that the HDF and full endoscopic PSHAP are similar in postoperative pain and outcomes. The cervical UV started at rested. The posterior cervical approach using the UV system was first introduced in South Korea in 2017 by Dr. Jae-hyun Park. Second, next we must know that the concept of endoscopic posterior cervical foraminotomy. Anatomically, cervical nerve root pass through the foraminal canal. The nerve root can be compressed by hypertrophic uncinate process and superior articular process in this area. So for complete decompression, the foraminotomy must be performed in whole foraminal canal. So then, what do you think about the endpoint of the foraminotomy? In my opinion, after the nerve root exit zone 3 area, each pathway is changed to the ventral side near vertebral artery. So before we finish the foraminotomy, we must check the vertebral artery or nerve root turning point. Many beginners try PSHAP, but almost of them can experience something difficulty or limitation. For example, first is insufficient facetectomy because of fear. As a result, it makes insufficient neural decompression and limited clinical symptom. The second is too much excessive facetectomy for root decompression. As a result, it makes instability and risk and accelerating intervertebral disc degeneration. As you know that proper pathotectomy must be lesser than 50 resection of facet joint. However, sometimes there may be cases where more than 50% of pathectomy is inevitable for decompression. In that case, the sufficient decompression must be focused because human has a regenerative system. Anyway, even so, this situation is bound to be a burden on spine surgeons. Another thing is the ipsilateral manipulation is not easy in UB surgery, especially you are a right-handed surgeon or not ambidextrous. Also, to decompression at the distal lobe root, we must remove the facet joint excessively in ipsilateral side. So, PCIF can be one of solution in this difficult situation. 2011, Dr. Zhang published the microscopic posterior cervical inclinatory paramerotomy. The key point of this paper is that if you did inclined paramerotomy, you can preserve the dorsal capsule of the facet joint. So I applied UV system here. So I get some better point. First, it is possible to minimize muscle injury than other endoscopic PCF. Generally, PCF use the transmuscular trajectory, but PCIF use periosteal facial trajectory between neck and lamina. And second, it is possible to access more distal lobe root, and it is easy manipulation of bone up with a valve and bleeding control with RF. Third, it is possible to minimize facet violation compared to PCF because undercutting of facet joint is possible through the inclinatory surgical corridor. This is operative setting. As in PCF surgery, patient position is very important. Slant down the upper back because of reducing venous return, and flat the neck, and fix the head with some plaster. Eyeball and chin is protected by gel pad, facial pad, and surgeon's position is opposite the target region. The portal incision is made in midline, and the two portals interval is about 2 centimeters. Before the surgery, we can simulate the inclined angle and docking point and surgical level with 18 gauge needles. This video shows the step of PCIF. The surgeon stand the left side and the pathologic lesion was located right side. The starting point and laminectomy is more medial side of V point. Generally, I use 3.5 millimeter spherical diamond bore, drill out first cranially, and perform at the lower margin of the upper lamina until detached ligament flavum is visible. Second, then drill out at the caudally upper margin of the lower lamina until the silhouette of dura is visible. And then we make a Then we make a tunnel for going out to the more distal side. We drill out with a cone-shaped 3 millimeter diamond bore. After that, we can see the medial aspect of facet joint and silhouette of root. After tunneling, we remove superior articular process tip with small curette or 1 millimeter keratin punch. Sometimes I use tweezers. This is a bone particle of SAP tip. And then after final bone work, we remove ligament flavum. Ligament flavum can act protector neural tissue and dura during the bone work. So for protection and keeping the clear operative field, we must remove ligament flavum after ligament flavum and finally, final stage. There are many epidural vessels around the root at the neural foramen. Vessel coagulation is done by small RF. This video shows the vessel coagulation with small RF at the ipsilateral side. As you see it is not easy to manipulation RF control. There is some adhesion and vessel between vessel and neural tissue. But the contralateral approach is easy to manipulate the instrument and make it easy to see the distal lobe root. To avoid the damage to the neural tissue, I lift up the ligament flavum or fibrotic band or vessel with RF tip and coagulation. Lift up and coagulation is lift up and then coagulation. This is my technique. When we did the discectomy, so specialized designed instrument will be useful, such as scope retractor. It can protect the neural tissue by RF or other instrument. Anuloplasty and anulotomy was done by a small RF, and this particle was removed by a small hook. Finally, we can check how far about decompression of root with a hook. The end point of surgery was determined until distal part of lobe root is free. Sometimes we can see the vertebral artery or turning point of lobe root. And sometimes, if lobe root swelling is too severe, just foraminotomy was not enough for decompression. In this case, pediculectomy is useful for neural decompression. And to insert an instrument under the root made it easy to provide some space. This video shows the lobe root was protected by scope retractor, and pediculectomy was performed by 2 millimeter spherical diamond ball. So foraminal space is widening post-operative CT. Finally, take-home message is contralateral approaching technique is performed in PCIF surgery. It is contralateral approach is most powerful weapon in UB. The PCIF give stability to the patient by less path violation and provide easy manipulation to surgeon. Thank you for your attention.
Thank you, Dr. Song. That was really an eye-opener and wonderful paper and wonderful presentation regarding inclinatory foraminotomy. Thanks a lot. Now I call upon my dear friend, Dr. Choi from South Korea. Hi.
Hi, Dr. Malcolm Pestonji and Anand Kevi. How are you?
We are fine. Waiting for you.
I hope to see you again soon after COVID-19 is subsided.
Yes, sure. We are waiting for that. Yes, Dr. Choi, you can share your screen.
Yes.
Yes.
Can you see that?
Yes, of course.
Thank you, Chairman. And my name is Dr. Choi in Busan, South Korea. Today, my topic is unilateral biportal endoscopic thoracic discectomy. As you know, symptomatic thoracic disc herniation, TDH is a rare condition, and the thoracic spine surgery account for only 0.5 to 4%. TDH has a particular onset and progression mode with sometimes an impending risk on spinal cord compression. TDH surgery is challenging because of a technical difficulty as well as a serious and hard to treat complication that may occur. Symptomatic TDH affect 0.1 to 3% of all spine disc herniation. Commonly, it affects adults aged between 30 and 50 years old. Low incidence of thoracic disc herniation comparing with the lumbar herniation is mainly due to the decreased mechanical demand and the splitting effect of the thoracic cage. TDH is located below the T7 to T8 disc in 75%. Because of greater mobility and PLL at this level, the T11-12 disc is most exposed to degeneration.
Next, no?
Can you hear?
Yes, yes, we can hear. Dr.
Okay.
Malcolm, please mute your.
Onset of a TDH is usually progressive. Thoracic back pain is chief complaint present. In the setting of progressive spinal cord compression, both sensory and motor dysfunction may occur. The thoracic spinal cord is particularly vulnerable owing to the potential intradural extension generating cord compression and thoracic hypothesis pushing the cord against the disc, denticulator ligament reducing the cord mobility, and the large thoracic cord diameter in relation to the spinal canal diameter, and a poor vascularity in the cord. A whole spine imaging must be obtained to rule out concomitant the cervical and the lumbar spine disc herniation and canal stenosis. Thoracic CT scan is obtained to evaluate the nature of the disc, which can be soft or hard. Hernia location is analyzed in specialized cervical consideration. Calcification or ossification are frequent in TDH. The calcification mechanism remained unknown. The volume of herniated disc can be measured by either CT or MRI scan. Particular entities, the gigantic thoracic disc herniation, defined as compromising more than 40% of the spinal cage as measured on XL CT. Adenocarcinoma is the largest anterior medullary vessel supplying the spinal cord. In fact, Adaquic artery usually arises from the left side between T9 and L1, most common TDH location. Surgical treatment for TDH is indicated if patient fail conservative measures and or if they present with worsening urologic symptom. Prognosis factor for poor surgical outcome in patients with myelopathy include longer preoperative duration of the symptom. The optimal approach provides adequate decompression through the minimize the manipulation of an already compromised thoracic cord. Currently, spinal surgeons use 3 types of approach. Posterolateral approach is indicated in case of soft and lateral and posterolateral hernia or multi-level compromising from OPLF. Depending on the extent of hernia, pedicle can be either preserved or buried. Anterior part of dura can be separated from hernia. Fusion is commonly performed at the end of the procedure. Lateral approach provides dorsal and unilateral lateral access to the spinal cord while allowing for the posterior instrumentation through the same incision. After the decompression, grafting the defect can be realized. Anterior approach provides an unparalleled ventral exposure of the spinal cord, which not only creates a safe working channel adjacent to the spinal cord, but also provides an optimal angle for the removal of a central and calcific hernia. Because of thoracotomy, this approach is thought to be more invasive than the non-anterior approach. Risk of injury as a major vascular structure is also preserved. The use of a conventional TDH surgery is limited by technical difficulty and restricted field of vision. The purpose of this study is the technique for the discectomy and or fusion procedure using UV and analysis of clinical post-operative results. From March 2018 to the July 2020, 12 patients is parallel and with thoracic disc herniation underwent UV thoracic discectomy without fusion case, and the other performed laminotomy, sometimes laminotomy and porotomy and partial pediculectomy and partial vertebrectomy via using UV posterolateral approach. The indication of fusion are revision case or wide pediculectomy case. UV can be performed under the general or epidural anesthesia with the patient in front position for the equipment, the 0-degree endoscope, RF device, irrigation system, and the surgical tool specific to the UV system should be prepared in the cell. Caudal entry is for the instrument, and if the serial dilation, working space is made. And the cranial entry is for the endoscope. Scope is inserted, and lamina is exposed. We always emphasize the continuous output. Saline input is through the endoscope, output through the working portal. First case, 70 years female case. She has many history of spine surgery. First time 2050 January, L2345 of decompression and fusion in other hospital. And the second operation is T10, 11, 12 decompression and the T11, T12, L1 fusion in other hospital. All procedure is open surgery and preoperative evaluation show T10, 11 inferior migrated right side herniated disc and T10, 11 total laminotomy state. Pre-op CT shows the calcified HIVD. Procedure first time T10, 11 area right inferior migrated calcified HIVD and the previous total laminotomy state. First time, I stand the left side and using two portal and the decortication of facet and the remnant lamina area, and after that and the bone graft. This CT shows the decortication and the bone graft area. You see, this procedure is a decorticated on the remnant lamina and the facet area, and decorticated state here, and the scope is out, harvest the bone on the air medium, and the next step, I change the standardized side and the paraspinal approach. Initial target point T10, 11 pass area. First time T10, 11 parametromy right side and right side fascial pediculectomy and vertebrectomy and start discectomy, and we change the 30-degree scope and continue discectomy. This video shows the after pediculectomy, partial pediculectomy and vertebrectomy, and 12 o'clock area is thoracic cord, and just push down, and cover the freer and proving, and discectomy is started. Continue, and we change the 30-degree scope to make a better view in ventral side. Also use the freer and probe. We use the probe and continue the discectomy. Check and again, proving again. Finally, perculated pedicle screw and rod are inserted. Post-op X-ray, post-op MRI shows the full decompression. You can see, and the post-op CT sagittal curve, and this is the right side pedicle area sagittal cut shows the partial pediculectomy and the partial vertebrectomy area, and the full decompression. In the right side, post-op MRI is a posterior fusion. Case 2 is also pre-op CT and MRI shows the right side, the T10, 11 right side, thoracic HIVD and non-calcified HIVD. This post-op X-ray and the post-op MRI and CT can show the partial pediculectomy and the partial vertebrectomy site. Case 3, T11, 12, OLF with compression fracture and superior migration case. Intraoperative photo and the T11 pediculectomy site and the discectomy is removed. You can see the T11 root. Result, 11 patient is excellent improvement, and one patient who was unable to work post-operative was able to ambulate with the use of the cane, but residual spasticity is still present, and the mean operative time is 81 minutes, and the mean BAS and the mean ODI is decreased, and the conversion to open surgery is not required. UBK from the surgical point of view is similar to the conventional spinal surgery, permit good visualization of TDH, and the minimal invasive procedure is UB is alternative treatment option for the TDH. Thank you.
So sweet of you, so sweet, and what a wonderful topic. Troy, amazing the way you did pediculectomy, the way you have removed the thoracic disc, amazing. We're really impressed with this topic and really impressed with this presentation. Thank you very much. and hope to see you soon. We are waiting.
Thank you, Dr. Vikstoji.
Bye-bye. Thank you. I think Anand, can we now invite our next speaker, please?
Yes. Now, I think Dr. Dae-Jung Choi is here already. So I would request him to start his presentation.
Dr. Choi, you will have to cut your screen share. Thank you.
Hi, everybody. Thank you. Thank you very much, Professor Malcolm. I think it's very honor to me to present my topic in this big meetings. Let's start my topics. I press the button, share the screen, and okay, I will start. Hi, I'm DJ in Busan, Korea. Thanks, Chairman, for having me present in this big meeting, and Hookland Spine for supporting biportal endoscopic spine surgery. Today, my topic is common mistakes of new recruit who are performing biportal endoscopic spine surgery, shortly BAS or UBE. BAS uses floating technique and keep the scope a certain distance apart from the target structures. We can move a scope freely and see the panoramic view just as open surgery. But through the floating interval, bleeding comes to our eyes first, so bleeding control and making surgical field clear are the key tricks in BAS. If you try to do something in bloody surgical field, you can injure the root or dura. We call it red screen. Under the red screen, you can make a root injury. So the first important knowledge you should keep in mind is vascular geometry in endoscopic view. Most vessels on the backside are coming from the segmental artery. It runs around the foramen and then makes several branches to the posterior side. So you can meet 3 main branches in posterior side and 3 branches in transforaminal approach. And there's another one called radical artery inside the foramen. At posterior approach, 9 o'clock left side, 7 at the bottom, and 5 o'clock right side are the main foci where bleeding comes out. If you know the main bleeding foci, you can guess where the bleeding comes out and control them easily, even in bloody, blurred surgical field. This is a map of vascular geometry around the foramen. You must be in trouble due to heavy bleeding when approaching around the foramen. In early learning curve period with no information of the vascular geometry. The first bleeding when you insert a scope on the transverse process TP is coming from the inferior artery at 9 o'clock direction on the left side. That means if there is a big bleeding, but you cannot find the focus exactly, coagulate any region 9 o'clock left side first. The second, when you try to find a facet or SAP tip, this is one of the branches lying on the edge of the facet under the muscle. It is called the branch of superior artery at 12 o'clock direction. It looks like a heavy rain. After capsulotomy, the interarticular branch runs under the capsule fiber, just beside the top of the SAP tip. So please prepare coagulation always when you scratch out the facet capsule. You can easily memorize the 4 main branches from the segmental artery. Just remember the magic spell 4 dragons on your fist. When you expect an exact direction where the bloody fire dragons attack, you can catch them with ease. Radical artery runs into the foramen inside and makes several branches. At first, you cannot notice its direction, but when you have special eyes on it, you can come to understand its shape and control epidural bleeding easily. That is a map of epidural vessel geometry. You should keep in mind it becomes a map of the treasure island of Bass. Sometimes before we are not familiar with endoscopic anatomy and you have few reference anatomy in endoscopic view, you can easily lose your way and fall in panic in disorientation and spending about 1 or 2 hours in the interlaminar space outside, even without starting main procedure. We should know reference anatomy in endoscopic view. When you rotate the scope, the view also must be rotated, and then you can easily lose your direction. You should know what is the right reference view, and you should try to keep it same view in every trial. Standard base camp view in BAS. We can see 4 main structures as a reference anatomy: proximal spinous process and distal spinous process, and interspinous process ligament between them, and rotatory muscle bundle attaching to the dorsal surface of the lamina. Interspinous process ligament is an eminent structure which looks like a tornado. You can control the scope and make the tornado standing straight up rather than lying obliquely. Magic spell not to lose your way and direction is making tornado standing straight up. Incomplete decompression is so common in early learning curve period. One of the reasons is that we don't know how to access the pathology deeper and proximally locating. Interlaminar space is also very narrow in severe spinal stenosis, and there's not enough working space through which we can access the deeper main pathology. Literally, it is very difficult and tough to access the contralateral proximal area through narrow interlaminar space. So distal portion can be easily accessed and decompressed well, but proximal portions of the contralateral and ipsilateral sides are not easily accessed, and this can result in incomplete decompression. The 15 millimeter interlaminar space is needed for 8 millimeter diameter scope and 5 millimeter instrument. When you try to go inside of the spinal canal, especially into the contralateral side, to make a 50 millimeter interlaminar space, proximal and distal spinous process space should be resected about 5 millimeter each. If you have no idea of SP-based resection, you must be always in trouble and struggle in a narrow working space. And you never reach the contralateral side deeper, even contralateral side foramen. SP-based resection is a key trick to give you enough working space for sufficient decompression under the sublaminar area. If you did not resect the SP base first and try to make a working space wider, then you finally resected the lamina too much. and you must do subtotal laminectomy in condition of lack of endoscopic anatomy information. Female 63, L45 severe spinal stenosis, posterior approach on the right side. Due to narrow working space, the surgeon did do total laminectomy on the right side and made iatrogenic instability with continuous mechanical back pain. Unless post of 2 months following up, fusion should be needed. The very best benefit of BAS is minimal laminectomy under maximal magnification and do sufficient decompression without fusion. This is another different case. Another subtotal laminectomy in one side was done and made a vacant facet joint, which lost totally one side articular process with the iatrogenic instability. We call it ugly BAS. To prevent this kind of wide laminectomy in a narrow working space, lower portal position is recommended for severe spinal stenosis. In lower portal position, we can access a spinal canal with less resection of SP base and lamina. One of very unwanted complication to surgeons who are performing BAS first is dural tear. Because underwater and its narrow space, basically you cannot suture. It can be also prevented when you follow the basic rules. The unique anatomy underwater in BAS is a central dural folding at the midline. Due to saline water pressure, the size of the dura is compressed, so there becomes a dural folding at the midline, which is hidden under the epidural fat. In addition to central dural folding, the central fibrous band is located at the midline, which is connected with the dural membrane and undersurface of the ligament flavum. Don't try to remove it and clean up the midline fibers. When you pull out the central fibrous band forcefully, the central area of the dura can be injured. The first trick to prevent dural tear is to preserve deep layer of ligament flavum until finishing bony procedures. Boring without protection of deep layer of ligament flavum is the most common mistake of recruits in learning curve. There's a central dural folding under the epidural fat, so when you put an instrument deeper into the contralateral side under the fat layer, you can injure the central dural folding directly. Always be careful of the central dural folding in the midline. So, I will tell you where is a safe back door. You should remember that there are 3 layers in the epidural space: ligament flavum, fat, and dura. The safe way crossing the midline is that you should go between the ligament flavum and fat layers. Never try to go under the fat layers. Under the fat layer, there's a huge lion, so when you try to go under the epidural fat layer, the lion will catch you and swallow you in a big mouth. Always you definitely make a dural tear several times, so you should know also how to treat it without conversion to open suture. One of the tricks you should know is how to insert a sticky taco seal on the dural surface. Cut the taco seal into the 2 pieces and folding it and envelope it with a gel foam. Folding it with the grasp with smooth gel foam and put it. This is called dural folding package. And this method is called patch compression method for incidental dural tear. Transforaminal approach is a very fancy and amazing technique of BAS, which is very best superior to the other open spinal surgery. But when you try to one or two first trials, you must make some unexpected complications. One of them is hyperperitoneum. Hyperperitoneum is a unique complication in transforaminal approach in using BAS. In case of L5S foraminal decompression, after finishing surgery in a recovery room, patient belly looked swollen. CT showed hydrothorax and hyperperitoneum. Disorientation during foraminal approach and going deeper too much is the reason. In this case, one side of the body was eliminated with a huge psoas hematoma. It looks very lucky. Corpectomy is just stopped before the big abdominal vessel. This is a standard view of transforaminal approach in left side. There are important reference anatomy structures: TP, transverse process, empty bundle, musculotendinous bundle, which can help you not to lose your orientation. SAP is not seen yet at first. SAP is hidden under the facet capsule and deep muscles. So you should remember two main guided structures, TP and empty bundle. Of course, there is a magic spell. Touch down the TP and look up the sky at 2 o'clock direction and run over the empty bundle. Then you can see the SAP tip. Never go under the empty bundle. When you go under the empty bundle, 100% you must make hyperperitoneum. Always keep in mind, touch down the TP, look up the sky at 2 o'clock direction, run over the empty bundle. You can easily remember the endoscopic anatomy around the foramen. Kung Fu Feast. Once you see that, you can easily remember the anatomic structures on the endoscopic view. Left thumb is the empty musculotendinous bundle. Right fist is the SAP tip. If you want to see SAP tip, which is the entrance door to the foramen, then you should run over the empty bundle. Never try to go under the empty bundle. When you have no complete 3D anatomic information over the foramen, you also could make incomplete decompression frequently. SAP has a very specific structures morphology, so you can easily understand endoscopic views and perform the ugly BAS. SAP has two plans, lateral plan and ventral plan. Lateral plan, which supports facet laterally, mostly it can compress or irritate the exiting root. Ventral plan, which is located at the foramen inside, which is the main pathology compressing an exiting root. So ventral plan of SAP should be resected to decompress foraminal stenosis, but your first few cases of transforaminal approach could show remnant ventral plan. In a revision surgery, the ventral plan is resected and we can find a exiting root compressed under the remnant ventral plan of the SAP. Please remember that SAP has two plans. Lateral plan, which is located at the foramen lateral side, just a supporting structure. After resecting the lateral plan, we can find the ventral plan located at the deeper side of the foramen. The ventral plan is a real pathology compressing an exiting root. Well, till now, I will let you know 7 magic spells which can save you from the very serious situations in early learning curve period. Without understanding these 7 magic spells, you can do ugly BAS in critical situation. I hope good luck and you as save many patients in your soil. Bess will always be with you whenever you call its name Bess, and you can be one of the strongest men controlling spine disorders safely and successfully. DJ is speaking now. Please remember DJ and 7 magic spells. Thank you. Thank you, everybody. Thank you.
And Dr. Choi, that was a wonderful presentation. Very beautifully put across basic steps where people go wrong. And I think you have really put that message across very nicely. We are very proud to have you with us. Thank you very much. And can I now request Dr. Jinwan, who has been waiting patiently from Dubai for us. Dr. Jinwan, can you share your screen?
Okay, wait, please.
Welcome, dear friend. Welcome.
Can you see my screen?
Yeah. Please proceed. Please proceed.
Okay, thank you so much. And I'm Dr. Jinu An, the orthopedic spine surgeon in Nanami Spine and Joint Clinic with South German Hospital in Dubai. I'm so honored to present this topic in this great webinar and a little afraid. After hear from the Dr. Choi, Daejong Choi, yeah, I'm a little scared to hear about many complications of the surgery with endoscopic, the BES and UV, that is the same techniques, but my topic is a little lighter subject, and I want to encourage the beginners without any serious complications. But I want to talk about the possibility and expandability of the UV surgery techniques. So maybe just my experience of the UV surgery. My question is maybe for the beginners. We have many questions, but in the endoscopic surgery, is it possible to treat all kind of the hernia disc, lumbar disc disease with UV techniques? And you guys in here know the answer of these questions, but beginners thought many, complications or some handicap, some difficulty because they don't know about the endoscopic surgery. What is the difference endoscopic and microscopic? So I want to tell about this one. The answer is absolutely yes. This is my experience. The conclusion of this topic is UV can solve all these diseases in lumbar region, including simple and complex, up and down migration, sequestration, foraminal and extraforaminal, even also revision surgery. I don't want to tell about surgical technique now, just to talk about the capacity and possibility of the UV surgery. So how is it possible? In early period of endoscopic spine surgery, there are many limitations to solve this problem. Limited view and instrument, migration and sequestration, extraforaminal disc. Even for expert endoscopic surgeon, that is a problem. And every surgeon cannot be expert because of long learning curve, some difficulties. So simply endoscopic surgery is not easy at that time. I want to tell about UV technique. This is very simple and very similar to microscope. The merit of UV is most familiar to spine surgeon. Anatomy is same as open microsurgery. We can use all instruments without limitations, more clean and more safe, more benefit to patients, minimal incision, less back pain, short admission days. So I think that the UV and micro discectomy is almost the same method, instrument, anatomy, and surgical result. But accuracy and safety is different. This is my personal opinions. Left side picture shows the UV view, right side picture shows the microscopic views. UV view is more clean compared to microscopic views. This means clean view make a surgery more safe and easy. Also, expandability of UV technique is very wide. In most cases of lumbar disc disease can be treated by UV. I will show this in the next slide case review. In additional herniated disc disease, also spinal stenosis are good indication of UV surgery. Okay, I will show 5 cases. First is the central huge disc. Second is on migration. Third is down migration. Fourth is the extraforaminal pseudocyst that is similar to this rupture. And last case is the revision surgery. Okay, first case is the central huge disc herniation. The MRI shows the L3-4 level ruptured disc and compressed the whole dura massively in the axial view. This patient had the L4-5 fusion surgery before. So in these cases, there are some adhesion because of the previous surgery. So the targeting point is very important. All cases in spine surgery for the disc removal, I think targeting is very important. Okay. Approach is the ipsilateral view to L3-4 levels using some fan field, and this is the self-retractor. I like this. I prefer use this instrument. This is very useful without any assistance. So just moving and rounding and breathing control with the astrocalus and slightly move to the dura to medially, we can see the ruptured disc portions. So same way as micro discectomy, but small laminectomy and easy to find the disc rupture. So after removing the huge disc, central disc, only check the dural pulsation. I think that's enough to finish the surgery. So next MRI, next slide is show the after surgery. So the central huge disc is removed and patient symptom is gone. Next case is the up migration. The previous MRI shows the big up migration disc left side, L4-5 levels. Coronal view shows the well-migrated disc portions, the left side is up to the, is kind of kinking in the axilla area. So for this patient, I use 2 techniques combined. The first one is I make some small laminectomy to upper margin of the L4 laminar area with UV technique, and the small remove the ligament problem and make some small hole. And second technique is I change the scope to the PLD scope. And using PLD scope, I found the edge of the ruptured disc and slightly move the punch, and I can remove the whole disc. You can see the big disc coming out in the video clip. So next slide shows the disc, ruptured disc, and the post-op MRI shows the removed disc, and the canal is very wide, enough space. So patient discharged same day without pain. And next case is down migrations. This previous MRI, pre-op MRI shows the L3-4 level down migration disc and left side. So this is same way. I always focused on the targeting. Targeting is very important. Up migration and down migration, just to remove the ruptured portion, laminectomy is needed to find the disc. So I don't remove whole ligament flavum. I don't remove the whole much laminectomy. So only just to remove that portion. So this is remove the upper portion of the L4 laminar and just retract the dura area. And same way to find the ruptured disc, just using the pamphlet and make some space can use the self-retractor. So this is my technique. I don't remove many soft tissue or laminar area. So after surgery, we can see the removed disc and patient's symptom is gone. And next case is a little interesting. See the previous OP MRI. When I saw this image, I usually suspect disc rupture extraforaminal areas. But the T1 and T2 image shows the low signal, both. So something strange, something different. Usually the disc rupture is different, T1 and T2, but this patient shows some same intensity in the T1 and T2 MRI. So I checked the CT scan also, and I suspect this is not disc, that is kind of the cyst or something like that. I did UV surgery with air containing cyst impression. This is the video clip. I did paraspinal approach. You can see beside the L5 root, I found the air containing pseudocyst. You can see the air bubbles. Imagine if you do this surgery with tubular or open surgery, you can, but cannot see this beautiful view, very clean views. And the difference, microscope and endoscope, is after surgery, we can confirm the disc is removed whole. So finishing the surgery is very easy, and we can check the decompressed nerve root like that. So after surgery, we can see the remove the cyst, right side, left side of the extraforaminal area. Last case is the recurrent disc herniation in L4-5 level and down migration. This patient have had a surgery before, the right L5 hemilaminectomy state. This is the same way ipsilateral approach. Usually for the revision cases, targeting is more important, I think. Sometimes we can distinguish what is the root or what is the disc or what is the capsule. Very difficult to distinguish the nerve and soft tissues. So I recommend don't touch the soft tissue too much and find the border of the L5 upper lamina lateral side because of there is severe adhesion. Find the ruptured disc set and remove. The revision surgeries take more time, but if you carefully attention to the anatomical situation, you can find the disc and remove without any injury to the nerve. So this is the post-operation MRI. Here is some tips for UV surgery for the beginners. I think UV is very good tool for the disc disease, but my tip is to carefully review the patient information first and decide the approach. It's up to surgeon's choice, ipsilateral, contralateral, or paraspinal. And accurate targeting is very important. minimal bony resection, and minimal injury to the soft tissue and bleeding control. So I think microscope discectomy and endoscope discectomy is not different, but I think every spine surgeon can do endoscopic surgery for the disc disease. Conclusion is UV is the powerful surgical method for the treatment of herniated disc disease. Can treat all kinds of disc disease, and it is easier and more safe than microscope, and show same anatomy as microscope. So it is familiar to spine surgeon. That means easy to learn. I think endoscopic surgery, including UV or VAS, will be standard treatment for the spine surgery. Thank you for your attention.
Dr. Jinwan, a wonderful lecture and a wonderful hint for up-migrated discs where you used a transforaminal scope, angled it in, and could manage to extract it beautifully. Amazing, amazing application.
Thank you.
And
thank you so much.
Thank you so much. We are grateful to have you here with us this year too. And I believe that we as panelists and also the attendees, we are all learning. We always learn from each other. It's been a wonderful experience listening to your lecture. Thank you so much. Thank you once again.
Very cool. Thank you.
I have with me a very young, promising, and a wonderful UB spine surgeon, Dr. Mankyo Park. It has been my pleasure to know him since 2018, when we first met in India. Dr. Mankyo Park, welcome. Please start sharing your screen. Dr. Jinwan, if you can stop your screen here.
Please.
Dr. Jinwan, you'll have to stop your screen share.
Yeah, okay, please. Wait, please. Something.
No problem, no problem. We have young Mankyo Park waiting.
Thank you. Thank you for inviting me to such a great conference.
Thank you. Is this your screen, Mankyo Park?
I can't allow my presentation. Okay.
Yeah. Welcome.
Can you hear my voice and can you see?
Yes, yes, very clearly, very nicely. Welcome.
Okay, thank you. Thank you, Chairman. My name is Mangyu Park, a member of Endospine Max and working at Bagonu Hospital in Korea. It's an honor to have the opportunity to speak at such a great conference. Let me begin by expressing my gratitude to the gracious host, Professor Malcolm Pestonji, and all distinguished doctors here today. What I'm going to talk about today is lumbar interbody fusion, unilateral biportal endoscopy. I will divide my presentation into advantage of ULIP and surgical technique of ULIP. By the end of my presentation, I hope that you will be familiar with ULIP. Various kinds of endoscopic spine surgeries have been attempted for lumbar interbody fusion. Recently, the UV technique has come to be applied in various degenerative spinal disease, including lumbar interbody fusion. We call this technique ULIP. Although the current level of evidence is relatively low, many articles have shown satisfactory clinical outcomes of ULIP. Comparative studies have shown that the effectiveness of ULIP was competent with conventional PLIP or TLIP. Moreover, many advantages have been documented. Now I'm going to explain the advantages of ULIP. The fundamental goals of fusion surgery are to achieve adequate neurite compression, arthrodesis, and realignment. Next, we have to consider minimal invasiveness, indication and complications, and so on. So let's talk about the advantages with this aspect. First, I will discuss the compression. In the case of microscopic tubular tulip, there are some difficulties in contralateral decompression with small surgical field, especially in the obese or heavy patients. However, UV allows for a good field of vision of the contralateral side with high magnification. Furthermore, if the foraminal stenosis is combined with the central stenosis, ULIP can directly decompression ipsilateral and contralateral exiting nerve root. As a result, ULIP can achieve direct ipsilateral and contralateral decompression similar to conventional fusion surgery. As for radiological outcome, I will talk about fusion rate. Big area for the interface between the graft and the end plate is one of the requirements for successful fusion. In other words, end plate preparation is essential for solid fusion in lumbar interbody fusion. Incomplete end plate preparation or end plate injury can lead to cage subsidence or fusion failure. In conventional lumbar interbody fusion, complete end plate preparation can be difficult because it's not identified directly. However, during ULIP procedure, meticulous end plate preparation is possible with direct visualization. Free elevator could be used. The cartilage end plate could be detached from the bony end plate under endoscopic view without end plate injury. Finally, surgeons can determine when end plate preparation is complete under a magnified endoscopic view. Prior to cage insertion, bone chips can be placed into the disc space with a specialized funnel. It is necessary to stop saline irrigation during the insertion of fusion material in order to prevent bone chip loss. After insertion of the cage, gel foam is applied to the anulotomy site to reduce loss of bone graft and bleeding from the bony end plate. Generally, dimension of end plate preparation is about over 70%. This X-ray CT scan show union after ULIP 1 year post-operatively. 3 comparative studies between ULIP and open polyp or MIS tulip found similar fusion rates. Other concern is sagittal and coronal balance. After lumbar interbody fusion, failure to restore lumbar lordosis cause bad outcomes such as chronic low back pain and ASD. There are several methods to make lordosis in ULIP. Performing contralateral facetectomy is crucial for the reduction of recesses and the restoration of disc height. Generally, we prefer contralateral facetectomy through sublaminar approach like this. However, when the facet joint osteophytes are prominent or great reduction of spondylorecesses is required, 2 new portals are created on the contralateral side to perform total removal of inferior articular process. Next, we try to put the cage transversely and anteriorly. And it helps to make lordosis with lordotic cages or different sizes to cages. We also try to do compression technique and manual back push techniques. Next, I will talk about minimal invasiveness. The retraction or resection of multifidus muscle may lead to muscle atrophy, resulting in post-operative back pain and failed back surgery syndrome. However, UV technique can preserve multifidus muscle. Post-operative MRI shows ULIP has benefits in minimizing muscle damages. When making portals, we must understand potential, this space we call zone space that's between multifidus muscle. After making portals with this potential space, hydrostatic pressure and retraction of multifidus muscle can make enlarge the initial working space. This concept offers benefits, preserve multifidus muscle, and start operation as soon as possible. Furthermore, UV uses a semitubular retractor instead of a working cannula. Therefore, muscle ischemia can be reduced as a tubular retractor is not used. Compared with the tubular surgery, we can make initial working space for surgery with minimal muscle damages in less than 1 minute. In terms of clinical outcomes, favorable clinical outcomes of ULIP have been reported. More importantly, the 3 comparative studies show that immediate postoperative back pain following surgery was significantly lower than open surgery. That means surgery-related muscle injury may be lower in ULIP. These advantages of ULIP can possibly result in quicker recovery and an earlier return to daily life following surgery. Now let's move on to the surgical steps of ULIP. In order to safely and effectively perform ULIP, there are surgical steps that need to be taken into account at each stage of the procedure. After making portals with this potential space, retraction of multifidus muscle and hydrostatic pressure can make enlarge the initial working space. This operation view is where the surgeon is standing on the left side of the patient. Left is cranial, right is caudal. RF probe is used to clean surrounding soft tissue to identify the ipsilateral cranial lamina. After that, ipsilateral laminotomy, removal of inferior articular facet was performed. And then we can identify facet surface of SAP. Contralateral decompression can be performed through sublaminar approach. Here is contralateral facet surface. The contralateral facetectomy through sublaminar approach provides release, which helps in reduction of spondylolisthesis and making lordosis. The superficial layer of ligament problem is attached to the dorsal surface of the caudal lamina. That's why we could detach the ligament problem to superficial layer by sweep over the caudal lamina with callus longe or prior elevator. After that, the caudal lamina and SAP could be identified. The caudal lamina and SAP are partially removed to make space for insertion of the cage. After that, thecal sac, ipsilateral traversing nerve root, pedicle, disc space could be identified. Anulotomy can be performed using hook RF probe. After limbing of the disc space, cartilage end plate was detached from the bony end plate using free elevator under endoscopic guidance without end plate injury. Finally, we can obtain a meticulous and clear end plate preparation like this. Insertion of bone graft is performed using specialized bone graft funnel. Generally, about 70 or 80% of the disc space could be prepared for fusion with ULIP. During cage insertion, thecal sac and nerve root can be protected with a specialized root retractor anchored at lower vertebral body edges. The cage is then placed transversely anteriorly using a cage impactor with the aid of a poroscopic gel foam is applied. And then the remaining ligament problem is removed to finalize decompression. After removal of contralateral ligament problem, we could identify contralateral side disc space and traversing nerve root. If direct neural decompression is required in ipsilateral and contralateral resting nerve root, it can be done after pressing the cage. Here is the ipsilateral resting nerve root. And contralateral resting nerve root could also be performing using contralateral sublaminar approach. The ULIP is completely with percutaneous screw fixation. How about ULIP's indication? The indication of the ULIP are similar as those for conventional fusion. High-grade spondylolisthesis, deformity cases are contraindication. Let me give you some cases. Grade 2 ischemic spondylolisthesis could be performed by ULIP. This is another case of a 3-level fusion by UBE. In limited cases, ULIP can operate in not severe deformity cases. This is a degenerative kyphosis cases. This is a degenerative scoliosis cases by ULIP. Even though ULIP has demonstrated several advantages, limitations are also associated with the technique, including longer operation time, limited indication, and a lack of multi-center randomized controlled trials that directly compare other fusion techniques with ULIP. Well-designed studies with a long-term follow-up and prospective randomized controlled trials should be conducted to further establish the effectiveness and safety of ULIP. Thank you for your attention. After COVID-19, I hope to see you soon. Thank you.
Manju Park, thank you very much for a very crisp and a very nice presentation. I really appreciated your approach to ULIP, including the dissection and removal of the flavum from the superior edge of the lower lamina, and then finding the SAP and going to the disc. That was a really wonderful presentation. Really grateful to have you with us. God bless you. And I think I will now invite our next speaker, Mankipa. Can you please exit your screen share?
Okay, thank you.
Thank you so much. And
Thank you.
Our next speaker, Dr. Cesar Luis Patrona. Are you there with us, sir? Dr. Cesar, welcome.
I'm sorry.
Welcome, sir.
Welcome. Thank you very much. It was an honor to be invited for you, Dr. Peston.
Thank you, sir. Please start your screen share and please start your presentation, sir.
Okay. My presentation is by the translaminar axis using the...
Sir, you'll have to speak a little louder,
Oh, I'm sorry.
Or increase the mic on your computer, sir.
Okay. Okay. I'm sorry. The translaminar axis, using the manual drills developed by Dr. Thomas Hoagland in 2014. This is an axis that I adapted for stenosis. This techniques was initially developed by hernia with high migration, and is a technique that you use to perform through the lamina with the manual drills, and the entry point where is placed this drill. I will explain in next steps of this presentation, and it's very interesting because we can to propose a new techniques for stenosis treatment. It's an alternative for over the top, because some patients that is submitted over the top, the drills of the electric drills is the principal instrument for dural and neurological damages. Then this technique is maybe more safe than the over the top. This is the point that I call the by Hoogland point with the family permission, of course, because Dr. Hoogland developed this technique, and I don't perform with coordinates like this one. Then this is the superior pediculus and inferior pediculus. This is the medial pedicular line, and you divide into three parts between the pediculus, and these parts, these caudal parts, is the point of the entry of these techniques. This point is very interesting because when you put the drills over here and you make a hole through the lamina, you see the central parts of the triangle of Cambing. It's too much safe to make a hole through the canal in this point. Sorry. This is the Hoogland point, and in the lateral view you see that this point is this one, and you make a hole with the manual drills that you present in next step, and the lamina, and you get the canal. And you start with Carrinson to open the lamina, the hemilamina. This is the lateral view, and another presentation. Where is the target? This is the Hoogland point, and this is the target, the imaginary target. When you open the hemilamina, you find the medial parts of the medial parts of the SAP, the superior articular process of the inferior vertebra. This is an important found during the surgery because the complete liberation of the canal, I need to take out these parts of the SAP. And here are a picture showing exactly this. This picture is the same position of this picture. And you are seeing this region, caudal medial, and these parts of the SAP, it's over here. And you need to take out these parts for the complete liberation of the canal. This is the ligament flavum, and this is the site of the medial parts of SAP. And here are the radiological point between the two pediculus, and this is a line between them over the pedicular medial line. You divide in three parts, and this is the target when I show back. It's very interesting because these patients that I underwent of this process, of this procedures, I keep the posterior spine with the spinous process and interspinal ligaments is skipping. I just make a freedom of the recess and medial parts of the canal. I perform bilateral when it's necessary. When I need to make a liberation of the two parts and the patient have multi-radicular compromittments with claudication and bilateral, I perform on the both sides. And I see this is the limit that you introduce the equipment, the instrument, and an imaginary line between this point of the superior plateau of the inferior vertebra. And the limit is the articular between the SAP and IPU. When I'm seeing over here and the lateral view. I'm showing I introduce in the township needle and I try with the wire guide. If it feels soft, I'm the ligament flavum. I take out the township needle and I start with the manual drills like this. I use a sensitive with the wire guides and the radiological coordinates. And here, the manual drill, this is wire guide. This limit is ligament flavum. And when you start the drilling with the number 0.4 centimeters of diameter, and I go step by step, 1 millimeter by 1 millimeter, until 9 millimeters of diameter. And here, maybe this is the number 8. Number 8. 8 millimeters for diameters. It's too much safe because the extremity is atraumatic. This extremity is a traumatic extremity. When I touch the ligament flavum, I have no damage, neurological damage with this procedure. And we use some special drills. This is the drills, the common drills that I use in the Transforaminal 2, but I start with these drills until number 7, and after I use these drills, that is half shaver. These drills, we have only a half of the circumference is shape. And here's sweat. See that? It's very interesting. It's too much safe because this extremity is atraumatic. When you touch the ligament flavum, you have a stop because this geometry will do a stop for the instrument. And here I have the 0.5, 0.4, 0.5, 0.7, and after I start the drills, the conical drills, the half shaver, and here are the later for to start. And now I'll show you the hole through the lamina. It's very interesting because this point where I show you in the initial of the presentation is where I have the principal narrow force of the canal. and I start with too much security. This is the ligament flavum, and you see here the lanes, beauty for the manual drills. This is number 4 and number 5, 0.4 centimeters and 0.5 centimeters. Over here, this lanes is for the 0.6 and 0.7. 0.8 and 0.9 is out, is too much out, is just for adapted the work sleeves. Then it's too much safe to make this perforation to the lamina. And here are the two new view when I just finished the drill of the lamina, and here I can use ceramical caryatids of 0.3, 0.4, and this is too much fast to finish the hemilaminectomy. Fast and safe. I spent around 15 minutes for the manual drills and maybe 1.5 hour to finish the hemilaminectomy. Here are the ligament flavum, and this is the finish of the insertion of the ligament flavum. Cranial, it's over here. This is caudal. Here we will have, after I take up this parts, I will see the medial part of the SIP that I need to take out too. We can see the free down of ligament flavum. It move. And you see the freedom of ligament flavum. And now with these parts, I start I proceed to take out the ligament flavum after this step. Now you can see I'm taking out the ligament flavum for the completely free down of the canal. With the dural exposure. And here I'm showing a problem of is too much common. I have some bleeding during the surgery, and this is too much difficult. I use the Biportal. It's too much frequently this bleeding from the bone. And recently I have used to some substance for completely stop of bleeding. And now I'm showing that this patient, it's an older woman that I perform 3 M-laminas, L3, the both side, and L4, only the right side. This patient had this position. This is VAS that this patient marked for me. And 16 days after, he has only a low back pain with 6 points of VAS. Here are the multiple axes, and I have the 2 M-laminas and both M-laminas of L3, and this is L4. and adjacent levels. We have a completely free down. The patient is 66-year-old and is free for sports, etc. This is a accommodated access. I performed the L3, L4 for translaminar on the right side, and after for transforaminal L45 and 5S1. Of course, this I have the clinical picture of the patient and this patient. It's an older woman that performed with this procedure combined access, and this patient get worse and can walk 2 kilometers per day. And you can see this is the most common when you have the lateral stenosis of the canal. This is L4, L5, and you can see over here, I have too much problems with the controls of these patients because I start during the pandemic, these patients get worse, don't back to the office. You can see this is stenosis, and this is the bilateral access for the completely free down of the canal. And you can see over here, and 3D CT scan, you can preserve the relation between the articular and this patient's get worse is VAS 0. Okay. The final considerations, I have 45 patients underwent to the age group is 59 years old to 95 years old. On average of the 2.0, you have the preoperator around 52.5% of the incapacity on average. And 3 months after I have 22% of the incapacity. Thank you. This is my presentation. It's a single presentation, but this technique is changed the life of most patients of my office. And thanks, Dr. Preston. Thanks to the committee, organizing committee. I'm too much proud to be here. And the second word.
This was a wonderful presentation, sir. You are doing something very unique. We have always been using these kind of drills, the Hoagland drills, for cutting the facet from outside, external foraminotomies. We have never used it for laminotomies. So this has been a wonderful presentation, and it is truly minimally invasive. Your CT scan images and all are really amazing, and I think we've learned something new. So thank you very much for sharing
Yes,
the presentation with us.
I would also like to congratulate Dr. Caesar. This was a wonderful technique, and definitely a most minimally invasive technique to decompress the subisthmus and the lateral recess area. And definitely we would like to learn it and explore it further. So thank you for enlightening us on this new technique.
Thank you very much.
Thank you.
Who's next? I now invite Dr. Sanjay. Dr. Sanjay, please welcome to the conference, and we request you to start your screen share and start your program. Dr. Sanjay, can you hear me, sir? Can you unmute yourself?
Yes. Thank you so much for the invitation, and I would like to thank the organizing as well. as well the podium to present a very interesting case. So this was a 9-year-old lady. You know, I've been trained by Hoogland, one of his last students. And, I want to share this case with you guys because I think it's very interesting. This was a 9-year-old lady. She was at academic hospital from Utrecht, which is another the Netherlands, and she was kept on conservative treatment for 1.5 years. So they Googled on internet and they found me, and they found out that I was doing the endoscopic approach, and they came to me asking whether I could do it. And this was a big problem in the Netherlands because it was not being reimbursed. So they had to pay it themselves. And they started some kind of crowdfunding for the payment of the procedure. And then I asked my colleagues, what would you do? Would you do the open approach or would you do the classical approach? And everyone is telling me, because it's very new in the Netherlands to do endoscopy, everyone was telling me, well, you are crazy, you have to do it open and an academic hospital, in the children's hospital, and so on and so forth. But no one in the academic hospital has experience with the kind of sedation I use, and no one is doing this kind of procedures. So I thought, what should I do? Should I do it open in the children's hospital, or do I do the endoscopy? So this is how she came in, and it's just watch her walking. She has a contracture on the left side.
Sanjay, sorry to interrupt. You need to start your screen sharing.
Oh, sorry. Let me see.
At the bottom of your screen.
Yes, I thought I did share my screen, but it didn't went well, I think. Here, share.
Yes, now we can see.
I'm sorry for that. So it was 9-year-old girl, and this is how she walks. Just watch her left leg. Even op de tenen staan, even op tenen lopen, weer terug. En op de hakken lopen. She can walk on her heels. Okay, helemaal goed. And this is how her MRI looks like. So what to do now? Open surgery, transforaminal. Unfortunately, I cannot ask the audience to get direct response, but after a long discussion with some of my colleagues, I decided to do it transforaminally. And the parents were okay with that because they didn't want the child to get open surgery. And this is how my theater setup is. I do it in prone position using a C-arm, which I can move myself. So we don't need a worker doing that for me. And so this is how her spine looks like. And you can see very large foramen. I'm still out of the canal. I really was afraid doing this procedure in this child. You see, she's very small, and I didn't know if I could make it. But anyhow, we managed to do it. First skin incision, infiltration of the skin, and then introduce the Tom-Shidi. So I'm here at the superior articular process and out of the canal still. Going to Cambridge triangle. Then start the drilling. And you can see I'm in the middle of the canal, exactly where the disc herniation is. And then taking larger drills. I don't have to explain that to you. And you can see I'm at the Cayman triangle in the spinal canal, a little bit in the lateral recess. And this is how the endoscopic view is. So the disc material is very sticky. It's not a big sequester which is coming out. It's really piecemeal surgery. Very difficult to remove it. You can see the nerve roots coming here, epidural fat. Now you see it's moving already. You could imagine that this girl is on the sedation. So she's sometimes crying, sometimes she's quiet, but really scary for me to do it. Because if anything goes wrong, then the whole neurosurgical department will tell me something. So this is the piecemeal material which is coming out. A lot of it has been flushed away by the rinsing. And this is her post-op MRI scan. So you can see the disc is collapsed a little bit. It's black as compared to the other discs. But anyhow, this is the result. And this is how she walks 6 weeks after the operation. Tomorrow. So we've published this in the Pediatric Neurosurgery very recently. And I think it's one of the youngest cases in the world doing well now. And this is data from my randomized controlled trial, which will be published very soon. And then hopefully we get some information about the fact that endoscopy is not something what we are just doing, but we are showing that the data is as good as compared to open surgery. Thank you so much.
Sanjay, that was an excellent presentation. And it was so gratifying to see that child walk completely pain-free and being completely normal. I congratulate you for that wonderful case and wonderful presentation.
Thank you so much.
Dr. Kavi, should we have a discussion on this case?
Go ahead if you have some pressing question. Yeah. Otherwise, we go to the next.
I want to ask one question, Dr. Haranji. How much cellular diameter is used in this patient? Because she's 9-year-old, so the foramen must be very small for her age.
Yeah, but I used the drill. The largest drill was 8 millimeter.
Okay.
Yeah.
And cannula is routine Richard Wolf cannula.
Excuse me?
The cannula is routinely what we use in Wolf cannula.
It's the it's the Maxmore cannula which I'm using.
Okay.
But all these cannulas are a standard, maybe 7.5 or 8 millimeters outer diameter.
Yes, that's true.
8 millimeter,
That's true.
that's perfect. You just went in like a slot,
Yeah.
Fine.
Wonderful presentation.
Wonderful presentation, sir. Thank you so much. It's so kind of you to be with us today. And now I have one more final star of our conference, waiting for him to start his presentation. We welcome Dr. Christian Morgensen. Dr. Christian, can you unmute yourself, please?
Hello, can you hear me?
Yes, welcome, sir. Welcome to our conference.
Thank you for having me.
Please start your presentation.
Sure. Okay, let me see. I have to. Okay. So please let me know. Can you see the presentation?
Yes, we can see it. Please enlarge it. Yeah, it's perfect. Start, sir.
Great, thank you. Well, thank you again for the invitation to talk in this conference. I'm going to talk a little bit about my experience with endoscopic cervical spine surgery. So this is my disclosure, and this is where I work in sunny Barcelona. It's sunny here right now. Just as an introduction, of course, you all know what MIS is. This is not MIS. This is the kind of patients that usually come to my place, even with the cervical spine surgery. It's big scars and operated cervical several times. And patients come thinking that they have had MIS, and this is not really MIS. So this is the kind of skin incision my patients are expecting. And similar to lumbar surgery, where, as you can see here with tubular surgery and microscope, etc. Well, cervical surgery with endoscopy has been having an evolution in the last decades. And of course, endoscopic surgery for the cervical spine, I got this table here from Dr. Kim, but basically it's very nice that you can see the different generations of endoscopes that have been allowing to expand the indications of the different surgeries. Right now, we're the third generation of endoscopes, which is the one that I'm going to show here, which is the one that I use for the cervical spine. Of course, you know all the advantages of endoscopic spine surgery, otherwise you wouldn't be in this conference. Especially that you do tissue dilation, we don't need to cut. This is as well true for the cervical spine, for the lumbar spine. There are many studies showing the non-inferiority of endoscopic spine surgery. And in the end, I will show you, some papers where I believe it's already showing that endoscopic spine surgery can be better than the open surgery. And of course, the problem is the flat learning curve. We published this paper for lumbar spine surgery many years ago, where we watched, okay, how many cases do we need to get to a 90% good and excellent outcome. Same here, how many cases do you need to get under 60 minutes of surgery? And when we overimposed it, we got between 60 and 80 cases, so about 70 cases. This is for lumbar spine again. But so for cervical spine surgery, my recommendation and the recommendation that I was giving when I wanted to start was first master the curve for the lumbar spine, and then go ahead and go into cervical spine, okay? So we all know ICDF surgery. This is a standard training for any neurosurgeon or trauma surgeon, for spine surgeon. And of course, there are some approach-related disadvantages, especially if you use retractor blades. And then you know that you can directly or indirectly injury some anatomic structures, leading to hoarseness, postoperative dysphagia, etc. At the same time, if you take out too much when you make a wide dissection and a wide discectomy, then of course you may destabilize the segment. This is why most open surgeons usually do fusion after doing the discectomy. Yeah? And of course, the more invasive your surgery is, the higher the risk that you have a possible hematoma or edema, which can be life-threatening. And then, so many people after cervical spine surgery go for one night to the ICU for observation. This is a case that one colleague of mine just did recently, last week, so that you can see that, I mean, it's a standard surgery all over the world. You can see the big foraminal herniation here on the right side. It was a young patient. So this colleague of mine, he did a classical open approach and then put in a cage, a standalone cage, as you can see here. And well, yeah, this was the scar after the surgery, 6 centimeters, which is yeah, an important scar. Okay, and I got this one from another colleague in LinkedIn. So, but you can see this is standard actually all over the place. And the problem is that if you have a young patient and you fuse them, you are already in getting into this yeah, line of adjacent segment degeneration. You're stiffening up the spine, etc., etc. So, in my opinion, it is interesting to have an alternative to go directly for fusion. Okay, especially when you also have the risks, like in this case, I also found in LinkedIn posted by this doctor, and you can see 41-year-old lady, 3-level ACDF, and look at this, you know. And then this doctor was asking, now what? What do you do with her? What do you do with this pseudoarthrosis, instability? You have to do a 2-level corpectomy to actually get all of this out. This is a catastrophe for a young patient. It is a catastrophe. So there are risks involved, even for such a standard surgery as ICDF. So I'm not saying it's bad. I'm just saying that it's interesting to see if there's an alternative to this. So should fusion be our first option, or maybe we can find some middle way? Well, yeah, you know all the complications that are related to fusion. We were commenting right now: cage dislocation, subsidence, pseudarthrosis, segmental kyphosis, etc., etc. And same thing with TDR. So there's a lot of discussion, of course, between fusion and TDR, and you can have well, yeah, there's also a lot of limitations, and many people, you know, who advocate for it, many people who disagree. And myself, when I see such a spine like this with a hybrid solution and several surgeries, I'm always trying to think maybe we could have given this patient some other alternative before, maybe. Okay, so the advantages I see for the endoscopic approach in the cervical spine is, of course, it's minimally invasive. We don't cut the tissue. We have progressive tissue dilation, just as I was showing before for the lumbar spine. You can do it with local anesthesia if you want. It's an outpatient surgery. You can send your patient home after 24 hours. You do have motion preservation because you do not need to fuse the spine. And as the approach is so less invasive than with open surgery, you do not touch the anatomic structures, so there's no need for instrumentation and fusion. And so no increased complications also for multiple level surgeries. And at the same time, I'm always saying we're burning no bridges. So even if we would fall short with the endoscopic spine surgery, there's always time to do the fusion. So endoscopic cervical spine surgery does not stop you from doing a fusion later. So I believe it's a very interesting approach. And this is a very, very important publications that I found after I talked to Professor Bartels, actually from the Netherlands. His group has done several studies with a randomized controlled trial. It's a randomized controlled trial for open surgery here, okay, where they compared the long-term outcome, sagittal alignment and clinical outcome after 15 years for patients treated with ACDF, for patients treated with TDR, and patients treated only with discectomy, open discectomy. And they found that there is, irrespective of the technique, there is no significant difference for the alignment of the cervical spine after surgery. And there is no difference in an RCT on any patient that they had after 15 years of follow-up. They had the same clinical outcome for patients who got the cage, patients who got a prosthesis, a TDR, and patients who just got the discectomy. And this is with open surgery. So, and again, another paper. So there is no superiority for a fusion technique just to discectomy. And this is for open surgery technique. So in my opinion, if this is valid for a single level in open surgery, it should be more valid for endoscopic surgery, where the invasiveness is even less than with open surgery. So I think this is a very important point when you have to justify to your patient or even to your colleagues. You can tell them, well, fusion and TDR do not necessarily obtain a better outcome in a long-term follow-up for one single level. So the anterior approach is usually, you usually use it for broad-based herniations, which are paramedian, okay? So like this. I started using a very small endoscope because of the approach. So you can see here the cannula inside the cervical disc. You do not cut open, so you have to be careful just to avoid the important structures. And you can see here how I'm performing. This was basically a nucleotomy with this kind of scope. It's a very, very small scope. So at the same time, the instruments were not valid to go outside the disc. So I saw myself limited using this kind of scope. The incision was very small. Sometimes it didn't even require suture. Okay, and you could do some nucleotomy, but this is not sufficient if you want to go to the canal and if you want to really decompress the canal. So for the treatment of cervical myelopathy and all other kinds of herniations, I'm using this third generation endoscope, as I was commenting in the beginning, which is basically the classical lumbar scope. And in this case, for example, this patient, well, he came to my practice with a neck pain of 7, arm pain of 6, and he had, well, all kind of, myelopathic signs. I'm going to show you the video of this case. So you can see here the herniation, it's compressing, and you can see the stop in the myelography, very small calcification. So I went in with the anterior approach, the discography, you can see it leaking into the canal, and then going anteriorly and using the endoscope I was just talking about just to get into the disc. So you can see here that I'm just taking out the soft tissue, opening up a small discectomy, anulotomy in the to get into the disc. And so you can see here now the nucleus inside. I usually take out a little bit of the anterior osteophyte so that I can place my cannula well with a high-speed drill. And once I've opened up the disc, I start working my way through to the posterior annulus, as you can see here. So you can see the end plates here in the end, okay? And they are always closing up. So I use the Carrison punch to do the nucleotomy and, well, work my way through. And you can see the moving end plates in the end. So I also do some end plate preparation because I like it to bleed a little bit afterwards, of course. And so I'm removing here the posterior osteophyte. You can see that I'm on the posterior wall. And so here we go. Now I'm palpating, just feeling if I'm getting all the material out of the herniation. And now I'm doing the anulotomy at the posterior side, as you can see here. And once I've taken out the annulus, the same way as you would do with microscopic surgery, I'm taking out the PLL. And you will see now the dura shining through the cervical myelin. So here you go. So here it is. This is a cervical myelin, okay? The canal is open. So I just go through and open up just to be sure that I have removed everything and everything is fine. So you can see the myelin pulsating, and I know that I've done enough. It's a 7 to 9 millimeter skin incision, and 3 hours after surgery, here is the patient. And he was already pain-free, moving all extremities. And he was very thankful because he had been having a lot of issues because of this cervical compression. So young guy in his 40s, and you can see it's a very small skin incision. Okay, and so 6 months follow-up, we have neck pain of 3 and an arm pain of 2. So a very happy patient. Same here with this patient. Yeah, also myelopathy. Just let me show you the beginning because the rest is very similar. You can see here the compression by the herniation. It's a cranially migrated herniation. You can see the myelopathic sign. You can see the compression on the dura. I won't show you the video because it's very similar to the one you just saw. So this was preoperatively, and this patient got by himself. He got 3 months later a postoperative video, and this is how it looks like. So let me show you again. Preoperative, postoperative. You can see still no subsidence here of the disc, and you can see if you look closely, you can still see the imprint on the myelin of the herniation that is now gone, but you can tell that it's a liberated space. So you can see here on the axial plane, and this is postoperatively. Very nice liberation. So for some cases, of course, it's not sufficient to do discectomy, and you have to do fusion. So we have been developing here, especially with my father, and I've been giving it a lot of thought, a way to do fusion. This patient here, you can see the rectification. She had a little bit of kyphosis. And you can see here how I did again a discectomy, and then I placed in the cage. It's not an open surgery. We did it with a 2 centimeter skin incision, hospital discharge in 24 hours. Compare it with the open surgery that my colleague did, 6 centimeters to 2 centimeters. So we have developed some instrumentation that allows us to do this endoscopically. Same here, 49 years old female with neurologic symptoms, weakness in the left arm, positive EMG. You can see this cranially migrated herniation, almost spanning 2 discs. Many people would say, well, let's make a corpectomy. I don't think that was necessary because it was a small herniation. And again, here you can see. So I did, anterior approach. And so soft tissue shrinking, anulotomy, taking out the nucleus, as we saw in the first video. Okay, I'm just skipping it a bit forward, just making some space. And then removing the posterior ossifieds, going caudally, in this case, just to try to remove as much as I could. And you can see the pulsating myelin here. Here you go. Pulsating, okay? So I know I'm starting to liberate it. So the nice thing compared to open surgery is that I don't have blood going to my way all the time. I don't need suction. And I have a very, very clear view. Very small instruments, very clear view. So in my opinion, I have, here you go. So pulsating myelin. And of course, because I was going 2 levels, okay, I needed to stabilize. So that's why in this case, I went to the 2nd level and I placed in 2 cages endoscopically. Everything through a 1.7 skin incision. Here you go, 2 cages. And so this was the skin incision you can see on the patient just a few weeks later. Okay, and then of course there's a posterior approach, which has been very popular. I believe it was popularized for open surgery or for microsurgery by Rick Fessler from Chicago many decades ago. And kind of, there was a small hype and then people stopped using it. And I believe that it has kind of lived through a renaissance with endoscopic surgery. So if you have a foraminal herniation, this is the right, like this one. So this is the right approach to do. And I use, again, the same scope I was using for the anterior approach. Limitations are, of course, broad-based herniations. If you already have foraminal stenosis, if you have instability or kyphosis. So let's look at this patient, very, only focused arm pain. And she came to me after the lockdown in Spain, and she had been having a lot of pain during the lockdown. And so I went posteriorly, as you can see here. And then same image as before, so it's the same scope. So it's an 8mm scope. And then I go through the soft tissue, and then you expose the ligamentum flavum, as you can see here, and you have to locate the V point. Yeah. So here you have the facets and the V point, and then you use the high-speed drill to open it up. And then I use the Harrison punches too, to slowly go through. You can see the V point here. And I go through the facet. Just, you try to not to take too much out of the facet. You don't want to destabilize, and you're opening up the canal here. You have a bit of ligament. And so I slowly open up. And then you can see the C7 nerve root. And actually, I had such a nice view that you'll see it in a minute. Something that you don't see that often. So I'm just opening my way through here slowly through the neuroforamen. Okay, and then look at this view. So you can see the two branches of the nerve root very, very clearly, very nicely. You can see the two branches here. So yeah, and then I'm going through the axilla and trying to expose the herniation and palpating through. And so also locating the disc. This is right through the axilla. You can see I'm in the disc. And now, yeah, just pushing a bit of this herniation out and taking it out with some forceps. So this is cranial, this is lateral. This would be the myelon. And you can see it slowly coming out. Okay, here you go. So now I'm just palpating to be sure that everything is free. And the nice thing was that the patient was immediately pain-free after the surgery. So she went home just a few hours after the surgery. Because you can see again, it's only a 8 to 8 millimeter skin incision. This is the patient. This is a 5 cent euro coin. This is the skin incision I did on the patient. 1 year follow-up, and she's at 000. Yeah. Like this case, 42 years old, foraminal stenosis more than a herniation, and a very similar case. I don't want to bore you with another video, but basically it's the same idea, and opening up the foramen and going through the whole process until you open up and see the nerve root. Yeah. And that's basically it. So this is not a picture from me. I got it from another surgeon, but I don't usually do CT scans, CAT scans on my endoscopy patient. But you can see the idea is just to make a hole, don't take out too much of the facets. And there's many publications now showing that endoscopic cervical foraminotomy with years of follow-up will have a lot of good clinical outcome, significantly improved clinical outcomes. And this one is a very recent publication comparing anterior and posterior endoscopic procedures for cervical spine. And they see that they have very similar complication rate. It was about 7.2%. Few more complications anterior than posterior, which is to be expected. Revision rate was 4%. So it's very, very similar to the open surgery. And using this scope, I use this scope for many things. I use it for the lumbar spine, for decompression. I use it for the anterior cervical spine, for decompression and herniations and for fusion. I use it in the posterior spine for foraminotomies and decompression of the canal. And I even use it for the sacroiliac joint. So, I mean, you could buy 17 different scopes for 17 different indications, but in this case, I believe that, and this is my message to you, which is I believe is one of the most important things in the advancement of the technology and the techniques in the recent years is You don't need 2,000 scopes for 2,000 different indications. Are getting so good now that you can use one scope for almost everything. Yeah, I basically use 2 scopes. I use this one for almost everything, and then I have a transforaminal scope for going through the foramen and the lumbar and thoracic spine, and that's it. I don't need more scopes. And this is because the quality of the equipment has just become better and better. And this was just to round up what I was saying in the beginning. So there are now publications coming showing not the non-inferiority of endoscopic spine surgery compared to open surgery, but the superiority already. And I believe this is probably what most of us who have been doing endoscopic spine surgery for many years already feel. And most people that I know that went from open surgery to endoscopic surgery never found the way back. And I think this has a reason. So maybe we will see more publications going to this way. But of course, those of us who are already in this field know that endoscopic surgery works very well. And this was my talk. So thank you for listening and for your attention.
Dr. Christian, thank you very much for a very wonderful talk. You have really covered the entire spectrum of cervical endoscopy, and we are very appreciative of your talk. And now I invite my dear friend, Dr. Ziggy Borinsky, to please start his screen share. And
thank you so much. I hope I can share it right now. Just let me know if it works properly.
Yes, it's working wonderfully.
So can you see my presentation? Yes.
Yeah. Please go ahead.
All right. I just go from the beginning. I think it seems to be all right. Yes.
Yes, it's fine.
You must be very tired after those 2 very busy days. So let me present my talk.
Speak a little louder. Ziggy, a little louder. Speak a little louder.
All right. So is it okay like this? Is it better?
Yes.
I will present this. Let me just close this only. Sorry. You can see clearly, yes? All right. So my talk will be about transforaminal epiduroscopic laser annuloplasty, which is like a combination of annuloplasty and the transforaminal endoscopy. I hope I can go through. So the agenda, I will talk a little bit about discogenic low back pain, annuloplasty, transforaminal epiduroscopy approach. I will compare discectomy and annuloplasty, and I would like to share some cases. So the definition of discogenic back pain is the pain originally from the major intervertebral disc. We do, of course, MRI. We try to find this hyperintense zone, which is the granulation tissue and the source of inflammation and the pain. If you go for the treatment, conservative surgery, and of course the minimally invasive, which you like, including endoscopic technique, is very preferable. So the mechanism of discogenic low back pain, which we utilize to treat this pain, is the irritation of nerve endings in outer third of the annulus. There is a mechanoreceptor, which is also irritated, and there is sensitization of nociceptors in the chronic discogenic pain, ingrowth of the granulation and small annulate nerve fibers, especially in the third part of the annulus, and there is a nerve root irritation in full thickness of the third and increased shear stress across the annual wall. So we currently can recognize 2 types of discogenic low back pain, like annual disruption-induced discogenic low back pain, and the end plate disruption. So end plate also plays a very big role right now in the pathomechanism of discogenic low back pain. This is the typical patient which we have in the clinic. There is the annual disruption. As you can see, there is a migration of the nucleus through the annulus, which is third, and there is a granulation tissue formation and the inflammation inside spinal canal. And there's a conflict between the annulus and dural sac, and this vascular granulation tissue is the source of the inflammation. If we go for the modified Gallas discogram description.
Hello.
Hello, yes.
Hello.
Yes.
Your presentation not moving. Let's stick for the first slide.
Oh, so you cannot see? Because in my computer, I can see it going. So you cannot see my presentation?
Let's
Is it
skip
okay right
for
now?
the first slide.
You'll
It's
have to
only the
start
first
again.
slide.
Yes. It's only the first slide. We are not able to see any of the slides.
Oh, I'm sorry, because I can see in my computer it's going. So let me. And
retry,
you can see
please.
right now the other slides.
Stop share screen and restart the screen share again.
Okay, so
exit and re-enter.
Okay, and so you will tell me how is it now? If I will try. What about now? Is it better?
Yes.
You can see it right now.
Yes, yes.
It's okay.
It's okay now.
So you can see
yes.
the screen. Oh, all right.
Yeah, it's moving.
Oh, it's moving right now. Okay. So we are talking about the Dallas discogram. So the patient with the grade 3 to 5, we operate by annuloplasty. This is the pathomechanism, the annual third, the healing process, ingrowth of the vascular granulation tissue. And this is the typical patient which we have in the clinic. You can see this hyperintense zone and vascular granulation. The nucleus is slipping inside spinal canal through the annual third. And this is our target for the annuloplasty. As I said, the end plate plays very important role in discogenic low back pain. So basically grade 5, 6, we can approach by this annuloplasty. Provocative discography is extremely important, and the grade 3, 4, even the 2, we can actually also consider as patients for this procedure. And we know also that sometimes this discogenic and vertebrogenic back pain is combined. So for those patients which recognize vertebrogenic and discogenic back pain, we can do both procedure same time. You can see here this pathomechanism for the discogenic back pain and sinovertebral nerve ablation, but also having the patient which end plate disruption, we can do same time vasovertebral nerve ablation. So we are going for sinovertebral, vasovertebral nerve, and we are treating discogenic, annulogenic back pain and vertebrogenic if it's needed. Sometimes we differentiate. We would like to find the pain generator and do the less invasive, which is annuloplasty. If the patient is still symptomatic, we can combine with the vasovertebral nerve. So going for the direct annual stimulation, annual probing, we are doing MRI, discography. We are obtaining and we are making some, let's say, consideration for the end plate disruption and the annual disruption. For the annuloplasty, we were trying to find the most minimally invasive. As you can see here, there is a patient with annual tear and the healing after 6 months. The process of resorption of the nucleus takes several weeks to a year even. And this patient, as you can see specifically, was treated by medicine, epidural third injection, physical therapy, traction, and exercises. But finally, after 6 months, he improved. There's another one with the healing, and the time of healing was actually 21 months for this patient. So again, the healing time is, let's say, considering by the amount of interposed nuclear material. But this is not a fast process. Usually will take, as you can see, up to 21 months, including conservative kind of treatment. There's another patient with the healing process around 7 months, including medicine, epidural third injection, physical therapy, traction, exercises. Here you can see patient after microscopic discectomy at the level 4-5, and this healing process took around 3 months after the intervention. If you go for the discectomy and repair of the annular defect, we can see that the recurrent disc herniation currently is recognized for around 2 to 18% of the patient, but the small defects is 1% versus the large defect, which is around 18-27%. So the minimal, the ideal minimally invasive annuloplasty, as you can see here, promote annual healing, and it should be done extradiscal, like extradiscal ablation of this sinovertebral nerve. For the young people, we try not to touch, we try not to do intradiscal procedure. If you go for the history of annuloplasty, you can see here it started in 1994. First, it was intradiscal annuloplasty, then endoscopic, open extradiscal annuloplasty. This is percutaneous intradiscal radiofrequency thermocoagulation. Still in some hospitals, it's performed. IDED completely stopped currently. The side effects were terrible because of the thermical damage of the inner part of the annulus. In some hospitals, still this trot radiofrequency annuloplasty is performed. Intradiscal bipoplasty, we have some good experience with this technique, but to place the probe in the posterior third part of the annulus is not very easy. Endoscopic annuloplasty using this laser yak was not so easy because of the approach for lateral, and open extradiscal annuloplasty is technique with let's say big surgical trauma. You can see here the open surgical extradiscal annuloplasty. It's historical right now. We stopped to do it, of course. And for the open annuloplasty, the annular third, as you can see, we used before to shrink the annulus bipolar coagulation. So the technique which we utilize currently is percutaneous endoscopic extradiscal annuloplasty, which seems to be with the minimum surgical trauma. We utilize, of course, transforaminal approach at the level 5S1. Still, we consider interlaminar, and sometimes having the patient after previous surgery, like for epiduroscopy, we are utilizing the sacral hiatus transsacral approach. If we compare this transsacral epiduroscopy with transforaminal approach, it's really very minimally invasive, only in local anesthesia, but we utilize currently only for the neural decompression and to perform adhesiolysis. It's not like a typical annuloplasty. The most important is the trajectory to epidural space, anterior epidural space. As you can see at the level 5S1, sometimes it's impossible because of the iliac crest. For the degenerated spine, if the neuroforamen is narrow and we have a problem to make foraminoplasty, there is difficult access to intervertebral disc space, especially the anterior epidural space. 3-4 level is relatively easy to access because of the big neuroforamen. So comparing posterolateral and extreme lateral access, we would like to approach this place where we have to denervate a posterior annulus because of the sinovertebral nerves. It seems to be the most anatomically, let's say, considered. This scope which we use for annuloplasty is curved. So as you can see, we have much better access to anterior epidural space using the curved scope, which is attached and which is, let's say, adjust the patient anatomy. So using the rigid scopes, we cannot, let's say, reach this anterior epidural space like we are using this minimally invasive, ultra small diameter of the scope, which is curved. We do it during the procedure. I will show you, and we can obtain, we can go to this anterior epidural space very easily. So comparing transsacral and transforaminal curved, it's a very good orientation. We can see very clear HD image. There is continuous irrigation, and the instrument is rigid, which is easier to navigate inside the epidural space. Here you can see transforaminal epiduroscopy, very different images, starting from seeing the annulus, doing discography, annular probing when the patient is only sedated, and we have the direct response. We can see herniated disc. We can do discectomy like for classical unilateral biportal or monoportal endoscopy. We can see after the compression exiting nerve root. We can do foraminoplasty. We can remove foraminal herniated disc. So all of the procedure which we perform for the classical conventional rigid monoportal biportal endoscopy, we can perform also using this instrument. It's a single-use instrument. As you can see, the diameter is only 3.4 millimeters, and the working cannula is around 1.8. Working length is around 16 centimeters. So compared with the conventional one, it's really ultra minimally invasive access. We started this procedure in Dubai 2016, so we have recently around 5 years of experience. But first time it was used in the US starting for almost 10 years ago. As you can see, the most important for this construction of the scope is this curved tip, which we do during the procedure. There's a special instrument like this one, so we can adjust the anatomy, the scope to the patient's anatomy. So when we introduce, it's a very nice adjust to the anterior epidural space, so we can reach and we can make denervation annuloplasty very easily, starting from 20 even to 40 degrees, as you can see here. By rigid endoscope, we cannot go nicely to anterior epidural space, like using this curved endoscope. There is a pulsed laser, and what is the most important, the penetration of this laser is only 0.4 millimeters, so the surgical trauma is extremely minimum. There's some cadaver tests performed. As you can see, there is no possibility physically to damage any neural elements using this Anuloplasty scope and the laser. The operating room setup is as typical as for the biportal, monoportal endoscopy. This is what you need only. It's a very simple set. The instruments are very typical for endoscopy, so there's no too many instruments. You have only one scope, dilatators, and this elastic working channel. The patient positioning could be on the side, it could be in the front position with Wilson frame, typical like for endoscopy. We're using usually IV conscious sedation. We have the full contact with the patient. Some patients, they need to be operated in general anesthesia. This is why we use intraoperative neuromonitoring. The skin entry point is very similar like for transforaminal rigid endoscopy, where this angulation 20 to 30 degrees we determinate before the surgery, reviewing CT and MRI. And performing transforaminal epiduroscopic laser annuloplasty, we can also do discectomy, and we can do discectomy and annuloplasty. So all of the possible procedure which we are performing using monoportal or biportal system, we can also perform using this ultra minimally invasive scope. It's a typical transforaminal approach, same like for the monoportal endoscopy. But as you can see, the surgical trauma is very, very minimal. The incision is less than 3-4 millimeters. For the conventional, let's say monoportal is around 8 millimeters. It's a typical approach, transforaminal. We shouldn't cross the midline of the pedicle because of the dural sac injury. This is how we place on the top of the superior articular process. This is very, let's say, well-known transforaminal approach. We place the guide wire. This is the toffee needle, and then the key wire. As you can see, it's elastic, so we can go to anterior epidural space very easily. Here you can see the intraoperative X-rays. And the most important, the dilatator is elastic, so it's very atraumatic, and this is how we can very easily, using the curved endoscope, reach this anterior epidural space. Here you can see how minimally invasive is the surgical trauma. So the patients stay gone a few hours after the procedure at the hospital. We do epidurography to be sure that we are still in the epidural space. We are not going inside. We are not doing intradiscal procedure. Then we insert the needle view SH, as you can see on those images, and very easily we can approach anterior epidural space and do the nervation. I will show you some clinical pictures. The most important, because